Good morning. It gives me an immense pleasure to welcome virtually for this hybrid CME to learned team of AATS for the 68th CME of our prestigious association, Indian Association of Cardiovascular and Thoracic Surgeons. I personally feel it would have been wonderful if this was physical rather than virtual and hybrid. We would have had direct interaction with the most experienced speaker of AATS. It is a very intelligently planned CME covering the mitral and aortic valve. It is divided into three sections: surgical approach to mitral valve, surgical approach to aortic valve, and non-thrombogenic valve surgery, covering almost all the controversies and basics as regards the surgical treatment of mitral and aortic valve concern. I extend my sincere gratitude to Dr. David H. Adams, Mark R. Moon, Dr. Tyron David, Dr. Tawasik, Choti Pong, Vinay Wadwar, Ismail E. Hamasi, Leonard G. Gardi, Won A. Stearns, and Joseph Wu, and Onsen M. Lee. Now we have a very good physical presence at the conference site along with the virtual registrations. I'm sure the message of CME will go around the world. I hope that meeting next year will be fully physical with the God's grace. I wish all the best for the speakers and moderators and look forward for the nice presentation and fruitful discussions regarding the topic. Jai Hind, long live IACTS. Thank you.
Thank you, Dr. Srivastava. I request you to kindly take your place on the dais. I now request Dr. Rajkumar Yadav, Organizing Secretary IACTS CON, to present the opening remarks for today.
Good morning, our President, Dr. Iyer Saab, Dr. Hiramat, Dr. Nair, Dr. C.P. Srivastava, ladies and gentlemen. First conference I attended of IACTS was in 1995-96 in New Delhi in Vigyan Bhavan. By seeing the things there, I admired on that day that can I able to organize such conference in future, and for that I was planning since beginning, and I bid for the conference many times in the Lucknow, in the Bangalore. Ultimately, in the Visakhapatnam, we could able to win this bid of holding the conference in Jaipur, and because of that day has come today. And actually, we got conference for 2021, but last conference was vanished because of the corona and what converted into a virtual conference. So it has gone to the central body, and we were given this 2022 conference. So I welcome you all in this conference, and I think another 4 days will be able to show you all the on virtual mode as well as on physical mode a series of guest lectures, a series of plenary sessions, free papers, e-posters, wet lab, working with this training villages prepared downstairs, and nursing sessions for physician assistants, and there's a good participation of trade. You can have a visit to the trade sponsors, their products. They'll be displaying this latest products for the use. And I also welcome the media persons and all the persons or the team working behind us. We are not two, but a team of at least 100 people who are working day and night since last, say, 1 year in making this conference successful. So I thanks and welcome you all again.
Thank you, Dr. Yadav. We now move on to the Cardiovascular Valve Symposium, dealing with non-thrombogenic solutions to valve diseases in association with the American Association for Thoracic Surgery.
Hello, David.
Tawasak, how are you?
Yeah, I got your letter. Thank you so much for your kind concern. Sorry that I cannot be there this year.
Oh, we're going to miss
Sorry.
you.
Oh, yeah.
Pedro and I are both struggling without you, Tawasak.
Yeah. But I can be at your disposal, either virtually or anything that you just assign me. I will do it. Thank you so much.
Okay.
Yeah.
So, Mark, I think we can welcome everyone to this program tonight. This is a special meeting for us, and we really appreciate all of our colleagues in India joining us tonight. We're calling from all over the United States, as well as Canada, as well as Thailand, to be with you tonight. And it should be a really interesting program. We're going to talk to you about some very important concepts in non-thrombogenic valve surgery. And I'm joined by a very elite faculty, including Mark, who's going to co-host this first session with me, as well as Tawasak, Tara and David, who needs no introduction. And then later on, Vinay Badwar, Ishmael Ahlamamsi, and Lynn Girardi are going to catch us up on the aortic space. And then finally, Vaughn Starnes and Joe Wu, Anson Lee will all join us from the West Coast. So it should be a really provocative few hours. And we really appreciate you all getting up early and joining us. And before we start the academic program, I just wanted to say a few words about the AATS Foundation, which is sponsoring this educational activity with the incredible support of Every Heartbeat Matters and Edwards Life Sciences. The foundation is a very active limb of the AATS. We are currently funding almost $2 million of programs annually and impacting, honestly, hundreds of surgeons all over the world right now. And they're sort of, pursuit of educational progress and which will all improve patient care. So it's a very active organization. We're also highly supportive of research endeavors, which is really, really important. And nights like tonight, I can promise you are one of the, real premier events, as well as top priorities of both the AATS and the AATS Foundation. And I really want to thank Mark Moon, because I think Mark really is the person that's helped get this really moving. During his presidency, I think we had a renewed energy on this kind of activity. And I think it's something that we're extremely excited about, and particularly proud to be joined by our colleagues tonight in India. We're sorry that all this COVID nonsense has kept us from coming over there, because that was our intention. But I promise you that we will be there again. And in the meantime, I think these sort of activities are incredibly important to maintain the brotherhood and to continue the pursuit of excellence in non-thrombogenic valve surgery. And as I mentioned, the Edwards Life Science Foundation, which is called Every Heartbeat Matters, and Amanda Fowler, who's the leader of that organization, is instrumental in putting these programs together. We're very lucky to have a partner that believes in these kinds of activities, and they're an incredible partner. And we're just so happy to be here tonight and be with all of you. So with that, I think we can start the program. And the first speaker tonight is Mark Moon, and Mark's going to talk to us about mitral valve analysis lesions and dysfunctions. So Mark, welcome to the stage. Thanks for taking over.
Thanks, David, for the introduction. And the last time I left the United States, I was in Ahmedabad, India, at the IACTS meeting. I haven't left the United States since. And I don't know if my pledge will be to go to India as my very next place that I leave the United States again, but it may very well be. I was just watching our beloved travel host Anthony Bourdain on television just now, the last hour, and he was in Kerala, India. And he was eating black clams that had to be cooked for an hour. He said, clams only have to be cooked for 3 minutes. They said, we have to cook these for an hour. But he said they were outstanding. So it's
Mark, I want to join you, and we'll go together.
exactly.
And is that Dr. Hiramoth on the stage with us? You just unmute yourself.
Yes, Dr. Hiramoth. Good evening,
Hi,
sir.
Dr. Hiramoth. Thank you so much for joining us. You are going to help us get through this session, and we really appreciate you helping
Thank you, sir.
with all of your colleagues to put this together tonight.
Yes.
Excellent. Well, I thought we'd start out just with kind of the basics of the mitral valve, just so we're all talking about the same physiology and anatomy. And that'll kind of set the stage for the next three talks that are going to talk about how to repair these abnormalities. And I think it all starts with obviously with what Dr. Carpentier did in 1983. It was at the AATS annual meeting, and he was an honored guest speaker. I think Tom Ferguson was the president that year, and he gave his address on the French correction, which was a whole new idea of how to fix the mitral valve as opposed to having to replace the mitral valve. And Dr. Carpentier, with Dr. Adams' help, put together sort of a collection of all of these findings, and in this outstanding book that I recommend all of you read. I've read it many times and have it on access for all of our residents. But they talk about the pathophysiologic triad, which includes the etiology of the disease, which is the cause, the lesions, which is what results from the disease, and the dysfunction, which is what results from the lesions. So I'm going to kind of break this down and talk about all the different lesions, and then hopefully the next three speakers will tell us how to fix these in detail. Carpentier's classification is classic, actually. Type 1 is normal leaflet motion. That's annular dilatation only with normal leaflets that just don't coapt. Type 2 is excessive leaflet motion with prolapse or rupture of the leaflets or cords. And type 3 is restricted leaflet motion or cord motion. 3A, as you would see with rheumatic, where both of the leaflets are generally quite stuck and just don't move and coapt. Or type 3B, where it's the posterior leaflet mainly that doesn't coapt and doesn't function well. So we're going to talk about the 5 aspects of the mitral valve apparatus: the annulus, the leaflets, chordae tendineae, papillary muscles, and left ventricular wall. And we'll start with the annulus. Annular lesions can include dilatation of the annulus or calcification. And the dilatation can be symmetrical, as we see in the left lower image, or it can be asymmetrical, as we see more often in the ischemic pathology, which has got rings designed in order to bring in that lower portion more so than the upper portion. And you can see the images of a dilated annulus where the leaflets just don't coapt, and also one of a calcified annulus, which is a much more complex problem to fix. Here's an example of a 64-year-old gentleman with atrial fibrillation, severe mitral regurgitation, and normal leaflets. In this situation, we had quite a significant degree of central regurgitation, and we put on a small downsizing annuloplasty band and did a Mays procedure, and were able to eliminate the mitral regurgitation quite successfully with only putting on a band. It was an isolated annular dilatation problem. When you select a ring, obviously there's different types. The rigid ring, the classic from Carpentier that was originally designed. The flexible band is available, as well as semi-rigid rings and bands that are either full circles or just partial. in their approach to the annulus. Next, looking at the leaflets and chordae tendineae. Leaflet lesions can be cleft in the leaflet, or a tear. We can have vegetations or perforations. We can have thickening or commissure fusion, as we see in rheumatic disease or calcification. Chordae tendineae can be elongated or ruptured or thickened and fused and shortened, which is a whole different problem. The majority of these address degenerative disease, and Tuisak will be talking about the more thickening, fusion, and shortening. First of all, we have to identify that there are non-pathologic clefts. Clefts are not necessarily abnormal, and the posterior leaflet has clefts in order to open the valve widely so that we don't have stenosis during a normal ventricular contraction. They're supported by chordae. They function like commissures, and they do not extend all the way to the annulus. Pathologic clefts, however, can occur in both the anterior or posterior leaflet. We can see an anterior leaflet cleft that's mostly a congenital issue, and we can see a posterior leaflet cleft in the images on the patient below. And we can see on the 3D image, obviously the cleft is between P2 and P3. And on the surgical image, you can see our first approach is to reapproximate the cleft, and then we will take that suture down in order to close the cleft. Next, we have vegetations or perforations of the leaflet, and these can occur in endocarditis or trauma. Here on the left, we can see a vegetation on the leaflet, and in this particular case, with an anterior leaflet vegetation, we were able to excise that vegetation and do a patch repair of the leaflet, sparing the patient from a mitral valve replacement that would have obviously limited life survival in that patient. Next, we can have thickening or commissure fusion, as we'd see in rheumatic disease, not involving the leaflets necessarily, but the commissures. On the left, we have anterior lateral fusion, and on the right, we have double commissural fusion, which can be addressed with a commissuroplasty, commissurotomy. Here's an example of leaflet fibrosis with a restricted posterior leaflet. You can see the image on the left. The posterior leaflet doesn't really participate in the closing apparatus or the closure. This is a patient with end-stage renal disease, congestive heart failure, and you can see there's a significant mitral regurgitation on the rightward image. Here is the intraoperative view showing the posterior leaflet fibrosed and thickened and scarred. And then below, though, the anterior leaflet is beautiful. It functions quite nicely. And as Dr. Adams says and reminds us routinely, if you have an anterior leaflet that is intact and functioning, then you can generally get away with a mitral valve repair doing various techniques that he'll discuss when he's talking about inflammatory disease. You can see the postoperative image after a 28 millimeter band in this patient was able to eliminate all regurgitation with no systolic anterior motion. When you talk about the spectrum of degenerative disease, Dr. Adams published a paper in 2010 describing this progression from fibroelastic deficiency to fibroelastic deficiency plus, to where there's not only a ruptured cord and fibroelastic deficiency, but the leaflets are normal, to where the leaflets themselves become abnormal, talking about increasing volume. Dreyfus has talked about increasing width, increasing height of the leaflet, and then the form thrust is where it's more than one segment of the valve. In this form thrust image here, we have P1, P2, and P3 all billowing. And then the Barlow's type valve by Professor Barlow in South Africa was defined as a patient who had billowing in all aspects of both the posterior leaflet and the anterior leaflet. So let's look at these in order. The fibroelastic deficiency, P2, here's a flail mitral valve in an 87-year-old gentleman. He had a P2 ruptured cord, but his P2 was relatively normal, if not normal itself. So in this particular case, we can do a limited triangular resection of that portion of the leaflet that has the ruptured cord. Some people do a preserving technique with plication of the leaflet, but I generally go with the Carpentier technique of excising that abnormal portion and reconstructing the leaflet. Just putting it back together simply with either a running suture, Prolene, or some interrupted sutures to reconstruct that leaflet. And generally, these patients also have a dilated annulus, so some sort of annular support is important. And it was Alfieri that has demonstrated that inclusion of an annulus supporting technique is important in almost all mitral valve repairs. Here we have a flail P3. It doesn't have to be just P2. And in this 38-year-old gentleman, he had a P3 ruptured cord, and you can see that on the three-dimensional images and the 2D images. And what we did in this patient, again, a limited triangular resection because it was just a small portion of a segment of the leaflet that was otherwise normal. To support that, though, in the P3 region, we also did an A3-P3 Alfieri stitch, which Carpentier used to call the magic stitch, and put on, actually in this patient, a relatively normal size, not downsizing band because his annulus was not excessive, and we did not want to risk any SAM. So a 32 millimeter band in this patient was able to eliminate all regurgitation. Anterior leaflet prolapse is a bit more complicated in many circumstances. When you're starting out in the mitral valve repair world, that you probably start with the P2 and then work out from there. Anterior leaflet prolapse should generally be reserved for surgeons who have done extensive repair because it can be somewhat more complicated to figure out exactly how to repair those leaflets. And it's never a problem to transfer a patient to a more experienced surgeon while you develop your experience. That doesn't mean that all surgeons can't learn to do mitral valve repair, but many centers only see a handful of patients or less of these per year, and probably best for the patients to defer those to a more experienced center. With anterior leaflet flail, this was a 54-year-old gentleman, new onset congestive heart failure, A2 ruptured cords. What we did in this particular patient was A2 neocords, and we put 3 of these neocords in to support the valve and put in a true sized band at 33 millimeters. And again, we're able to eliminate that regurgitation and have no regurgitation postoperatively with support. Here's fibroelastic deficiency plus chordal elongation in an 83-year-old woman with symptomatic mitral regurgitation. She had P2 prolapse without rupture. It was an elongated cord, but she had an extended portion with increased width and increased height of her P2 segment. In this particular patient, again, excessive height, excessive width. In this particular case, we went with the classic quadrangular resection that Carpentier described with some annular plication. In our particular case, we only used one annular plication stitch. This is kind of an older technique, but we did a downside. She was a small woman, put in a 27 millimeter band, and again, postoperatively, no regurgitation. So we eliminated and got that middle scallop back down to its appropriate height. The foreign thrust is a little bit more extensive. Here's a 58-year-old woman with dysbionic exertion. She had a long-standing history of a murmur, and you can see the significant regurgitation. In this particular case, though, on the 3D image, we can see P1 and P2 both have excessive width, and on the intraoperative image, they both have excessive width. In this particular case, we not only took care of P2, but we had to decrease the height of P1. And you can see for this image, the schematic is that P1 was greater than 20 millimeters. The P3 was less than 20 millimeters. So how are we going to make that work? We have to decrease the height of P1. By doing that, we do a sliding plasty of P1, cutting underneath the leaflet and moving it medially, and that decreases the height. And also an annular plication with a rigid band. Here's a form thrust that includes both all P1, P2, and P3. 57-year-old woman. She had a functional double cleft, as you can see in the three-dimensional image with color. She had leakage between P1 and P2 and between P2 and P3. The classic form thrust as described in Dr. Adams' paper. In this particular case, we can't just do quadrangular resection. P1 and P2 will be too tall. We can't just do a P1 sliding plasty. We can't just do a P3. So we had to do a bilateral sliding plasty, P1 and P3, decreasing the height of both of the leaflets and putting on a supporting band in order to adjust the anatomy to a normal height. What we're trying to shoot for is about 15 millimeters height in the posterior leaflet and a 3-to-1 or 2-to-1 ratio between the anterior leaflet and posterior leaflet at closure. Here's a bileaflet Barlow's. This is a 50-year-old woman, again with severe multiple jets in the mitral regurgitation. You can see jets going around behind the posterior leaflet, jets behind the anterior leaflet, and she had billowing of all the leaflets. So intraoperatively, we have an assessment. Generally start with P1. P1 is generally a reference center, but in this particular case, or a reference point, P1 was also dilated. All of the segments seemed to be dilated. So here intraoperatively, we did a triangular P1 resection, P2 sliding plasty, P2, P3 cleft, P3 neocord, A3, P3 alveoli, and a band. So essentially we did multiple techniques in order to fix this patient. It wasn't just one simple technique, but we had to address all the segments and make sure all the segments had a procedure in order to eliminate their abnormality. Next, we have chordal and leaflet fibrosis or calcification. Here's a 72-year-old woman, quite severe regurgitation. You can see her anterior leaflet and posterior leaflet do not move well. She had peripheral vascular disease, COPD, diastolic dysfunction, pulmonary hypertension, and she was quite debilitated woman. So I think we needed actually a result here that was quick, efficient, got rid of her regurgitation in order to hopefully improve her pulmonary artery hypertension. So are we going to try to strip these valves? I know we'll see Tuisak try to do that in a younger patient. This is an older patient with multiple comorbidities. And Carpentier and Adams described the likelihood of repair based on the pliability of the leaflets and also the involvement of the subvalvular apparatus. Pliable leaflets with minimal subvalvular involvement, definitely we can repair those valves. But if there's a rigid leaflet and we've got severe calcification of the subvalvular apparatus, we're not going to have a good likelihood of repair. This patient, you can see, had posterior leaflet and cords that were thickened and scarred. And in this patient, it's best to just go ahead and do a valve replacement and eliminate her mitral regurgitation. So not everybody gets a repair, but almost everyone that has degenerative disease with a normal anterior leaflet can get a repair. Let's look at the papillary muscles. Here's a ruptured posterior medial papillary muscle in a gentleman with acute myocardial infarction. You can see the leaflet is quite prolapsing, severe acute regurgitation, but postoperatively, after reconstructing that papillary muscle and repositioning it into the left ventricle, we were able to eliminate the regurgitation. This can be done acutely as well as chronically. And finally, the left ventricular wall. Aneurysms, dyskinesis of the inferior basal wall, left ventricular ischemia or infarction can all be addressed with a repair. Here's a restricted posterior leaflet motion, a type 3B, 57-year-old gentleman with chronic ischemic mitral regurgitation. We put in a 28 millimeter ischemic mitral regurgitation ring. That's the ring that brings in asymmetrically reconstructs the annulus so that it takes care of the portion that's most dilated, and we were able to completely eliminate the regurgitation. This patient's had an excellent long-term result. And finally, combined lesions. Here's a patient with leaflet and left ventricular wall. She had severe mitral regurgitation, a non-bypassable circumflex. She underwent P2 resection and a band. I thought that would take care of things. But coming off pump, you can see she still has regurgitation. One plus, that's probably 2 plus regurgitation. I wasn't happy with that, and I thought there must be something else going on. We took better images and found that the inferior basal wall was dyskinetic. And that was what Irv Krohn showed in his studies in the New England Journal of Medicine, JTCVS, that in an ischemic, if you have a dysfunctional inferior basal wall, you can have recurrence of regurgitation after mitral valve repair. However, in that study, they also put 2 bigger rings in. And in this patient, what we did, instead of taking the true sized flexible band we put in originally, we put her back on pump and placed a downsized 28 millimeter ischemic ring and eliminated completely her regurgitation. So you can't be satisfied with 1 plus or 2 plus result if you're going for a mitral valve repair and expecting a long-term result. So the principles for success, are to do a complete valve assessment, establish a precise diagnosis. Preoperative echo is great, but then intraoperative echo and assessment, generally comparing the leaflets to P1, which is generally the reference point, but not always. Determine the most appropriate treatment option. Consider transfer if it's a complex lesion before you've embarked on a surgical intervention. Segmental valve analysis, localize and categorize the dysfunction of all the segments of the valve. Do a complete inventory of the specific lesions you plan to repair and address each lesion with a technique. So thank you very much. I hope this introduction has prepared us for the next 3 talks. Thank you very much. Dr. David is now going to address degenerative disease and ways to address that surgically and techniques we can use to fix our problems.
I guess Mark already mentioned most techniques used to repair mitral valve prolapse, which is the pathophysiology of this disease. I have no conflict of interest to disclose. There are 3 separate entities pathologically that causes degenerative mitral valve disease. The most common one is myxomatous. And to be quite honest, was Professor Carpentier who introduced this concept of fibroelastic deficiency. If you speak to a pathologist, they're going to say, what is this? The word deficiency is more to quantify an amount of something. However, when we look at mitral valve, paper thin, transparent, not very elastic anymore, we call that fibroelastic deficiency. The vast majority, however, in my experience, is really myxomatous mitral valve degeneration. And dystrophic calcification of mitral annulus is a major problem. We used to say this is a disease of the old, but I have a large amount of patients on the 50s, 60s with dystrophic calcification, particularly patients with genetic syndromes, like in Marfan syndrome. If you do an aortic valve sparing operation, Marfan's, and replace the mitral valve, it's a self-defeating prophecy. May as well do a bento and put a mechanical valve, because you repair the aortic valve, we repair calcific mitral annulus degeneration as well. This certainly is the best, simplest lesion. And we are very lucky as surgeons because it represents approximately half of all patients that present with symptomatic or asymptomatic mitral regurgitation. It's a P2 prolapse, paper thin leaflets, very simple to repair. Things become more complicated when every segment is prolapsing, but more important, the posterior leaflet is displaced. It's no longer in the endocardium or the left ventricle. The posterior leaflet becomes atrialized, developing what we call the mitral annulus disjunction, first described by Hutchinson in 1987 when he was a Hopkins leukemia Marfan's patient, actually. And of course, this one here too, which, believe or not, I just doing this afternoon. I do at least 1 or 2 a month in relatively young people. Of course, if as an 80-year-old, I'm not going to spend 2 hours taking calcium out and rebuild the mitral annulus. You simply replace the mitral valve if you can secure the mitral valve in a calcium. I think for cardiac surgeons that embark themselves in repairing mitral valve, this slide is likely the most important I'm going to show you today, is the anatomy of the mitral valve, the functionality of the mitral valve. The mitral valve has an anterior and a posterior leaflet
but by far more important, the mitral valve has two halves. Has a lateral half that is entirely anchored by the anterior papillary muscle, and a medial half anchored by a very complicated papillary muscle. And to be quite honest, I've done 3,000 mitral valve repair in my career. I have seen more than 20 or 30 patients with no papillary muscle, where the posterior leaflet on its medial half and the anterior leaflet is anchored entirely in trabecular carne. So this papillary muscle is complex, highly variable, and is a problem to repair. Actually, 90% of the pathology in mitral valve is here, on this half, not on that half. So the pathophysiology is one of the first, the leaflet prolapse causes mitral regurgitation. Mitral regurgitation causes volume increase of the ventricle, and the increasing size of the ventricle causes anodilatation. This perhaps is true in patients with fibroelastic deficiency, in older patients. The younger patient, the 30, 40, and 50-year-old who develop MR very seldom have fibroelastic deficiency. They have an advanced myxomatous degeneration of mitral valve, which likely anodilatation happens first. The annulus become atrialized, wall tension goes up, then they develop prolapse. Prolapse of what? Well, more than in my practice, half of them is isolated posterior leaflet. The most common site, P2, because again, is the most stressful part of the posterior leaflet. One half moves dramatically, like the anterior portion of the posterior leaflet. In other words, the anterior half of the posterior leaflet, the part that's anchored to the anterior papillary muscle, is much more elastic, moves much better during cardiac cycle, as opposed to a more stationary part attached to the posterior wall of the heart and posterior papillary muscle. Next, bileaflet prolapse. And the least common is isolated anterior leaflet prolapse, which, to be quite honest, is the same as posterior leaflet prolapse, equally simple to repair once you have done enough. I find this the most complex ones to repair, not the anterior or posterior. Carpentier established the guidelines how to repair mitral valve, but you have to remember that well before Carpentier, many American surgeons were repairing mitral valves. Dwight Magoon had his own technique to repair mitral valve. But Carpentier should be given the credit to have established some guidelines on how to approach and to repair the lesions. And this was the most common one, prolapse the posterior leaflet. He originally described resection and quadrangular resection, replication of the annulus. Most of us don't do quadrangular resection or rectangular resection anymore, or whatever resection you want to do. Most of us do a limited triangular resection, not to resect the leaflet, but largely to lower its height. Because if you leave a very long posterior leaflet in a patient who has a hyperdynamic heart, you might get in trouble after repair by developing SAM, systolic anterior motion anterior leaflet. There are other factors as well, particularly the patient has a aortoventricular angle. More acute the angle it is, more likely they are to develop SAM. But I never seen SAM in a patient whose posterior leaflet doesn't move. It's impossible, unless you do have a HOCM, hypertrophic obstructive cardiomyopathy. But then it's not a mitral valve disease. You take a piece of the septum out, the MR disappears. Another way to repair is to anchor the prolapsing segment with Gore-Tex sutures. We introduced Gore-Tex originally in 1985 to repair anterior leaflet. 10 years later, we start using for every leaflet. Why only anterior? And there are different ways. I changed from a single suture to a continuous multiple loops. Fred Moore introduced the prefabricated loops to anchor the prolapsing segment. When to use one or the other technique, at least in my view, is entirely dependent on the height of the posterior leaflet. If this is more than 2 centimeters, free margin to annulus, there is no way in hell you can use Gore-Tex or short this leaflet without causing a major bulky and obstruction of the inflow. You're going to have to shorten because the distance between papillary muscle and free margin is not 2 centimeters. So between 18 millimeter or more, I think Gore-Tex alone is not enough. You should shorten a bit back triangular resection, then put the Gore-Tex if you don't resect anything, but it should be shortened. When we introduce Gore-Tex, we start a single suture by passing through the fibrous portion of papillary muscle, bring both arms to the atrial side, and adjust the length by blowing the ventricle saline, and look where it co-opts. This is not a bad technique for a beginner. After you do 100, 200, you pretty much know which level it is. Actually, by 1990, we had changed the technique. We tied the Gore-Tex to the fibrous portion of the muscle, and we started a normal chorda tendina. In other words, the first loop go from the muscle to a normal chorda, one that, to your judgment, is not prolapsing. Pass twice to the free margin, go back to the fibrous portion, bring it back to the free margin, pass twice. Well, how long do I make this? The same length as the previous one. The previous one is normal. And keep moving until next normal one. If you do that, you don't have to blow the ventricle saline, don't have to see if the coaptation is right or not. How do you repair prolapsed anterior leaflet? Well, we still use Carpentier classic technique, the chordal transfer. We no longer use this one here, where you take you go to papillary muscle, take an adjacent cord that goes to the posterior, detach the posterior and flip over. We try to find the chorda from the ventricular side of the leaflet, a secondary chorda, or from the posterior and suture there. This is not always possible. And this is immensely simpler, faster, and in our hands, far more reliable. I have absolutely no experience with Alfieri stitching. I have never done one in my life. I'm not planning to do either. I don't think it makes sense to divide the mitral valve in 2 orifices and then put a ring to make it very stenotic. I mean, I just, all respect to Otavio, is a great man. I believe his result, but it just doesn't make sense to me. How about Kamishura prolapse? Well, Kamishura prolapse, perhaps an Alfieri stitch is okay, but not really Alfieri. Carpentier started doing this when I was his fellow, 43 years ago. A partial closure. You can close up to 1 centimeter of the medial commissure, and you do not detect any gradient at rest, because most flow between the left atrium and left ventricle occurs around the lateral half of the mitral valve. Why? Anatomy. because the bloody posterior papillary muscle doesn't move very much. It's part of the ventricle. The ventricle has to be full of blood before it pulls this part of the leaflet into the ventricle to allow blood through. In 4G MRI has been documented that most of the flow of the mitral valve is beneath the aortic valve and to the left side. Closing here, even closing half centimeter, you might have trouble with obstruction. You're going to measure a higher gradient than you do on the other side. Alain Carpentier introduced a technique that sometimes is still valuable. This papillary muscle is so complex that if the commissure is prolapsed, what you can do, you can shorten the whole muscle, but take a pledge suture in the head, the fibrous portion, and stitching down 5, 6, 7 millimeters, whatever the level of prolapse is. It's more difficult than commissuroplasty and 1 or 2 Gore-Tex down there. All these patients need an annuloplasty. The problem with annuloplasty is the patient who has fibroelastic deficiency and develop acute mitral regurgitation, and now is in CCU in heart failure, intubated, and the mitral valve, the anterior leaflet is 22 millimeter, the posterior leaflet is 6, 7 millimeter. You're going to do annuloplasty and get that patient. He's going to go home with mitral stenosis. So I don't know in that setting if an annuloplasty should be done. I don't do it. I repair the prolapse and leave the patient alone. Following up to 25 years, some of those patients came back with recurrent mitral regurgitation, not because the annulus dilated, because something else ruptured. So annuloplasty protects the chordae tension as well by reducing wall tension on the mitral valve leaflets. What kind of annuloplasty? In this disease here, I cannot show any difference at all among all the commercially available rings. I use a band posteriorly and nothing else. I don't think it has to be flexible, rigid, all this curve. I can tell you that 10 years later, they're all rigid and fibrotic and calcified. So might be flexible when you put it in. Later on, it's no longer flexible. And finally, I do repair these patients, particularly if they're young. It's a long operation. We have to detach the whole mitral valve from the calcium, remove all the calcium, rebuild with autologous pericardium, and then reattach the valve to the pericardium. That's a whole talk by itself because very seldom you have 2 identical MACs. This is our latest publication on our outcomes. We have been fortunate enough to work in an environment where the government, that is the only payer for healthcare in Canada, is the government. They don't seem to object if you do an echo every year in every patient. They pay for, we do it. So we had some 8,500 echoes in these 1,200 and some patients. Follow up to 25 years. We had enough patients at risk at 20 years. They were 58 here, 60% were alive and free of reoperation. 21% died from non-cardiac death. There's nothing your surgeon can do to change. This you can change. And half of these cardiac deaths were sudden deaths. But again, this is topic of another talk. I think we have an operation now to prevent cardiac deaths, sudden deaths in mitral valve prolapse. We are up to 14 patients now, 6 of them with defibrillator we removed defibrillating 3 because after 3 years, no more cardioversion was necessary. And this is what is good about this operation. Very, very few reoperation at 20 years. 6% only had a reoperation in the mitral valve for mitral valve disease. Thank you.
Ryan, thank you so much. And I wanted to invite Dr. Hiramat.
Yeah, Dr. Adams, we have.
So maybe you could share those, and I have a couple as well. I think it's a good break point. And then because Tawasak and I are going to talk about inflammatory valve disease, and we can have another question session after that. But why don't you read some of the chat questions, because I thought they were very interesting for Dr. Moon and Dr. David to respond to.
Yeah. One question from the audience is that any support about pediatric and congenital mitral valve repair? What is the difference from adult repair?
So the question is around, do the principles of adult repair apply to congenital repair, pediatric repair?
Well, I think they do because they're all anatomic pathologic change. Clefts are very common in the pediatric, more so than some of the other abnormalities that we speak of. But it's identifying I think the principles are to identify the pathology of each of the segments of the leaflet and address each of the segments of the leaflet independently that are abnormal and make changes. There was also a question about what's the learning curve for the novice surgeon. And I would challenge Dr. David to tell us, is he still in a learning curve? Is his technique improving with even this many years of successful repair? Or is there a point where you say, I've got this down, I can do it all? What do you think about the learning curve, Dr. David?
It never ends, unfortunately. We're always learning something new. I hope, I want to believe that the patients I operate in the past decade will do better than the previous one. But unfortunately, better you get at it, more you keep pushing the envelope. I just said I repair MAC. Well, now I have just 130 MAC. We're going to be presenting at Dave's course in New York, in Boston. And the results are not as great in the past decade. 130 MAC, we had a reoperation 10% at 15 years, where the whole group is only 6%. Now, is a reoperation 15% at 15 years bad? I mean, I don't know. The alternative would have been a tissue valve. If you compare to a tissue valve, likely is better. If you compare to a mechanical valve, repair will not measure up. But there'll be other things might be confounding. Mechanical valve requires warfarin. Warfarin can kill as well. So I don't know. I think you're always learning.
Yeah, I tend to agree. And I think, as far as a newer mitral valve surgeon learning some of these techniques and developing their own skill, I think it does focus on understanding the echo principles before the surgical intervention is undertaken. And that can be learned through just looking at echoes, looking at the echoes with the cardiologist, and going to courses and things like Dr. David puts on, Dr. Adams puts on, where we have not only just some surgery and do some surgery, but look at the echoes extensively. We spend almost half of the presentation time reviewing the echo so that we can determine, yes, I can repair this valve. Yes, someone else can repair this valve, maybe not me. And that's when you would refer the patient away. But I think those things are very, very important.
Yeah, I think, Mark, to the question, I'll just make two comments. One about pediatrics. So for those of you that do see young children, you're probably not going to see really young children, but say that sort of 12 to 18-year-old and you're an adult surgeon, there are two things to keep in mind are you're going to have a different annuloplasty approach. Most of yours are going to be reduction annuloplasty as opposed to remodeling annuloplasty. And I couldn't agree with the point Tyrone made more. As the annular dilatation is less in fibroelastic deficiency, your annuloplasty is really to I think support the rest of the repair, and it's not really to reduce orifice. So those are reduction annuloplasties. You don't have to cross to the trigons, and you can honestly stay below the commissures. And that's really important in growing children. So with children, remember, you're not going to go to the trigons and reduce the annulus, and you're certainly not going to fixate with rigid rings. Most of the time, we'll use pericardial bands and try and put them below the commissures or just at the commissures. And the second thing in children is you're not going to use Gore-Tex. You know, they're going to outgrow fixed chordal links, particularly if they're under the age of 10. In that circumstance, you're almost always going to want to rely on a combination of resection and chordal transfer, whether that's secondary chordal transfer or leaflet flip techniques. But you're always going to want, I think, to try to use Gore-Tex. Gore-Tex is really not your friend in really young growing children, so you do have to be thoughtful about that. The other point was about Mark, about this idea of lesions and recognizing them, and I couldn't agree with you more. And I'll just make one other comment that, I think the most important lesson I learned along the way was not looking at the whole valve to begin with. I think if you look at a whole valve, you're probably going to it's a little bit like when you're behind. There was this big college basketball game the other day in the United States, and the team was losing by 15 at halftime. And if you just go in the locker room and say, wow, we're losing by 15, how am I going to win? I've got to score 15 points in the next. You had 20 minutes. All you have to do is score 2 points, outscore the other team 2 points every 2 minutes, and you win. And I think the same way about mitral valve repair. Don't be intimidated by the total picture. One of the most valuable lessons I could ever tell you all is try and fix a segment or two and make sure that's in line and the height's right and you resupported it. Do a saline test and confirm you fixed a quarter of the valve or a third of the valve. Once you've done that, you will gain the confidence to keep going. Because if you try and look at the whole valve and the complex valve morphology, you'll get intimidated and you'll be surprised how many more valves you'll repair if you go to the operating room with the idea, I'm going to take an hour and I'm not going to replace a valve till I've spent an hour trying to repair one.
That goes to one of the questions in the question line was, is the saline test reliable in any kind of MR? And you just said we use it to assess different segments. How do you use the saline test?
So Mark, I'll tell you what I do. I'm curious what if Dr. Hiramat or Tyrone has a different comment. What I like to do is if I address a segment of the valve, let's pretend I've got A2, A3 prolapse, bileaflet prolapse, A2, A3 prolapse, but I've also got a tall, irregular posterior leaflet. I like to fix the posterior leaflet. I'll take my forceps, hold A2 and A3 in the closure line and retest it. That's just to test my height and support of the posterior leaflet. If I let go, the anterior leaflet will still prolapse. So I find saline testing is really quite useful along the way, and we mark valves all the time as we're going. At the end of the case, I think saline is the most useful to judge the height of the closure line. And of course, you can document whether you're watertight or not. But it's a little bit artificial. It's not the pressure you're not going to generate as high as the ventricle. You need to push the ring down to make sure you've got the sort of valve in a proper position to assess it. But it's very reliable. It's reliable, I find, in all valve disease. The one thing, and I'm sure Tawasak will agree, in rheumatic disease, when leaflets are very thick, now you've got to, you sometimes have trouble pressurizing the ventricle enough to see what the final closure line is going to look like. So there is a leap of faith in rheumatic valve disease. Sometimes you need systolic force to really see what your final closure line is going to look like.
Dr. David, do you use the saline test reliably, or how do you assess your valve as you're doing your repair?
No, I infrequently saline test. If I'm in doubt of my judgment of what I do a lot is keep comparing posterior to leaflet if they come to the same level. There is something about mitral valve repair. I don't know when this happened to me. I started repairing back in 1984, 85. By 1990, something clicked in the brain. And perhaps the click in the brain correspond to the first 100 or 200 cases. That I don't, for this disease, I don't think is that complicated to prepare, to be quite honest. I use saline tests infrequently.
Yeah.
It's not
And let me
quite-
just say that I haven't caught up to time. I've only done about, I don't know, 7,000. So I'm still trying to get to Tyrone's number. But Tyrone and I are preaching different gospels. Tyrone is preaching the Fred Moore gospel, by the way, which is or the Carpente gospel, which is Tyrone, you're relying on anatomic reference.
Yes, repair.
Yeah. And I'm relying, and Mark, I like anatomic reference points, but I really trust physiologic reference points, which is why I always put 2 knots in a Gore-Tex, fill the ventricle, look at my position, and then adjust the height. So I find saline gives me a physiologic, it's a different way to assess the anatomy versus just trying to choose reference points, because it creates reference points when you fill the ventricle.
Now,
What do you think
it
of that,
does,
Tyrone?
but your test involving diastole and the mitral valve closing systole.
Yeah, let me say I'm testing.
So
I agree with you. No, I agree with you, Tyrone. We're testing the valve in diastole. That's why you have to be careful. If you have a very pliable ventricle, you can overfill it. You're testing the valve in diastole, and you're only generating the interventricular pressure of say 40 or 50, not the systolic pressure. But that's why you can't reliably test it in rheumatic patients. On the other hand, you are getting fairly even force on the chordae. So in terms of using it as a physiologic reference point, it's fairly secure. What do you think of that?
Yeah, well, but still, you're going to increase the diameter of the cavity by distending. And luckily, the papillary muscles are not in the apex. They are at the lateral and posterior midwall. So the effect of this tension perhaps won't be as dramatic as it is, but again, you cannot measure function MR. You can measure only for prolapse. I think the extension of the ventricle saline is good enough to measure prolapse. It showed the prolapse.
Yeah, I just like seeing symmetry. It helps me understand symmetry of the final closure line. Again, it's all matters, and I do think I don't want anyone to be intimidated by any of these discussions. You guys can all learn how to do mitral valve repair in degenerative disease, and it just starts with, if you go back and watch Mark's talk, which I'm sure will be online, you watch that talk 10 times, believe me, you will have 90% of this. And if you just listen to the little pearls that Tyrone just gave you about, how to think about the 3 most common things you're going to see, which is the posterior leaflet, bileaflet, or anterior leaflet prolapse and mitral annular calcification, you're going to get the blueprint very quickly. Tyrone, I couldn't agree more. The problem I see with mitral valve repair is many times we've overcomplicated it. It's not that complicated.
And also give up too soon, or sort of look at it and say, oh, that's a non-repairable valve. I like your whole concept of you've got to work at it, work at each segment and address each segment, and get yourself to the point where you say, well, you know what, maybe we will be able to repair this valve.
Yeah, I believe simple prolapse of a single segment we can all do. Where the real skill comes, where you have the confidence to start doing segmental repair, knowing you still have other things that you're going to address later, Mark. I couldn't agree more. Dr. Hirabath, let's close this session. Make a comment for us or give us some wisdom from your end.
Yeah, in fact, there were a few points to learn. And in fact, some or two more questions are there. What is the intraoperative testing apart from saline test? What Dr. Mark Moon and Dr. Tyrone David would recommend to the surgeons?
I have nice hooks that I use to judge the height of the each segment. And in addition to the saline test, looking at each segment and its height and in relation to the annulus, I think is important.
Yeah, I use two hooks, one in each hand from commissure to commissure. Carpentier did the same, you know.
I think we all learned.
I'll just give you the corollary. I almost never use two hooks in every segment anymore. I try and visualize a reference segment, which it really varies. But I'm just going to get back to one more point about the saline test. Please fill the ventricle with saline and mark your closure line with an ink marker. When you empty the ventricle, you will learn all kinds of things. If your false commissures are in that ink line, that's a consistent source of mild residual regurgitation. If your anterior leaflet has more than, say, 2 centimeters below the ink line, you really need to resuspend the posterior leaflet lower. Usually just a single or 1 or 2 Gore-Tex will do that, but ink and then if you do a saline test and you see the tendency for prolapse of the anterior leaflet, if you just mark that with a dot, it will always take you to where you want to try and put an anterior leaflet cord. But I can't tell you, a marking pen is so useful. And the less of this you do, the more useful it is. Tyrone can do anything.
No.
The rest of us, believe me, a little bit of purple ink on a valve will make you operate much more like Tyrone.
You know, it's funny. We all three of us learned how to do mitral valve repair from Carpentier. Am I correct?
Yes, absolutely.
And we've all evolved essentially the same, although we've got discrepancies.
Another question is,
yeah, I just would like to add a little bit about the testing of the valve competency. In addition to the analysis of the anatomy and the physiologic movement, we also have to assess the quality of each segment of the tissue. This is what I learned from the rheumatic. If the leaflet partly is thickened and non-pliable, even we have the same length, it will not close at the right time because they cannot come up. That's why we have to do the peeling to change the quality of pliability so that they come up and close at the right time, at the right level. This is one thing that we have learned during the rheumatic valve repair. We must care about the quality of the tissue of the leaflet and cord as well.
Yeah, and Thomas, like your point is so important. And I'll just make one last comment about resection, because I think that what one of the lessons from Mark's talk, and one thing to remember is that and Tyrone mentioned this as well, resection can control the marginal cords, and but by doing a wide base resection and sewing 2 cords together, when you transfer them, you can displace the margin of the posterior leaflet. That's controlling prolapse. But what Thomas just said is also very important. If you've got excess volume, marked degenerative disease, Barlow type deformity, what you don't want to do is invert leaflets and make them thicker and less pliable. You want to always try and maintain leaflet pliability. So that's when the resections need to be deeper in the body of the leaflet, not just at the margin. But I will say, Mark and Tyrone, that we have the mitral conclave coming up in about a month, and I wish this could have been the opening plenary discussion. We would have gotten rave reviews. I think it was great fun to have both of you give that discussion and have a discussion about it. It would have been a lot of fun. But at any rate, we probably ought to move on. I like keeping the aortic surgeons up later at night, so this has been fun for us. Since mitral gets to go first, we get to keep everybody else up later. But maybe I better get my talk, and we'll move on to sort of inflammatory processes in the mitral valve.
Well, the aortic surgeons are always up late doing some sort of
Yeah, that's
emergency.
true,
Mitral
too. I
surgeons get to go to
forgot about
bed.
that. You're right. They're always up doing dissections and stuff, so they can talk about all sewing all those circles together after we're all gone home. Okay, so listen, my talk tonight is going to be off the beaten path a little bit. I wouldn't dare we want to talk about rheumatic disease and in terms of non-thrombogenic surgery, particularly to an audience like this. And again, I just want to express my appreciation to the Indian Association of Cardiovascular and Thoracic Surgery. This is an incredible opportunity for us. And your friendship and partnership means a lot to the AATS. And I really mean that. Mark and I were at the board meeting a few weeks ago, and the first thing we said when we talked about a live valve course next year, the word I wrote back to him was India. So we really want to come back and do this live with you. Tonight, what I wanted to do is I wouldn't dare talk about rheumatic disease with the master of Tawasak on this phone. So I thought I'd talk to you about something a little bit off the beaten path, which was mitral valve repair in the setting of non-rheumatic inflammatory disease and scarring. Because this is also a very important subset of patients that you'll see. And as I'll show you, almost all of them can be solved, but they're less common, so recognition is real important. So these are my disclosures. These are my disclosures. I've been involved in the development of several annuloplasty rings, as well as involved in leadership of many different pivotal trials of transcatheter valve therapy in the United States. But I'm not really going to focus on that this evening. So what I wanted to do to explain non-inflammatory valve disease that affects the mitral valve and walk through how we think about it is show you 5 cases to demonstrate this. And the first case I'll show you is a 60-year-old patient. He's asymptomatic. He's got obviously severe mitral valve regurgitation, a normal ejection fraction, small left ventricle, and surely someone that is going to have an expectation for 100% repair. So here's his valve analysis. You can't really see that calcified papillary muscle and fibrosis on the echocardiogram, but you can see it's created almost a bilobe posterior leaflet. And to repair that, what we're going to do is we're going to resect this calcified papillary muscle head that's really restricting leaflet motion back to Tawasak point. We're going to create mobility here. So you can see I'm resecting the calcified papillary muscle head, debriding it off the annulus. And then we're going to use the excess height that we've got to put this back together again. You can see here, I'm taking advantage of having the leaflet attached to put horizontal mattress sutures in. Then we'll use the residual leaflet to reconstruct the posterior leaflet. Now notice I did not correct prolapse in the first step. I'm using the body of the leaflet to create the coaptation surface, knowing I'm preserving areas with chordal rupture. Then we'll do the leaflet reconstruction. That's the ink test I was talking about. Then we can decide whether we need to do anything else. In this case, you can see I marked that area of prolapse in the anterior leaflet. And now I'm going to resuspend the valve with a chordal transfer. And now you don't see the ink anymore as I've pulled that down. And then the last step will be to add Gore-Tex to reinforce this leaflet, as you can see I'm doing now. And then we'll just put a true-sized band in it or prosthesis in it, and you'll see what's going to happen. So there's an operation, again, where the main point there was this unsuspected finding of a calcified papillary muscle in the body of the leaflet and the importance of resecting that to get a good result. And then it's just a segmental approach. So very straightforward valve repair, but important not to be intimidated by that thick calcified chordae. And again, a fairly common thing in inflammatory prolapse. The second patient is a 50-year-old woman, again, asymptomatic. severe MR, and also a normal ejection fraction, small left ventricle. So she's going to have very high expectations for repair. And you can, if you watch this echo carefully, you don't get a sense you're up against much. You think this will be fairly straightforward, but as you'll see, the echo sometimes belies the complexity of what's below the valve, and what you address below the valve is very important in terms of reconstruction. So here's her valve, obviously a Barlow type deformity, diffuse abnormalities with myxomatous change, excess volume, and a height in the posterior leaflet. But look at her anterior commissural area. Her anterior papillary muscle head is frozen into the commissure and into P1. So lots of excess tissue. And again, as Mark was saying, very intimidating to look at it. You're really going to have to take your time here. So the first thing we'll do usually is release the anterior commissure. We're dissecting the anterior papillary muscle head off the commissure, doing a papillary muscle split, and then we're going to remodel the anterior commissure. We're going to advance it and remodel it. We dissect all the calcified cords. Again, this is a prolapse case, but it has subvalvular inflammatory change. So we've addressed that, and now it will become a standard repair for prolapse, of which you can do a sliding plasty, as we're showing here, non-detachment sliding plasty, which we are doing a lot of these days. Even Gore-Tex would work, but we'll do a straightforward detachment sliding plasty in this case. But the key was resecting the frozen anterior papillary muscle and mobilizing the anterior commissure. And then once we've done with that, then it just gets back to the normal routine of a posterior leaflet that's a centimeter or a centimeter and a half. Make sure you've corrected the prolapse. Again, we mark valves with ink to test our closure line. That helps us understand Gore-Tex. There, I'm displacing the posterior leaflet to make sure enough of the anterior leaflet is out in the orifice of the valve. And you can see how with the ink test, I can see more of the leaflet in the orifice now. And then that allows us to true size a ring, or in this case, slightly oversize a ring. And that's the new Physioflex annuloplasty ring. It's a partial ring that has variable flexibility and variable shape. And I think it's ideal for a form-fruits case like this, where you're trying to involve or trying to eliminate the risk for systolic anterior motion. And there's the final result. So again, remember, for both those cases show you that you may go to the OR with prolapse, but you discover subvalvular inflammatory disease, not in the annulus and the papillary muscles and the cords. And if you see that, go back to your sort of rheumatic principles around remodeling and releasing those as you're thinking about how you're going to reconstruct the coaptation surface. So the next case I'll show you is a 60-year-old patient. Again, history of prolapse. He's got some kidney disease. He's been symptomatic. He's got MR progression. Again, when you look at that, it looks like it could be type 1. Maybe there's a prolapse. Hard to see on that echo image. Preserved left ventricle. And let's look at what we found here. Unbeknownst to us, we found this which are Libman-Sachs vegetation. So again, looks very intimidating, actually fairly straightforward. So if you see an inflammatory change like that on the valve, please don't get your scissors out. You know, get your rongeur out or your biters and take all this stuff off. Almost always, to Thomas-Sachs' point, you can peel these off the leaflet. And so whenever you see a Libman-Sachs type inflammatory process in the valve, just find that plane and peel it off the valve endocardium. Again, that'll take you 15 or 20 minutes to do carefully. Almost always you can preserve most of the valve. Occasionally you've got to do little triangles or quadrangular resections, but that's going to be very well tolerated. But you can see as we move along here, and again, it takes about 20 minutes to do this perfectly, you can start to find the normal valve under these inflammatory lesions. And then you can make your decisions about what else you need to do. Almost every time we'll reinforce it with an annuloplasty, although we won't be very aggressive with it. And then occasionally we'll find some subvalvular abnormality, like here you can see that looks a little funny. Okay, we'll release that, or we'll do, in this case, we'll do a magic suture. It really was below the valve. I couldn't agree more with Dr. David. You got to be very careful narrowing the anterior commissure. Posterior commissure, break a leg. You've got 2 or 3 sutures you can put there. We really won't go past 1 suture in the anterior commissure, and then there's a true size PhysioFlex band again with, again, a good result of something that looks complex. It's actually fairly simple to deal with. So here's the next case. This is something that you'll see in reoperations, to Tyrone's point. Remember, flexibility is transient. Almost all these valves grow into the ventricle, and occasionally they overgrow in the ventricle. And this is another inflammatory process that generally can be treated with re-repair, not replacement. This is a 49-year-old patient. He had a previous mitral valve repair in an outside institution with a right thoracotomy, had AFib, had dyspnea, has a mitral stenosis now with a mean gradient of 12, and you can see he's got a large ventricle. Here's what we found this time. You can see the post-relief. It looks like the ring was too small to begin with, and it's certainly overgrown with fibrosis. So fibrosis like this can restrict the hinge point, restrict the orifice, and I think it can compromise valve function as it did in this patient. Here you can see, as Tyrone points out, it doesn't look like a lot of annular dilatation, does it? Remember, there are no rules in this business other than that you have good coaptation. We took the ring out and we stopped, and we got an excellent result. So again, don't forget that it's not mandatory. I always use a physio ring, or I always use this ring or that ring. Sometimes you don't need a ring. In this patient, we simply took the ring out, debrided all the fibrosis, and got an outstanding result. Then the last case I'll show you is relatively new. I think Tyrone and I are singing the same music. We're learning how to cure sudden death in patients with mitral valve regurgitation. And this is also probably the most elegant and cutting edge form of treating subvalvular inflammation. This is a 63-year-old patient. Has had a long history of MR, has a history of PVCs, which he's told to ignore, had a witnessed cardiac arrest, has severe MR, preserved ventricular function, believe it or not, was still recommended to be followed. We met him somewhere along the way. And this is the sort of patient that today we will do a complete repair, which includes isolating the papillary muscles. And I'll show you how we did that. So our group has published this a year and a half ago in JAMA Cardiology. We're using hybrid PET MRI to try and identify not only scar in the tips of the papillary muscles, but also early inflammation. And you can see this patient has both scar and inflammation. And what this is a sale effect. Remember that when John Barlow, long before Echo, described the original patients that had clicks plus ventricular arrhythmias, what he was describing is what we're now documenting. It's the base of the papillary muscles and the tips. It's the papillary muscles that are attached to large cell leaflets under excess force when the ventricle squeezes. And it's creating inflammation, whether that is from tension or from ischemia, I don't know, but that's what we're treating. And now we'll show you the operation. Of course, you can do the valve repair, which will shorten the posterior leaflet and take tension off. But look at the scar in the papillary muscle. And in cases where we can isolate the scar to the papillary muscle, we will do a combination conventional valve repair to lowering the height of the posterior leaflet, which will decrease tension on the papillary muscle. And here you can see just sort of standard techniques. We're closing one of the commissures. We're going to detach the valve, do a large quadrangular resection to decrease volume. Then we'll do sliding plasty to decrease the height. But in addition to that, we're going to isolate the papillary muscles with a cryoprobe. And so our goal here is to try and isolate the papillary muscles from the ventricular wall. And that's what you see we're going to do here. We're going to take our cryoprobe, and we're going to isolate the papillary muscle now from the base of the ventricle and the base of the mitral annulus. We tend to do 2-minute burns here. It's very effective in isolating the papillary muscle. And then when we get done, you'll see this final repair. Now the repair will be done in a standard way. So now we'll just remodel the free edge here. We're just getting a better closure line. Or I should say a symmetric closure line. Again, it's really a combination of papillary muscle cryoablation plus a good Barlow valve repair. But I think this is a big, big story in mitral valve disease is treating patients that have this tendency for ventricular arrhythmias. And if they have appropriate isolation of scar in the papillary muscles, I think it's the other non-rheumatic inflammatory process that you're going to see become much more important for us to address in the future. So with that, I'll stop. Mark, thank you so much for including me in this tonight. It was a lot of fun. And maybe Tawasak can speak and we can have a couple of questions about inflammatory processes before we move on.
Can I ask you a quick question about doing the PET scans? What do you do that only in patients that have had an arrhythmia? Because how do you identify them? It's got to be a low incidence.
Yeah, Mark. So now we're doing them in patients that have had, if they have histories of PVCs, we're doing that. What we're going to do and what we've submitted to the NHI or the NHLBI is to have a prospective study where we're going to start doing that in patients with the phenotype. Because bileaflet prolapse, particularly women with bileaflet prolapse, is really the phenotype that will I think go on to have inflammation. And I believe, again, we have to prove it, but I think one day we will have on that algorithm. I think that if you're going to do active surveillance for bileaflet prolapse, I believe we're going to learn that PET MRI will be one of the discriminators. If you have inflammation, I think you'll be more apt to have early surgery. Now, the papillary muscle ablation, that's more selective. We've got to make sure, and usually that's done by, we work with one EP physician, Mark Miller, and he can really isolate that to papillary muscle origin, analyzing the EKGs. But I do believe inflammation is going to be a big story. And one thing's for sure, and I'll just say this one more time. We have always said ischemic MR was a disease of the ventricle. I believe, Mark, what we're going to discover the next 10 or 15 years, and I'm curious what Tyrone's comment is, I believe all mitral valve disease is a disease of the ventricle. I think eventually all mitral valve prolapse or mitral valve phenotype damages your ventricle. If it's prolapse, say FED, it's from volume overload and pressure. If it's Barlow's, there's probably two ways it damages the ventricle. One is by volume load. The second is by fibrosis of the papillary muscles.
And the Leibniz-Sachs, when you peel it off, is it going to come back, or do you give steroids or some sort of other anti-inflammatory?
We've been selective about steroids, and we've given them all anticoagulation for 6 months. And I must say, we haven't seen recurrences. It doesn't mean we won't have some, but we found that to be pretty effective. And again, I honestly don't know, Mark, when these steroids stop. I know we start them. I don't know when we stop them.
More work to be done.
It's exciting stuff, though.
For sure. Oh, and one last thing, when you do that papillary muscle splitting, how deep do you cut, and where do you cut in the papillary muscle? Right in the middle, or to one side or the other?
Oh, I'm
or-
sure Tawasak's going to tell us, but I like to try and split the head. I'd like to go down at least a centimeter into the papillary muscle head, which usually will get you about 1.5 centimeters or 2 centimeters below the plane of the annulus. It's hard to split it too much. And boy, I don't know. I'm convinced that you need very little living tissue still intact, and it's still quite stable. It's not like you leave a ribbon like papillary muscle and somehow it ruptures. I've never seen that. I think that fibrosis is the enemy. So if you're going to do a papillary muscle split, be aggressive with it.
Dr. David, what do you think about the papillary muscle split? Do you have any secrets to that?
Well, yeah, we do. But I do not from extensive experience, but rather from mentorship. Carpentier used to say you should split transversely between anterior and posterior to increase mobility of the anterior leaflet mostly. So if you have a fused cord that involve both, talk about the anterior perimuscle now, if you split perpendicular to the, it doesn't do a thing. The idea is to allow the leaflet to move more. So resect secondary chorda and split muscle to increase mobility.
And to increase the inflow orifice.
Yeah, of course, yeah, but to increase your orifice because the leaflet is going to open more if you split papillary muscle.
Because Tyron, I'm convinced some of these very bulky papillary muscles are also, obstructed.
Obstructive, yeah.
So splitting them, you can see with your sucker tip how you sort of get another access to the ventricle when you split these papillary muscles.
Yeah.
Especially considering the anterior papillary muscle head is most frequently fused, almost always, and that's where your inflow is, as Tyrone said. It's
absolutely.
so important I wouldn't say it's an advanced strategy, but just all of you should keep in mind that your anterior commissural area is where your inflow is, and your greatest force for closure is in your posterior commissural area. So that's why I'd be very thoughtful about how you line things up in the posterior commissure, and be very thoughtful that you try and mobilize the anterior commissure, not restrict it.
David, may I add some papillary muscle technique? We have done a lot in dramatic, and then it's a very important question. And then we select the papillary muscle that looks normal, and then make the cut mostly at the tips down to across the fibers, and usually less than 1/3, because we know the blood supply from the two sides.
Yeah.
In this way, it is very, very safe procedure and improve the mobility of the subpar apparatus significantly.
Yeah, I think you're right, Thomas. Like, that's why I said, if you split the head for a centimeter or 1.5 centimeters, generally speaking, you're going to split between 25 and 40% of it, probably 30%. You don't want to go to the base. And you don't need to, by the way. You'll notice remarkable changes when you split it 1 centimeter or 1.5 centimeters.
That's excellent. Well, I think we should probably move on to our last talk, huh? Tawisak is going to tell us about the rheumatic specialty in mitral valve repair.
Mr. Chairman, ladies and gentlemen, first of all, I would like to thank you, the organizing committee, for my invitation for me to share the experience. My topic today is to talk on the strategy in rheumatic valve repair. I have nothing to disclose. I think perhaps it is good for us to compare the rheumatic inflammatory process like a wildfire that burned out everything. So the result, the wreckage is actually is unpredictable. Some is totally destroyed, some is just partially, and some are deformed. And this is the key problem of the rheumatic valve repair, because the goal of the mitral valve repair is to restore both the normal mitral dynamic of both diastole and systole. In fact, the repair strategy of the rheumatic valve repair is the same as other causative of valve disease, that is to restore the mobility of type 1 with good coaptation surface, and we have to remodel the annulus for long-term durability. And this is the same. However, because of the causative of the rheumatic process, it causes the different pathology. So the same principle with different pathology, we need to have a different approach, strategy, and technique. And this is the same thing when we look at the rheumatic valve. The target of the inflammatory process is involved with the commissure, cord, and subvalve structure, leaflet, and the annulus. All of this will be affected by the rheumatic process. And the challenge is now is become clear. For the commissure is often fused and with calcified of the commissure. The leaflet is often thickened, retracted, and calcified. The subvalve is fused, shortened, thickened, and some elongated, whereas the annulus often is fibrous, deformed, and sometimes calcified and dilatation. All of this is a big challenge that we have to restore back the normal diastolic and systolic function now. In diastolic, we need to have the fully open valve with non-restrictive and no obstructive movement to achieve the type 1. And the channel, the fenestrated channel, now we understand that it provides improved diastolic flow in addition to the central flow. This need to have a significant in terms of mitral dynamic. And pliability of the leaflet and cord is so important to provide the optimum flow, optimum opening without obstructive sequelae. And for the systole to have the type 1, we must have pliability of the leaflet with no restrictive of the cord. And with this pliability of the leaflet, it will provide coaptation and absorption of the more systolic stress. And then finally, we have to remodel the annulus. So often that we have to encounter the calcium, especially whether the leaflets about the calcification. If it's full layer, we need to resect and then think about the tissue repair. If it's partial, maybe we can think about the decalcification, peeling, or adding with some tissue repair as well. For the subvalve restriction, it is often that we have to do the papillotomy fenestration, and we have to do quite often resection of any restrictive cord and obstructive cord, and then do chordal repair with appropriate measure. The leaflet tissue defect, either to have the leaflet tissue repair or peeling, can be very, very helpful. So all of this is to summarize our tools in order to repair this rheumatic valve is to do the commissurotomy plus papillotomy, chordal splitting, fenestration, do the leaflet thinning, augmentation, or decalcification, chordal repair with resection, shortening, transfer, or replacement with neochordal replacement, and to remodel of the ring with ring annuloplasty. Actually, it is a team approach that we can see that it is very, very crucial for us to understand. So with this, I would like to summarize and then show to all of this strategy and approach to this video. This is a case that we commonly find in cases with fibrotic rheumatic MSMR. You can see that the valve is really stopped by the fibrotic and the calcium. The first thing to do is to do commissurotomy, and this by sharp resection, as you can see here. And with resection of the secondary cord, there is few and thick, and we can see that with each resection of the cord, the valve is mobilized back. And then this to do the papillotomy to further mobilize the subvalvular apparatus using the sharp dissections, all of this. And this is the severe chunk of the calcium and fibrotic tissue. Also, we can trim it off, cut it out by the sharp dissection of this. And all of this is carefully open the commissure on both sides up to the certain degree that is, and then further mobilize the papillotomy further. And with gradually mobilization of this approach, the valve become more open nicely, and then to peel, and then to relieve the leaflet from this thickened layer of the tissue and the fibrotic tissue. This peeling can be done on both the anterior and the posterior, and starting from the hinge part like this, yeah. And then peel it down to the rough zone. At the rough zone, usually we cannot peel it further because it has no pain, and then we have to resect this thickened layer out by the sharp scissor to cut it out. Then you can see that the base of the leaflet in this case is the posterior is become mobilized, and the anterior is mobilized. The valve become very, very normal looking when we test the valve, as well as, and then we can achieve both the diastolic and systolic. Put in the ring to remodel the annulus. You can see that we get a very good valve function back in this case. And this is the case with the, we encounter more and more is the post balloon, and then patient come back with severe restenosis, and the patient still optimal for repair. In this case, although the case is now a little bit more severe with severe fibrotic and sometimes with calcification, using the same approach and the strategy of the repair, we can gradually improve the repair rate in this group from the about 30 to 40% up to now is about 80%. You can see that we start by the commissurotomy, and then because of the very severe subvalve restriction, we slowly mobilize it by cutting all of these calcified subvalve that is taken out to free the remnant of this leaflet, and then peeling all of this thickened layer. Starting in this case, we start to peel at the anterior because it's easy, and then you can see that slowly we can peel and then achieve the very normal looking about below. Then we cut all of this calcification of the tissue that interfere with the movement of the leaflet. In this area is the posterior. We slowly cut it out by sharp scissor, and in addition to the sharp resection of the subvalve apparatus out, and you can see the valve is now become more better. The thickened layer of the peeling tissue now, we cut it out by the sharp resection, and then the rent of the leaflet is repaired using a 5-O-Purline and cut it out. And then in area that is, we cut all the thickened cord out and need support, we put in the PTFE suture. In this case, it's a 5-O Portex. And then put in the ring. You can see that finally we get a very good looking and very good mitral valve, functioning mitral valve back. And on something before I conclude my talk is we found the severe functional TR plus organic TR often, and this is the way that we can bail out after a long process of rheumatic valve repair. In this case, we simply use the Alfieri technique to suture the anterior and the septal leaflet using the 5-O Purline mattress suture at this area so that it becomes edge to edge. And then we have to see look for the organic. In this case, is a septal leaflet with some prolapse of the septal leaflet close to the septal anterior commissure. We simply use the remodeling technique 5-opoline to correct this prolapse of this septal leaflet of the tricuspid valve. And then with this combination of the edge to edge and some repair of the localized functional organic TR, and then we put in the ring to secure the repair of this tricuspid. You can see that the tricuspid valve in this complex TR is very quickly repaired in a very good way. So in summarize, I would say that the key strategy is we have to correct both diastolic and systolic. Stepwise approach, holistic repair, not just commissurotomy. Due to commissurotomy, fan shape, caudal resection of the ACP complex. MR is usually due to restrictive cord type 3A. And then fenestration need to be done more frequently in order to provide the collateral flow. Peeling is integral to provide pliability. It can be done both for the leaflet and for the calcification, and select the appropriate valving is crucial for long-term durability. Thank you very much for all of your attention.
Excellent. Thank you, Tuisak. That was an outstanding review. Just one quick question. Is there ever a peeling that you describe for the mitral valve that's relevant for the tricuspid valve so much, or is it mostly functional? As you said, there was some organic component, but is there also the fibrosis that you occur and scarring that occurs on the mitral valve?
Yes. Now we start to use the peeling for the pneumatic TR as well to peel the leaflet of this tricuspid valve and make it more pliable. But often that we find in addition to the functional TR, we often find the organic TR on top of somewhere that we need to correct as well and put in the ring. Usually it's very good. For the alveolar stitch, we use as a bailout in case of too complex, and we have spent a long time, then we use this. This is quite good. We bail out with the low mean gradient across the tricuspid valve with the TE, intraoperative assessment.
Excellent. Dr. Adams and Dr. David, do you have any final comments to close out our mitral session?
Yeah, I have got one question to our Dr. Twasi. During the process of peeling, if there's a perforation, how do you handle it?
We simple suture with 5-opoline.
No, if the perforation is wide, do you use a pericardial patch to cover it up, or how do you plan it?
In our experience, it's just a small rent or a linear length that we can do that. But in case it is a tacky one, we can use a pericardium to close it, for sure. To close and then
pericardium, or you don't
the
treat the pericardium?
Yeah, pericardium, autologous pericardium.
Do you treat it with formaldehyde? Do you treat it with glutaraldehyde or use it fresh?
Yeah, that is good. If it's small, we use fresh. If it's big, at the end clear pressure load area, we use glutaraldehyde treated.
Thank you.
Dr. Adams and Dr. David, any final comments?
No, I don't have anything. I'm all respect to Tawisaki, I'm very skeptical for this extensive resection and mobilization. I wonder for how long this stuff is good. 2, 3, 5 years?
It depends on our experience as well. With the layer of the tissue, it's not full layer, and we can peel. We can see that the underneath is a normal. We can be sure that it's quite long. We have been using this technique for more close to 8 or 9 years now. It's still good in some cases. Those that's not good because we have done not adequate. We still leave some fibrotic tissue at the beginning. We do not replace with the orthologous pericardium at the beginning. This is a learning curve. Sir.
It's always like it's very phenotype dependent, meaning that I'm sure you agree. My experience is that first of all, it's much more straightforward to do in children than in adults, and secondly, sometimes you can, like in the video you showed, you develop a plane, you find a pristine valve below it. I think you're going to get a great result. Sometimes it's hard to get the plane, and then you're a little less enthusiastic, I would say, about the long-term durability. So again, it's all about the phenotype. But you're right. I think the key message here, I would agree, and I learned this technique from you in Thailand. Operating on cases with you there is try it. Use it, and I like to use a 15 blade. Split it, get to the base of the endocardium of the valve, and then see. Because oftentimes you're surprised at how much you can actually peel off. But I don't think it's 100% of cases. I think it's like anything. There's some luck and some phenotype in this.
One last, thank you. One last, very short expression. In rheumatic, I would like to emphasize again that the most we often forgot the dorsal physiology that we need to restore back. That means we have to restore, resect several things at the subvalve apparatus. We need to restore the pliability so that the leaflet can open nicely. We need to restore the fenestrated channel so that the mean gradient will be reduced. All of this, I think that we have a great impact on the long-term durability. We have to study long-term.
Diastole and systole, very important part to Isak. Well, this concludes our mitral section. Dr. Hermuth, shall we take about 2 minutes to regroup, and then we'll start the next session? We're a little behind schedule.
Sure. Yeah. Thank you.
Dr. Badwar is going to introduce Dr. Vinay Badwar from West Virginia while Dr. Nair joins.
I'm not sure whether they allow us to go to another session or not. Yeah.
So thank you all for your attention. It's been a wonderful talk on the mitral valve. We're going to move on now to the aortic valve and beyond as we come up.
Great.
So
Dr.
Nair will
thank
join.
you very much. Mark, thank you.
Thanks, everybody.
Thank you, sir. Thank you.
Is that Dr. Nair?
Very good morning, Dr. Mark.
Very
Nice to
good.
see you.
Nice to see you too. All right. Enjoy the next session. Vinay, take it away.
Hi, Lynn.
Thanks, Mark. Thank you, David. On behalf again of the AATS Foundation and Edwards Life Sciences, welcome to the second session. Wanted to welcome our co-moderators, Dr. Girardi and Dr. Nair. And we'll start the program off. I know we're a little bit behind, but we'll look forward to a nice panel discussion afterwards on really three topics on the surgical management of aortic stenosis, so with TAVI versus SAVR, the Ross Renaissance by Dr. El Hamadzi, and then of course valve-sparing root replacement by Dr. Girardi. So to kick us off, I'll start us off with the TAVI-SAVI debate and give this presentation to begin.
Hello, my name is Vinay Badwar from West Virginia University, and my topic today is TAVI versus surgical aortic valve replacement. Should we trust the guidelines? I have no relevant financial disclosures. Now, this insertion of the statement of shared clinical decision-making for lifetime risks and benefits of valve type, tissue versus mechanical, and approach, transcatheter versus surgical, in the 2020 AHA-ACC guidelines is important to note the relative equivalency of transcatheter versus surgical therapy for heart team assessments. This will become relevant as we walk through the guidelines. In the flow diagram for symptomatic stage D as well as asymptomatic stage C patients, note the relative equivalency of class 1 recommendation of SAVR or TAVI for patients with aortic stenosis. Of course, when patients are complicated, asymptomatic, low ejection fraction, or low surgical risk, SAVR is still recommended. Now, let's break down the guidelines. For severe aortic stenosis with age less than 65, SAVR is still recommended as a Class 1 recommendation, level of evidence A. For age 65 to 80, there is relative equipoise between SAVR and TAVI. And for age greater than 80, TAVI is preferred. When patients are asymptomatic less than age 50 or less than age 80, equipoise between SAVR and TAVI. In asymptomatic aortic stenosis that's very severe with rapid progression, SAVR is recommended as class of recommendation 1, but level of evidence B, non-randomized. When a bioprosthetic prosthesis is preferred and there's poor vascular anatomy for access for TAVI, then SAVR is somewhat the default preference. And when there is high or prohibitive risk, TAVI is preferred, as of course recommended from the landmark PARTNER 1 and core valve trials. Now, when the predictive survival is less than 12 months, caution is recommended for intervention and palliative care should be considered. Class of recommendation 1, level of evidence C. Of course, when patients are critically ill, then percutaneous balloon aortic valvuloplasty as a bridge to decision or bridge to therapy is a 2B recommendation. So in other words, TAVR is considered in any of these three categories. Of course, this is a relatively broad consideration without direct mention of risk. So how did we get to this point? Well, if we look at the analyses of the low and intermediate risk trials, these have been performed using non-inferiority endpoints. In the PARTNER 2 intermediate risk trial, you can see that with non-inferiority endpoints, the primary endpoint of death or disabling stroke was essentially overlapping with both cases, with the confidence intervals overlapping 1. All-cause mortality or disabling stroke in the core valve SURTAVI intermediate risk trials were similarly overlapping. Now, if we look at the low risks patients, you can see that the low risk in the PARTNER 3 trial were essentially the same, with age of 73 with a STS risk score of 1.9. In the low risk trials for the EVOLUTE trial, the core valve trial, also similar age and similar STS predictive risk of mortality. But there's no significant difference between groups. Now, when looking at the low-risk trials, there's important to note that there's no difference in mortality. However, there is an initial stroke penalty incurred on SAVR, which is higher than the TAVI patients in the initial operative procedure. Importantly, it was chosen to include rehospitalization, which unfortunately favors TAVI, particularly following surgeries such as pleural effusions and things of that nature. And that penalty incurred in the initial 30 to 60 days carried over throughout the entire follow-up period. These elements are what led to FDA approval for both the low and intermediate risk cohorts. Now, important to note is the patients that were actually excluded from the low to intermediate risk groups, and that was all bicuspid aortic valves, coronary artery disease, appropriate patients for mechanical valve therapy, concomitant procedures, and any quote-unquote unfavorable anatomy as judged by the selection eligibility committee of these trials. That includes horizontal axis, LVOT calcification, or annuluses that are either too big or too small. So a fairly highly selective group. And when now using these indications that were generated by non-inferiority endpoints in heart teams, one needs to be careful to avoid indication creep for patients that were actually not included in these randomized trials. So selection is key, particularly for long-term outcomes. Important to note that in current therapy, in this paper from Jack, that close to 1/2 of the low-risk patients that would otherwise be included in the trials exhibited at least one major criterion not evaluated in these TAVR trials that were actually operated upon. Also, that in some of these patients, embolization can occur, and the risk of periprocedural TAVI embolization and migration, as noted by the travel registry, included 273 patients, 1% of all implants in this one trial. And note that the mortality of these patients are markedly increased, as well as the stroke risk compared to non-embolized patients. Moreover, when approaching a relatively low to intermediate risk patient, one can think about a TAVI being implanted and then another TAVI being implanted. Well, these are results from the valve-in-valve TAVR investigations, and looking at 1-year all-cause mortality is again non-trivial, ranging from 8.5% to up to 25%. Now, when we look at the PARTNER 2 intermediate risk data at 5 years, you can see that the data is somewhat overlapping, in that the Kaplan-Meier curves cross when we look at the primary endpoint at about 36 months. And while the hazard ratio remains not significant, there is a trend slightly in favor of surgery. Now, in the SURTAVI trial, or low-risk Evolute trial, that it was just published within the last 5 to 6 days and presented at national meetings in the United States, there is slightly more overlapping similarity in the core valve experience at intermediate risk at 5 years. So the jury is still out, but the longevity looks to be stable in these patient populations. However, when we look at the real world data, so these are patients in this trial called the Observant Study, looking at 5-year outcomes of composite death, stroke, or rehospitalization for cardiac reasons. Interestingly, in these relatively real world, less adjudicated patients and less selection eligibility committee type patients, the SAVR patient population is favored. When we look at the application of the heart team in real world, there is a troubling trend. And this is data from Canada looking at that the actual utilization of heart team was very high in 2012, but in recent years this has waned off as one team decides to pursue a TAVI first philosophy. So the challenges of management of aortic valve disease include, when one decides SAVR over TAVR, include these key points. Bicuspid aortic valve stenosis. Now, one should mention that in the last 6 months, there have been small studies as well as the National Readmission Database, studies out of Cleveland and Cedars-Sinai that have indicated that possibly it is okay to do bicuspid TAVR, but these data are not randomized and they're really early experiences. So this still remains in favor of SAVR. Also, these anatomic positions, low to intermediate risk until we have longitudinal data, appropriate for mechanical valve. Aortic insufficiency without annular calcification remains important. Or a situation when the functional basis is preference even for surgery, but those that indicate non-sternotomy approach may be more appropriate, such as frail or other patients such as this. And so I would ask, is there another option? And would posit that there might be, and that might be RAVR. This is a case of a 76-year-old, otherwise robust and healthy symptomatic patient of aortic stenosis, highly significant gradients, STS predictor risk of mortality 2.3%, but he's very active and a farmer. And the heart team weighed these issues and recommended a non-sternotomy SAVR at our institution. This is the transesophageal echocardiogram revealing severe aortic stenosis in the short axis and long axis view. And this is approached robotically. So robotic assisted aortic valve replacement is done through a small 3-centimeter mini right lateral thoracotomy that is completely rib and muscle sparing. And this is not right anterior thoracotomy, or the RAT approach. This is a right lateral approach. Antegrade cardioplegia is delivered either directly in the aortic root or via coronary ostial catheters to assure excellent myocardial protection. You can see the visualization of the aortic valve leaflets with the robotic approach, the severe stenosis. And the annulus is debrided and the leaflets excised in the standard fashion as done in an open operation. But in this case, all using the robotic Metzenbaum scissors. Now, I'm asked often is that, can you fully debride the patients? And the answer is yes. In now close to 200 patients consecutively, we have never had to use the rongeurs or anything other than the Metzenbaum scissors, including all levels of severity of calcification, including LVOT calcification. This is able to completely evacuate any and all calcific material with thorough and meticulous debridement of the annulus without major issues. We utilize a blunt sucker tip to the wall that sucks out all calcific material. You can see the entire outflow tract through this visualization, and then sutures are then placed through the annulus in a circumferential manner, much like you would do in an open case. Our institutional routine is not to use pledgets, and so this is mimicked also in the robotic approach. We feel this safely allows for appropriate sized valves being placed. And it's very important to place as large a valve as possible. For the same reason, the TAVI experience has shown that larger valve sizes have better longevity. And so this is the implantation of a bioprosthesis. The sutures are secured with suture fasteners, and the aortotomy is closed using running 4-0 polypropylene suture in an identical manner to the open case to complete the RAVR. Postoperative echo, as one would hope and suspect that the outcome is similar to surgical cases. Patient was extubated in the operating room with no transfusions or inotropic support, with no paravalvular leak, with a mean gradient of 10 millimeters of mercury, and follow-up at 30 days, 90 days, and 1 year reveal asymptomatic New York Heart Association class 1, ejection fraction of 60%, and a gradient of 11 millimeters of mercury with this particular bioprosthesis. So we can approach valves that are bicuspid or tricuspid in origin at varying degrees and all degrees essentially of calcification, and using both mechanical as well as bioprostheses in the aortic position, as well as experience has been gained, combine this with other concomitant procedures such as mitral procedures, mitral repair, surgical ablation, even tricuspid repair, along with robotic aortic valve replacement. So to summarize, TAVI versus SAVR, for patients that are age greater than 65 of low to intermediate risk, SAVR is favored during shared heart team decision making for bicuspid valve disease until further data becomes available of safety, anatomic high risk features for TAVI, minimal aortic leaflet or annular calcification, and obviously all of this should be further informed by longitudinal evidence of superiority when comparing SAVR versus TAVR, particularly in these otherwise low risk cohorts that have excellent outcome with SAVR. Also, providing a non-sternotomy option for surgeons around the globe may facilitate patient and provider choice towards SAVR. Thank you very much for your kind attention.
My co-moderator, Dr. Girardi, will introduce Ismail.
Thank you, Vinay. It's my pleasure to introduce Ismail El-Hamamzi, who is the Randy Griep Professor of Surgery and the Director of Aortic Surgery at Mount Sinai Health System. He's well known for his pursuit and persistence and his outstanding results with the Ross procedure, and he's going to give us a talk on a Ross procedure renaissance. Thank you.
Thank you very much, Dr. Girardi. It's a real pleasure for me to be here with you today and to share some thoughts about the ROS, which I think not only has a big role in young adults in the Western world, but really has a huge role to play in countries where rheumatic heart disease is still very much prevalent and present, and young people are requiring aortic valve surgery. So let me try to expose to you why I think there really is a role for the ROS in non-elderly adults. I have no disclosures. This is the kind of case we're discussing: a 50-year-old, otherwise healthy individual with severe symptomatic aortic stenosis, normal ejection fraction, no coronary artery disease, and normal ventricular function. What would one propose to this patient? Well, a tissue valve or a mechanical valve are two good options, but I'll show you why in young patients they are associated with imperfect results. And so the first point of my presentation is that conventional aortic valve replacement in young adults is associated with excess long-term mortality, which is why we need to be looking for some alternatives. This is a study from Sweden where they looked at all patients undergoing aortic valve replacement. And what you can see is about 7 or 8 years after surgery, the mortality of patients undergoing AVR in the black dots, it becomes significantly higher than the age and sex matched Swedish general population mortality in white. And these are all patients of all ages. So one would perhaps, hypothesize that older patients are the ones driving this excess mortality. Except when the authors stratified the patients according to their age at the time of surgery, the youngest patients, those under the age of 50, had the highest observed to expected mortality ratio at 4.5. And in fact, the older the patients were, the closer that OE ratio was to 1. So in other words, the younger the patient is at the time of surgery, the higher that excess mortality seems to be. Well, you may say this is an old study. More recently, when I was in Montreal, we analyzed our data of mechanical aortic valve replacement in patients under 65, and we looked at almost 470 consecutive patients, of whom we excluded anything that we thought may impact long-term mortality. The mean age was 53, and the average follow-up was 9 years. And again, when we looked at the survival of these patients versus the age and sex matched general population, you can see there's a significant survival difference between the patients undergoing mechanical AVR, isolated elective mechanical AVR, versus the age and sex matched general population. Well, then we thought maybe it's anticoagulation. What about if patients do not need anticoagulation? Well, the Cleveland Clinic looked at their data. In that same study, we looked at survival free from reoperation after mechanical AVR. And at 10 years alone, a 50-year-old undergoing mechanical AVR had an 82% survival free from reoperation. In other words, 10 years after surgery, 1 in 5 of these patients are either dead or reoperated. And this was mainly driven by death rather than reoperation. So rather sobering results when you think about mechanical AVR. Well, in terms of tissue AVR, this is a study from Cleveland looking at over 2,500 patients undergoing a tissue aortic valve replacement. And this is another one from France looking at the same number. And if you look at the age of the patients in the x-axis and their survival in the black curves after AVR versus the age and sex matched general population in gray, you can see that there's a significant survival difference between the observed and expected survival of these patients. And the younger the patients were, the higher that excess mortality, similar to what I showed you in that Sweden study. This is another study from Scandinavia, over 3,300 patients undergoing isolated AVR. And again, patients under the age of 60 had a significantly higher observed to expected mortality. And the older the patients were, the closer that observed to expected ratio was to 1. And the last study I'll show you is the study from Joe Wu's group in Stanford looking at California-wide data, almost 10,000 patients undergoing isolated AVR at the age of 65. And they stratified the patients according to their age, 45 to 54 at the time of surgery. 15-year mortality was 26 to 30% if patients underwent a biological or mechanical aortic valve replacement. In other words, a 50-year-old undergoing isolated biological AVR had about a 1 in 3 to 1 in 4 chance of being dead by the age of 65. Really not great results, and I'm sure not what we would hope for our patients undergoing isolated aortic valve replacement. And the same was observed for patients between the ages of 55 and 64. So I would submit to you that aortic valve replacement in non-elderly adults is far from being a curative approach. It is at best a palliative approach. And that's why we need to be looking for alternatives. But if we want to look for alternatives, we first need to understand why we're seeing the success with that. And I think the answer is twofold. One is hemodynamics, and two is biology. And when I say hemodynamics, we really have to think patient prosthesis mismatch anytime we're doing aortic valve surgery, but particularly when we're doing aortic valve surgery in younger adults. We're now much more aware of this notion because of TAVI, but we have to be aware of it regardless of TAVI in the future. And why? Because patient prosthesis mismatch is a very prevalent issue, no matter how much we think we don't let our patients leave the operating room with PPM. Around 40 to 45% of our patients leave the hospital with some degree of PPM. And TAVI and PPM is relevant in terms of durability of the valve, but it's even relevant in terms of survival of the patients. But more importantly, in younger patients, it has a much lesser impact in older patients than younger. And the second point I mentioned is biology. The aortic valve is a lot more than just a passive open-close mechanism. It is a living structure that performs very sophisticated functions. This is just a cross-section of an aortic valve cusp. And the only thing I want to stress out is the similarity between this and a blood vessel. You see there's a layer of endothelial cells on both sides. There are cells within the body of the leaflet comprising smooth muscle cells, fibroblasts, myofibroblasts. An aortic valve cusp only measures about 300 microns in thickness. It opens and closes over 100,000 times a day, whether patients are resting or exercising. It is really a lot more than just a passive open-close mechanism. But going back to clinic, what that living structure and these complex functions mean is a perfect laminar flow through a normal trileaflet valve, excellent hemodynamics at rest and exercise, low thrombogenicity because endothelial cells prevent platelet aggregation, and good resistance to infection. And if we think about our patients undergoing AVR and what determines clinically relevant outcomes, such as survival, valve-related complications, or even quality of life, all of these features determine these long-term outcomes. So instead of thinking about a mechanical valve versus a biological valve as we normally do in clinic, I rather think of them as one and the same. They are both acellular, non-living substitutes with no potential for growth, repair, or adaptation. So what is the role of the Ross procedure in that context? Well, the Ross is the only replacement operation that guarantees long-term viability of the aortic valve and root. We now have explants 30 and 40 years after the Ross. And when we look under the microscope, we can see that trilaminar structure well preserved. So it provides unique biological and hemodynamic features to the aortic valve substitute. And the question is, does this translate into improvements in clinically relevant outcomes? 10 minutes is really too short to cover that. So for those of you who are interested, I invite you to read this state-of-the-art review that we recently published in JACC. We recognize some of the authors, Dr. David, Professor Yaqub, and others, that really covers the topic very comprehensively. I will focus on one single outcome in this presentation, that is survival. Survival is a binary outcome. You're either alive or you're dead. You can't be really half dead or half alive. And so it's a very hard endpoint to meet. This is the first study I'll show you, one of the few randomized open valve surgery studies in the literature, where Professor Yaqub had randomized patients to undergo a Ross versus an aortic homograft replacement. Young patients, the average age was 38, and the mean follow-up was 10 years, so pretty long follow-up. And these were all comer patients. As you can see, 8% had active endocarditis, and almost half of them were redo operations, with the most frequent previous operation being a homograft root replacement. And yet, at 12 years after surgery, survival of these patients was exactly identical to that of the UK Asian sex-matched general population, which was not what was observed with the Omicron. Well, this is Tyrone David's experience, and it's exactly similar. At 15 years, survival of his Ross cohort, average age 34, with an average follow-up of 10 years, is exactly the same as that of the Ontario Asian sex-matched general population. In fact, he updated his data recently with now a median follow-up of 18 years, a very long-term follow-up. And survival at 20 years was 89%, similar to the general population. Of course, there is patient selection. Otherwise, we wouldn't be doctors if we were not selecting the right patient for the right operation. But nevertheless, there is a way to restore survival in young adults undergoing aortic valve surgery. But one may think Yakub and Tyrone, these are exceptional surgeons, and they are. What about the rest of us? The Germans put their data into a national registry, 2,500 patients, 10 sites, average age 44 and mean follow-up of 11 years. Recently published it in JACC, and you can see that at 20 years, survival is still identical to that of the German Asian sex-matched general population. This is a study from Australia, a propensity matched analysis of Ross versus mechanical aortic valve replacement. Average age of the patients is 43 years. And you can see that at 20 years, there's a 10% survival difference between the two groups, which is quite significant. This is a more recent study we published looking at California and New York State data. We matched patients undergoing a Ross, a mechanical AVR, or a biological AVR, 434 patients in each group, with a mean follow-up of 12 years. The average age of these patients was 36. And you can see that at 15 years, survival of the Ross cohort of mechanical and tissue, or mortality rather, of mechanical and tissue AVR was just over 10%, whereas the Ross cohort had mortality that was similar to the age, sex, and race matched general population. Importantly, there was a lower rate of valve-related complications with the Ross versus biological or mechanical AVR. And last, what we looked at is third-day mortality after each of these valve-related complications to demonstrate that they're really not all created equal. In fact, if one had to choose one of the complications, reoperation seems to be the safest complication to have instead of stroke, endocarditis, or major bleeding. And the last study was this one from the Toronto group looking at Ross versus tissue AVR, 40 patients with a mean follow-up of 15 years. And again, survival or mortality was much higher with tissue AVR than it was with the Ross, with a hazard ratio of 0.35 for the Ross procedure. And also higher rates of reintervention, of structural valve degeneration, as well as pacemaker implantation. So these are all other studies from that review, all of them showing that same signal. So it really is the only replacement operation that to this day has been shown to systematically restore long-term survival after replacing the aortic valve. But what is the Achilles heel? I think it's twofold: surgical risk and durability. I'll show you my personal experience with the Ross because I think it can illustrate how safe this operation can be, even for someone starting a Ross program and someone with very little surgical experience. I started doing Rosses 6 months into practice. We're now up to almost 600 patients, with 15% of those being redos, 60% having concomitant procedures, and 6% being operated for active endocarditis. Operative mortality was 2 patients, which compares very favorably with the with conventional aortic valve replacement. Bearing in mind, both of these mortalities were in the first 100 patients, demonstrating the definite presence of a learning curve with this operation, but also the overall safety of it when performed systematically. And as you can see here, both mortalities were early in the practice with no mortality since that time. We also had more complications in the first 100 patients, more patients needing dialysis or re-exploration for bleeding, many fewer of those in the last almost 500 patients now. Importantly, the mean index effective orifice area is 1.5 square centimeter per square meter, and no patients had moderate or severe mismatch in the entire cohort. What about durability? Well, I think what we've learned over the last 30 years is that technique really matters when it comes to the Ross, just like we'll hear in a second about valve sparing group placement. All little technical detail, don't just translate into safety of the operation, but also translate into durability of this operation. So it's important to trim the autograft muscle, leaving no more than 2 to 3 millimeters below the insertion of the cusp, because we know this muscle becomes devascularized and necrotic and provides no structural support to the valve. It's important to implant the autograft deep in the LVOT so that the native annulus can support the autograft in the aortic position. We like to use single interrupted Prolene sutures and pass the sutures right at the hinge point of the cusp so that we totally exclude that muscle. It's important to trim the autograft about 2 millimeters above the commissures to avoid leaving any supracommissural PA tissue. And there are many more details, but time will not allow me to go into them, other than to say that if we follow all of these rules to the letter, the annual rate of reoperation for both left and right side is just around 1% per year. This is the German study. This is that California and New York study. And again, some of these operations go back to the late 90s, and we have improved the techniques since then. This is a propensity matched analysis of Ross versus mechanical AVR from Toronto, showing no differences in reoperation at 20 years. And this is my personal series showing a cumulative risk of reoperation of about 3%. At 8 years would be more accurate than looking at 10 years where there's fewer patients at risk. But certainly the operation is improving with technical modifications and is a durable operation, both in aortic stenosis and regurgitation patients. This is from that review. And again, all the studies show a reoperation range of about 1% per year. So what do we propose to this 50-year-old? I would argue that a Ross procedure is the best operation for him in order to restore his long-term survival, all the while keeping his valve-related complications lower and optimizing his hemodynamics. So I think the paradigm has shifted from the simple discussion of anticoagulation versus reoperation in these younger patients to first assessing, are we achieving normal survival and quality of life? So to summarize, the aortic valve is a living structure with multiple functions. In young adults, the goal is the long term. We have to stop thinking about 1, 2, or 5 year outcomes. We have to think about 15, 20, and 30 year outcomes. And in that sense, prosthetic AVR is associated with excess long-term mortality. And a pulmonary autograft with its unique biological and hemodynamic features seems to translate into restored late survival, better freedom from valve-related complications, excellent quality of life and hemodynamics, and can be done with similar operative risk. But all of this should be done in Ross reference centers, as we recently argued in this JACC editorial. With that, I would like to again thank both associations for the privilege of being here today and look forward to a very fruitful discussion.
Well, thank you so much, Ismail. As always, a wonderful talk and excellent video. We look forward to having some time for discussion. So to kick off the next presentation I have the pleasure of introducing my co-moderator, Dr. Leonard Giardi from Cornell. Dr. Giardi is the Wayne Isom Professor and Chair of the Department of Cardiothoracic Surgery. He'll be giving us an outline on his thoughts on valve-sparing root replacement tips and tricks. Leo?
Thank you, Vinay. Can you hear me okay? Yes. Thank you. So thanks to the associations for the invitation to speak this evening. I have no conflicts to report. The number of aortic root procedures continues to increase across the globe and here in the United States. This report from the JTCVS in 2015 documented the distribution of those aortic root operations reported to the STS database for the 5-year period of 2004 to 2009. Mechanical composite valve grafts were still the predominant type of procedure being performed, while the number of homografts and stentless prostheses declined in usage. However, both biologically stented composites and valve-sparing root replacement operations increased substantially over that time period, and those numbers have continued to climb. In high-volume aortic centers, however, mechanical composite valve grafts are being performed far less frequently. We published this data in 2015 in JTCVS. The number of biological composites and valve sparing procedures, as you can see here, increased substantially over that time. This is a reflection of the aging population undergoing more complex procedures like a BioRoot, and of our increasing comfort in performing complex valve sparing operations on all types of patients with aortic root disease. Now, looking specifically at valve sparing root replacement, there's a tremendous interest by those focused on these types of procedures to examine broader issues like the hemodynamic benefits of one procedure over another, reimplantation versus remodeling, or which graft gives the best results, a straight versus a Valsalva. I can see myself having a heated discussion with Dr. David shortly after this discussion. One might also talk about the interest we have in expanding indications into patients with much larger aortic roots, 6 centimeters, 6.5 centimeters, those with severe AI, bicuspid valves, or even in the setting of an acute type A dissection. Of course, and Dr. Ismail talked about this earlier, what discussion would be complete without a discussion on potential benefits of regionalizing complex procedures in high volume centers. Now, these are all very interesting topics, and nuances probably best discussed about this same time in New York over a single malt scotch. However, what is the most important issue when performing a valve sparing root replacement is how can one get excellent operative results and give the patient a durable result that will hold up over time, and that's what we're going to discuss this evening. Now, there are still some surgeons and centers out there committed to performing valve sparing root replacement with the remodeling technique as originally described by Mr. Yaqub. However, a majority of aortic surgeons believe this operation to be inferior as it lacks annular stabilization. And this compromises the long-term durability of remodeling when compared to reimplantation. Annular stabilization via external support is now more commonly being applied, and the longer-term outcomes of this modification of the remodeling technique will bear some follow-up in the future. However, the overwhelming majority of valve sparing procedures being performed are being done with the reimplantation technique, otherwise known as the David procedure. As such, we'll focus our attention this evening on the tips and tricks of this procedure that are crucial to achieve very low operative risk and good long-term aortic valve competency. Now, majority of the patients undergoing valve sparing root replacement are those with tri-leaflet aortic valves. And just as one relies on intraoperative transesophageal echo to guide the performance of a mitral valve repair, thoughtful interpretation of an intraoperative TE is crucial before taking on a valve sparing repair as well. This patient with a tricuspid aortic valve has little aortic insufficiency despite a markedly dilated root. In these situations, limited leaflet pathology is anticipated and minimal post-op AI is expected after valve sparing root replacement. However, when the TE shows a directional jet of AI either towards the anterior leaflet or towards the septum, one can anticipate leaflet pathology, and additional leaflet or commissural procedures may be necessary. And as demonstrated again and again, long-term outcomes when leaflet repair is required are not as predictable, and depending on patient age, comorbid conditions, or the need for additional cardiac procedures, it may be wise to abandon the valve sparing root replacement and proceed with a composite valve graft replacement instead. It's more reliable, shorter time, less complicated, more predictable. Now, once on bypass, we're going to go over some of the tips and tricks, but once on bypass and arresting the heart, we excise the aneurysm, mobilize coronary buttons. Here's the right, the left is behind the pickups here. And then we take a look at the leaflets looking for any obvious pathology like significant fenestrations or significant prolapse or degeneration or even a perforation that might dissuade one from continuing on with the valve sparing procedure. The next step is the development of a circumferential subannular plane that will serve as the attachment site for the Dacron graft. Here we're developing that subannular plane behind the left sinus. We like to do this with sharp dissection. We don't use Bovie electrocautery for this type of mobilization. And what we're looking for when we get back there is markers of appropriate depth. We like to see this yellow line that signifies the annulus on the outside. We also like to see the posterior ventricular wall, as you can see the muscle here. The similar plane is then developed along the right coronary and non-coronary cusps. Here we're developing that plane underneath the right coronary button. You can see the right ventricular muscle here, And once again, you'll see this yellow line that signifies the annulus. That's the appropriate depth that you need to get to have an appropriate level of suturing for the Dacron graft. We then reassess the aortic valve again to confirm the integrity of the leaflets before moving forward with subannular stitches. We then look at the commissures in the LVOT, make sure there isn't any additional pathology down there that might require attention. The diameter of the annulus is then estimated with a Hagar dilator. And we use a Valsalva graft that is 5 millimeters larger than that dilator that comfortably fit into the annulus. While the OR staff is opening the graft, we confirm the location of the single horizontal plane along which we will place our annular sutures. And this dashed line shows that plane here. We also measure the commissural height from that line of annular attachment up to the top of the commissure. This is particularly important in this region along the attachment of the anterior leaflet, as well as looking and keeping out for the membranous septum as we come and suture around this edge. We then like to place circumferential, non-pledgeted horizontal mattress sutures along this single horizontal plane in the LVOT, taking care not to scallop the sutures, which can lead to uneven subannular attachment or subvalvular attachment of the Dacron graft. And certainly there are groups out there and others out there who espouse the use of 1 or 2 sutures only at the nadir of each sinus, but we prefer a circumferential suture line. It better stabilizes the annulus for the long term while also adding a second layer of hemostasis beneath the primary hemostatic suture line of valve reimplantation. We then take our Valsalva graft and mark our previously measured commissural height from the ST junction of the Valsalva graft down to a line that we print along the entire circumference of this graft. As you can see here, we're putting that line in place. We then go ahead, as you see in the previous slide, and I'll stop this here just for a second, but you can see that we make, in addition to the line where the annulus is going to attach, we make a U shape, and we outline that in each and every sinus. We want the reattachment sites for reimplantation to be more shaped like a U and definitely not shaped like a V. When it's shaped like a V, it will shorten the annular attachment site of the leaflet, which will ultimately lead to prolapse. And that's certainly not going to contribute well to long-term patency or competency of the valve. We then cut off the bottom of the skirt. We really don't use that unless we're making a biological composite valve graft. But it's important that we have these U's, as you can see them here. It really helps guide your suturing from inside the graft, or sometimes, depending on the depth of the graft, it can be a little difficult to make sure that you're following the path that you're supposed to get a good U-shaped reimplantation. Now, when tying the annular sutures, it's important to tie these over a dilator, particularly when using a circumferential suture line like we do. Without the Hagar in place, one can get a really inappropriately tight annuloplasty. And we also emphasize for our fellows that we want to tie these snugly, but not too tightly like we do for an aortic valve replacement. Without pledgets, one could easily pull that stitch through the ventricular septum or the muscle in the back wall of the heart and create catastrophic subannular bleeding. Now, after we finish tying the subannular sutures, we then make a quick visual inspection of the valve and leaflet coaptation. Now, even before we secure the commissures, leaflet coaptation usually looks like this when we anticipate a successful valve sparing procedure. You can see pretty good coaptation even at this point in the operation. Commissural reattachment is then the next step. We do this with 4O Prolene horizontal mattress sutures with Teflon felt pledgets on both sides of the reattachment site at the ST junction of the Valsalva graft. If these collapse, certainly valvular insufficiency will ensue, so we make sure these are secured properly. And then we also reinforce the tops of these commissures with our reimplantation suture line as well. Here is such an example of where we've completed the reimplantation of the left coronary sinus. And now we're bringing that suture up to the top of the commissures. We're taking that pledget that we use to resuspend the commissure, and we're sewing through it 2 or 3 times, securing it to the tops of the graft. Again, we're pretty uptight about making sure that the commissures have absolutely no chance to collapse. This video shows the completed valve reimplantation. That certainly gives one confidence when you have this appearance, and one would expect a coaptation length of more than 8 or even 10 millimeters when the valve has this appearance. Now, there aren't any real tricks to left coronary reimplantation except to say that when in doubt, place the button in the middle of the sinus. The Valsalva graft is nice in that it gives you a little extra flexibility with respect to the length of the left main. And so coronary ischemia is rare when we perform this procedure with a Valsalva graft. Now, like mitral valve repairs, we first proceed with the saline test to give us our first glimpse of valve competency. The level within the graft should not drop during this test if the valve is working properly. However, more importantly to us than having a nice column of static saline is a technique we've been using at Weill Cornell for the last 2 decades to assess the valves we have reimplanted. We secure a Foley catheter with a 30 cc balloon to the end of our Octopus cardioplegic delivery system. We then place the Foley inside the graft and begin delivering cold blood potassium cardioplegia at a rate of about 300 cc's per minute. If the valve is competent, as this one is, one can fill a firm graft and see the sinuses bulging. This also allows us to inspect the left main suture line as well as the annular suture line for hemostasis. Also reassuring is with a competent valve, we also expect a significant drop in myocardial temperature as we deliver this dose of cardioplegia. When we see it crashing down like here, we know we have a good competent valve and we're getting good coronary perfusion. It's very reassuring. Once we've confirmed valve competency with the Foley test, we then touch up any areas in question with 5-O-prolines that are horizontal mattresses like this. Any little gaps you want to sort of get rid of and not want to worry about once you take the clamp off. So this is sort of a belt and suspenders approach. The sutures are all tied on the outside. There's no knots that could potentially compromise the valve leaflets as they open into the sinuses. We then perform the distal anastomosis. We reimplant the right coronary artery last, make sure it's of the appropriate height, and that's best done with the distal suture line already intact. The end result should be a competent native valve, as seen in these post-op TEEs on both the long and short axis views. Forgive the bubbles, we're still de-airing when we're looking at this. This also is time for us to measure the coaptation length, which has been shown to correlate quite well with good short and long-term valve competency. Now, these are the results from our 2015 JTCVS paper examining outcomes for 3 different root procedures: biovalve roots, mechanical roots, and finally valve-sparing root replacements in the 3rd column here. The results for this relatively young and highly selected population undergoing valve-sparing root replacement are excellent. Operative mortality remains at 0, a stroke risk of less than 1%, and the operation, as has been described by Dr. David, it's very hemostatic, and our 3% re-expiration rate supports this, even though 20% of this group underwent an operation with concomitant circulatory arrest. Our propensity match comparison of valve-sparing root replacements to composites is also consistent with published data by others showing an increase in the need for reoperation out to 5 years with some valve-sparing procedures. Now, the reoperation rate isn't markedly different from a biological composite valve graft, but it is significantly higher than those having a mechanical composite. As we get more experience with this operation, I think this will probably drop, but this will, this is going to require very careful follow-up to make sure we understand the long-term results. So in conclusion, valve-sparing root replacement, like all root procedures, is being performed with increasing frequency. As we gain experience with the technical aspects of the procedure and as we learn how to select the patients likely to benefit most from this complex operation, the outcomes are excellent, particularly in higher volume aortic centers. On the technical side, annular and commissural stabilization are crucial to the short and long-term outcomes, and it's why many favor the reimplantation technique. We are firm believers that the Valsalva graft facilitates the accuracy of this procedure, but it also promotes a less steep learning curve for our trainees and for the junior faculty who are trying to master this very challenging operation. Finally, in-depth analysis of our results using 4D flow MRI will help us better understand the optimal configuration of this operation and also lead to greater insight into the downstream impact this procedure has on wall tension, longitudinal wall stresses, and how this might impact descending dissections and aortic growth in the future. So I thank you for your attention and return you to Dr. Badwar for our panel discussion. Thank you.
Well, thank you so much, Leo. It was an outstanding presentation and a great lesson to our audience and participants as we publish our best work in our journal in the JTCVS. shameless plug as an associate editor, of course. But as we now enter into our discussion panel, as you know, we're a little bit behind, but I wanted to ask and just kick this off and first welcome Vaughn Starnes and Joe Wu to join us in the panel. And really ask both yourself, Leo, and Ismail on surgeon barriers as we look across the globe and in India as well, and we try to advance technology and techniques. What do you see as the individual surgeon barriers for either valve-sparing root replacement, starting with you, Leo, and then to follow Ismail on the Ross versus other types of surgical valve therapy as we look to improve innovation across the globe? Leo?
I think certainly as more experience was had over time with the exclusion, Bentall people became more comfortable with sort of detaching everything and being able to see things as well as you possibly could, so that you could control bleeding and have a lot more impact on the postoperative hemostasis. And I think it's just experience. It's a real leap of faith to do a reimplantation. I remember the first few that I did. It's nerve-wracking and you really worry. But Dr. David was right. It's a very hemostatic operation if you pay attention to the details and you sort of follow the basics of making the commissures as high as you can and making sure you have good hemostasis at the reimplantation suture line. Most of the time it works out pretty well, but it is a real leap of faith. And don't start with someone with a 6.2 centimeter root and 4+ AI. That's probably not the learning curve you want to have. But similar to a Ross, it's very technically demanding, and it does take a good learning curve to get better at it. So at some point you sort of step over the threshold and then you just keep moving ahead.
Well, that's an excellent response. So case selection and fortitude. So I suspect, Ismail, your response will be somewhat similar. And I mean, you make the compelling point of curative versus palliative, and how has that been going as you try to proselytize Ross procedures across the globe and the adaptation?
I don't know that I'm proselytizing, but I think what it takes is trusting the evidence and trying to get away from the perceptions and that notion that has been circulated for so many years now, that the double valve disease, all these notions, which were true at a time, but I think now time has proven that if the operation is done properly and importantly in high volume center with expertise, that the results can be really outstanding in the long term in carefully selected patients. And so it's first trusting the evidence, and secondly, for whoever is interested in starting a program, it's having a dedicated aortic practice, aortic root reconstructive practice, because a lot of the technical details that come with the Ross are shared with a valve sparing or a Bentall operation. So at the end of the day, the Ross is a glorified Bentall. There's really not much more to it. But there are a lot of details, and unless you do this on a very regular basis, you will fall into some of these traps occasionally. So that's really part of the story. And like we say, a reference center is not just a good surgeon. It takes good anesthesia, ICU, perfusion, imaging, cardiology. There's a whole team that needs to be there for the results to be optimal in the short term.
Well, very good. Thank you. Vaughn, any comments on that question from your perspective on barriers?
Well, I think Ismail gave a very nice presentation. I think what we're all really saying as we do more and more Ross is it has to be a supported Ross of some fashion. The root implantation without support obviously produced AI over time with aortic root dilation. So I think if you're going to do it inside the aortic root, you have to have careful matching of the aortic sizes. And I would be interested in Ismail telling us about what aortic size may be too big for the Ross, or like we have done, gone to a supported type of Ross procedure, almost like a Bentall operation, to try to, I've done that mainly to try to get more people to use the Ross, because you've got the autograft on the back table, you sew it inside a graft and then put it down in the aorta. Makes it a little easier than trying to do it sort of inside the aorta. So I'd be interested in your comments, Ismail.
Sure, thank you. I think the what you said is absolutely true. I think a lot of people have taken the Ross up since the notion of putting it in the Dacron graft, that has made a lot of people very secure doing it because it feels more familiar than just dealing with the autograft. The way we approach it is to divide the loop into annulus, sinuses, and sinutubular junction instead of putting it in the Dacron graft to try to mitigate any annular SCJ dilatation, all the while trying to preserve as much as possible the dynamism of the sinuses. So anytime there's mismatch or anytime the predominant lesion is AI, I'll do an aortic annuloplasty, an extra aortic ring annuloplasty, which is very similar to a reimplantation procedure, except the Dacron is only 4 or 5 rings high. And the idea is to make sure that we match the size of the pulmonary and aortic annuli perfectly. And that stabilizes it and it prevents dilatation long term. At the STJ level, we interpose a short Dacron graft anytime there's the slightest mismatch between the native ascending aorta and the STJ of the autograft. And that also stabilizes. And then I use the native non-coronary sinus wall and the left-right commissure lift to jacket the autograft from the outside. And last but not least is blood pressure control for the first 6 to 12 months. We don't let the systolics exceed 110, 115 to really allow the autograft to adapt to this systemic pressures and avoid any early dilatation, which we know begets later dilatation.
Well, that's excellent. To now turn it over to our co-moderator, Shiv Nair, representing the Indian Association of Cardiothoracic Surgery. I believe there's some questions from the audience that you'd like to ask. Dr. Nair.
Thank you, Dr. Badwar. First, I would like to thank AATS and all the presenters for this session, Dr. Badwar, Dr. Kirati, and Dr. Al-Hamzi for this late hour sharing your experience with us. The question is, one of the questions is the impact of paravalvular leak. As we all know that even in India now, there is an indication creep, the term used by Dr. Moon on the increasing number of TAVRs being done as compared to surgical AVR. But this issue of paravalvular leak, which was shown to be 33% versus 6%, it seems to be kept on the back burner. What is your opinion? How do we assess whether this paravalvular leak is going to have any, following TAVR is going to have any impact on long-term outcomes?
That's an excellent question. I'll start with that, and maybe I'll have Dr. Wu also chime in. There's some early evidence, particularly published also in the JTZS as well as in JACC, that, as you rightly know from the question, that at least when there's 2+ paravalvular leak or greater, there is a significant impact, not just on valve reoperation, but also survival. And I think this is what this is all about, is as we start to come up with innovations and think about the use of the heart team, particularly with lower and lower age and lower risk, that we have to be very well focused on not just short-term follow-up, but longitudinal follow-up with these patients. And well-functioning heart teams do have that embedded. Dr. Wu, would you like to provide your thoughts?
Yeah, I would just say that as a SAVR-only surgeon, I'm always looking for reasons to knock TAVR. And so paravalvular is another one of the many, including pacemaker and thrombosis, et cetera, that I like to bring up. But, our good friend Vinar Thirani actually published some of this in the Lancet and also showed that any sort of paravalvular leak does have an impact, negative impact on the outcome of the patients. Having said all that, I think technology, the advancement of technology, both in the devices and the imaging, will progressively lower all of these problems, pacemakers, paravalvular, et cetera. And so those devices and the TAVR arena in general will get better and better and better.
Now, I know we have a limited time. Dr. Nair, do you have additional questions, or can I turn it over to the rest of the panel?
Please do.
Dr. Al-Hamzi, Ismail, any additional thoughts on PVL and how are things, how does that impact choices and risk, particularly on selection of valve disease? And I ask that based on now not only indication creep, but etiology creep, as we're starting to have bravado now approaching bicuspids and LVOT calcification, and not always looking into the details of that pathoanatomy, but realizing it after the fact? How is the things being approached at your center in Mount Sinai?
Oh, thanks, Vinay. I think, like you said, it's all about the details which really matter. And it's also about realizing that the horizon we're interested in, the younger the patient is the long-term horizon. It's not just 30-day, 1 year or 2 year outcomes like the data shows us in the low-risk patients. So the younger the patient, the more perfect everything has to be and more controlled. And I think it's not a perfectly controlled environment yet. We still get caught with PVL and left bundle branch blocks or pacemakers. And so until we've resolved some of these issues with the advancement of technology, we have to be very careful in applying these. They can be done very safely in these young patients. So that doesn't become the question anymore. And we have to move the conversation from can we do it safely to how effective is it in the long term. And each and every one of these elements, PVL, pacemakers, etc., has been demonstrated to be associated with not 10 or 15 year mortality, but just 1 and 2 year mortality in these patients. So we have to be very thoughtful before, letting age creep and etiology creep and indication creep into the TAVR world. So we try to be as selective as possible and careful and a team approach at Sinai when we see these patients.
Thank you. Leo, in your institution, how can you maybe comment on the functioning heart team, and with your surgical expertise combined with the transcatheter expertise, how does this type of indication creep, etiology creep get managed in your institution? And any thoughts for our Indian colleagues on heart team sort of re-emphasis?
Well, we sort of take the trust but verify approach to things. There is a lot of indication creep throughout New York City. I think Ismail could back that up for sure. I see a lot of patients with bicuspids who've all been told they should have TAVRs. Most of them are pretty young with very low risk, and more of them than I would like to see have significant aortic dilatation that is somewhat being ignored. I think the other thing that I think is interesting for me when I think about TAVR is one of the things that I've been alarmed by is looking at these perivalvular leaks and how they're being chased down an interventional pathway simply because there's some literature out there suggesting that a TAVR explant followed by an AVR is just an extraordinarily high-risk procedure. And I'd be interested in the other panelists' comments on that, because truth be told, I just haven't found that to be that difficult an operation. And it doesn't matter whether it's a core valve type valve or a sapien type valve. With a little care and just making sure you get in the right plane and get the percutaneous valve out, it's really not much harder than an AVR, and it's certainly a lot easier than a reoperation that we've all done 100,000 times on a previously placed surgical valve. So I'd love everybody's thoughts on that, because it's alarming to watch these people get chased with these PVL type procedures.
Well, I mean, you're bringing up what I was going to make a comment on for our, just as we wrap up this discussion, is that really, at least in the United States, as Dr. Girardi just highlighted, but also perhaps in India as well, that we're seeing a new operation that is becoming more and more common, and that is TAVR reoperations. As we have age and indication creep, and we have PVLs, and we have other complications, HALT and other issues, particularly in these younger patients, that a valve-in-valve TAVI or TAVR, or a percutaneous coil or Amplatzer or plug put into a PVL obviously is not ideal. And surgeons are becoming more and more well-versed in its operation, as Dr. Girardi just outlined. Maybe Dr. Wu, have you taken out some TAVRs and any other additional pearls to outline for us?
Yes, they're usually infected and they usually fall right out.
Short and sweet. That's great. Ismail?
Yeah, I agree. I think it's I think the point I'll make, though, to Dr. Girardi's point is that it's easy in his hands because it's a high volume center. I think when we look at that 15% mortality data, it's all across the US and you have high and low volume centers. And they're easy operations in experienced hands because you know the planes and you know how to address things. I think they can be a bit more treacherous in less experienced hands. So again, reinforcing the notion of high volume centers and regionalization and concentration of care for these particular operations.
Thank you. Vaughn, any last comments as we wrap up the session?
Yes, I think just one quick comment. I think taking those valves out, and I've taken out several of them now, is I would start in a non-coronary sinus because I think the key to the operation is not to injure the coronaries. And if you get into that plane, it's an easy plane then to start dissecting around. I also dump some ice on it because it does help the metal to collapse down pretty easily. So those are a couple of the techniques I use.
With the nitinol frame, yes, absolutely. Well, this has been an excellent session. Thank you all. Thanks to the panelists. Thank you to our co-moderator, Shivnir from the Indian Association. And I wanted to thank not only the AATS Foundation, but also Edwards Life Sciences for sponsoring this excellent session. And we'll be turning it over to our technical moderator here as they present a video from Edwards Life Sciences. Thank you all for your participation.
On behalf of the AATS and my co-moderator, Dr. Iyer, I want to welcome everyone back to the final session of the Cardiovascular Valve Symposium. For this session, we are so fortunate to be joined by Dr. Vaughn Starnes, the chair of the Department of Surgery at USC and a once-in-a-generation world-class technical surgeon and clinician who both is an expert in adult and pediatric heart surgery, valve surgery, and just about any type of cardiovascular surgery. And today, he's going to talk about valve options in children.
Thank you, Joe. Thank you, Joe. And I'd like to thank the association, both the ATS and the Indian Association of Cardiovascular Surgery, for allowing me to give this talk. I'm going to talk about the non-thrombogenic aortic valve surgery in children and special considerations. So in a child, one of the things you have to take into consideration is the child's somatic growth and the need for growth of the aortic valve itself. When we talk about patient prosthesis mismatch, we usually talk in adults about a valve that's too small. In infants and neonates in particular, you have valves that are too large. And obviously in children, you got to think about the concern of prolonged anticoagulation, which is a real problem for children to take anticoagulation over time periods. And it's often problematic due to absorption and other issues. And obviously we have rapid deterioration of heterografts in the very young. So if you look at the causalities of aortic valve disease in children, congenital bicuspid aortic valve is the most common. It often presents as critical aortic stenosis, particularly in the neonate. It is the most common indication for intervention in the United States. Other lesions, such as Schoen syndrome, that affects the LV cavity and also the LVOT and aortic valve, is also seen very frequently, and of course, interrupted aortic VSD. We do see truncal valve quite a bit and truncuses. And a lot of these are quadracusp valves. They can be leaky, they can be stenotic. So another causality of truncal valve stenosis or insufficiency. And you see endocarditis, and of course in developing worlds developing countries around the world, we still have rheumatic heart disease to consider. So in the beginning, I think one would approach the valve as in to save it, and we look at ways of the early stenotic valves in children as aortic valvotomy approaches, balloon versus surgical. The other issue, if we can't do a balloon valvotomy or surgical valvotomy, we look at ways to do valve repairs. That'll be a leaflet reconstruction or leaflet extension, or more commonly now in the Ozaki leaflet replacements. If those techniques are not available or there's been multiple operations, we go to obviously the aortic valve replacement, usually with a mechanical valve in a child. And of course, we'll talk later tonight about the Ross procedure that we heard in the earlier session as an ideal operation for children. So if you look at aortic valve stenosis and aortic valvotomies, I think initially balloon valvotomy is indicated in isolated predominantly stenotic valves. If you look at percutaneous versus open surgical techniques, today in the United States, the predominant first line approach has been balloon valvotomy, although there's now data I'll show you that says possibly surgical valvotomy is preferable in terms of long-term outcome. Balloon valvotomies are more successful in trileaflet valves with fused commissures, although in the neonate, it's usually a bicuspid or even a unicuspid valve. And we often end up with a fair amount of aortic regurgitation after balloon valvotomy. It is not a great option in restricted small annuli. In those circumstances, you usually do not get a great result. But again, as I say, in the United States, particularly port ventricular function balloon aortic valvuloplasty is the most common modality. If you look at the outcomes of balloon aortic valvotomy and you look at significance, freedom from significant AI over time, as you've seen in this study, is that at 56% at 5 years only of significant AI, and only 49% at 10 years, so the need for reintervention. And freedom from valve reintervention as a valve replacement was only 84% at 5 years and 70% at 10 years. If you look at surgical valvotomy, a couple things that obviously you have to take into consideration is the need for cardiopulmonary bypass and cardiac arrest to do the procedure. However, from the price you pay there, you do get a controlled, complete valvotomy, and you have the ability to address other lesions if they exist. And Raska's study, he found that over a period of time, if you look at surgical valvotomy, the freedom from aortic valve replacement was 93%, 83%, and 68%, and 57% at 5, 10, 15, and 20 years. So at 10 years, 83% of these children did not need a valve replacement if they underwent a surgical valvotomy. And again, tricuspid valve morphology obviously demonstrated 100% freedom from AVR at 20 years. Again, comparing surgical valvotomy with balloon valvotomy, the group Schindler et al. Looked at 52 surgical versus 51 balloon at a mean follow-up of 13 years. And sort of surprisingly, operative mortality for balloon valvotomy in this group was 7.8% and 3.9% for surgical valvotomy. The 10-year survival rate for balloon valvotomy was 88% and 94% for surgical valvotomy. Obviously, again, sort of proving or demonstrating that surgical valvotomy might be the preferable choice, although not the commonly performed procedure, particularly now in the United States. And I would say that in our own experience, we have superior long-term outcome if we do a surgical aortic valvotomy in terms of need for further valve surgeries. So when do you consider a valve procedure or a valve a leaflet modeling technique? Well, you do that when the valvotomy has been inadequate, the annulus is of normal size and you've got AI, or you've got valve morphology that is amenable to repair, either a single leaflet pathology and the leaflet's non-calcified. So these are the factors associated with shorter freedom from aortic valve interventions. Presence of moderate or greater AS at the time of surgical valvotomy had a 5-year freedom from reintervention of 33%, versus you didn't have significant AS, it was 70%. And if you look down below, if you look at the various techniques of repair versus valve replacement, repair is certainly superior to valve replacement. But giving you a peek into my future presentation here, Ross procedure was superior to either one of those. So one of the topics of discussion now in the literature is the Ozaki procedure. This technique can be applied to several pathological conditions, particularly those lesions where we don't have a pulmonary valve like truncuses, or situations where we have a single leaflet involvement. The advantage of this procedure is it allows for continued annular growth because we have a lot of redundant tissue that we place in the valve leaflets. It does not necessitate long-term management of anticoagulation. As I've pointed out, you can use it as a single or multi-leaflet option. It's applicable, obviously, to patients like truncus that don't have a pulmonary valve. But I think the primary challenge of this operation is still the longevity of the leaflet tissue that we use to reconstruct the leaflets from, whether that be autologous pericardium, photofix, bovine pericardium. I think we're concerned about the durability of this repair over time in young children.
Hey, Vaughn, can I ask you a question while we're waiting?
Sure.
Have you seen any issues with photofix?
Of the types of leaflets that we have gone to, that has seemed to be the better one. Obviously, autologous pericardium is the one we prefer. The photofix does tend to get thickened over time, much quicker than obviously autologous pericardium. But I think all these valve leaflet replacements, I have concern about whether or not they're going to be durable, because we know the heterografts in young children are not very durable. So this is sort of a study that one of our current faculty members did while he was in Great Ormond Street, where they looked at the durability of the repair as it related to whether it was bovine pericardium or autologous pericardium. And what they found at GOS, looking at about 58 children, is the materials performed equally, but at 1, 2, and 3 years, they had 94% freedom from significant AI or reoperation and 79% at 3 years. So I think what we see in children as compared to Ozaki's original information in adults, that the heterograph and the pericardium and the Ozaki does deteriorate fairly rapidly over time. And we still have early data. We've done about 10 of these patients at Children's, and so far it looks like our curve is going to be about the same, that we're going to have about a 50% failure rate at about 6 or 7 years. Next slide. So again, if we're going to do aortic valve replacements, it's usually in this situation, again, late truncal valve lesions, multi-valve repairs, and poor LV function, or a failed Ozaki or Ross. Next slide, Ramsey. Let's go ahead and skip that slide. I'm running behind a little bit. So obviously, we think in children in particular that the Ross procedure, I think, is the ideal procedure, particularly in neonates and infants, where we use it as an unsupported autograft. It allows for growth over time. It's an ideal choice in this age group. And in fact, that they do not do well with Coumadin. We use it in children where we can't either do a balloon or a surgical valvotomy or repair the leaflet. And it's obviously considered in, I think, all young adults, as Dr. El-Hamzi presented earlier. Next slide. This is our experience at Children's Hospital. We've operated on 307 children since 1992, and we've operated as early as 2 days out to 22 years. We've performed 21 neonates, it's less than 30 days of age, and 40 infants. Children between 1 and 18 years, 232, and adults 18 to 22. The median follow-up of 6 years. As you can see, there's been very nice growth in this early young age group. This was a report out of Asian Cardiovascular Society, and we've paralleled this data with our children. The annular growth does parallel the somatic growth, so it's just not aneurysmal formation. Next slide. If you look at the overall survival, it's 92% in our group out to 15 years. And I would dare say that's much superior to any mechanical or bioprosthetic valve that we might try to use. Next slide. If you look at LVOT reinterventions, what we found, it was fairly age specific. And this was really before we started doing any kind of supported Ross. And this was really the stimulus for us to look at how to better support the Ross or the autograft. We've found that in other than infants and neonates, particularly in the young teenage group, that the root did dilate, and we had about a 25% failure rate at about 10 years. Next slide. So on the basis of this observation, we began encasing the autograft in a hemoshograft. And we did this in 52 patients older than 10 years of age, and we improved the 5-year freedom from reintervention on the autograft from 81 up to 91%. And that was a group that we followed out as long as 15 to 20 years. And freedom from replacement of the valve at 3, 5, and 8 years was 92% at 3 years, 86 at 5, and 86 at 8 years. So we had a plateau that we got beyond 5 years, it still stayed the same out over time. So the autograft was very stable at that point in time. If you look at obviously the pulmonary homograph that we had to use in the pulmonary position, it's inversely related to age. The younger the infant, the quicker the homograph had to be replaced. And this is not a surprise to anyone, because if you do a pulmonary homograph in a 1-year-old, you usually get 3 to 5 years out of it before you have to remove it and use a larger homograph replacement. Next slide. This is our neonate and infant experience. I thought was quite interesting. This is in all of our neonates and infants over the last 27 years. We had 58 of these, median age of 63 days. If we did a ROC analysis on it, and we found that age less than 84 days was an inflection point for mortality. If you studied it more carefully, what you really found that 84 days, if you operated on patients with Shone's complex, that is concomitant mitral disease, small LV cavity, that's really where the mortality occurred. And we believe in that particular group, we actually go to a single ventricle type palliative approach as our initial operation, i.e. a Norwood type operation, to get the child out to an older age before we consider doing the aortic root replacement. Beyond 84 days, we had excellent survival rate, as you see up top. Next slide. If you look at the neonate experience, what was really rewarding is that we had freedom from autograft reintervention of 98%, 96%, 96% at 5, 10, and 15 years. So operating on these very young children, putting the Ross autograft in, it was a very durable repair over time. Obviously, we did have to go back and change out the pulmonary homographs, but that was not a big price to pay for this autograph's superiority. Next slide. So this is a patient that I performed a interrupted arch VSD on in a newborn period. This child is now 2.5 years of age with a very stenotic aortic valve. So it's a complex redo operation that we went back on and did a Ross procedure in. This is opening up the right ventricular outflow tract and getting prepared to enucleate the pulmonary valve. This can be somewhat complicated in a redo situation, mainly because where the VSD patch is, the autograft sometimes gets very closely adherent, but oftentimes you can get the valve out very successfully, as we did here. The valve's a little bit thickened because of the turbulence from the VSD patch, but was very, very usable. Again, this is our autograph. As you put saline in it, very, very competent valve. Sew this valve into place. I use a running stitch in these children, 5-O-proline usually. This particular child had a slight root enlargement because of a very small left ventricular outflow tract, so we did do a cono in association with this autograft insertion. Obviously, this is the implantation of a left coronary button onto the autograft. This is the completion of the operation, the pulmonary homograft put in the RVOT. So I think in summary, valvotomy, obviously, I think is preferred in the first stages of addressing aortic valve pathology in neonates and young children. I would submit that as we accumulate more data, I think surgical valvotomy, although requiring cardiopulmonary bypass, may be superior in terms of long-term outcome. I think our valve repair techniques are improving every day. I think leaflet extensions, Ozaki with leaflet replacements, do have an important role to play and when you operate on children. I still believe the Ross procedure is the ideal procedure, particularly with children with competent pulmonary valves. And I think, where we have truncal valve pathology, the Ozaki procedure may be the procedure of choice initially until we get the child out to a much older age where maybe taking Coumadin will not be such a big problem. So thank the association for allowing me to present this. I'm sorry we had a little glitch with our slides, but thank you.
That's great, Vaughn. Will you be able to stay and participate in the discussion, and we can ask you some questions then?
Sure.
Great. Okay. Wonderful. Okay, so I've been asked to talk about non-thrombogenic replacement, the growing evidence for biologic valves. And I have no disclosures. I do have some biases, and this is just one example. This is an opportunity I had to go to India and operate. And here I'm doing a minimally invasive mitral valve repair. My biases are basically to repair whenever possible. And this is just another example. This is a valve-sparing aortic root replacement, even in the setting of multivessel coronary artery disease requiring CABG, where I've done a valve-sparing aortic root as the preferred option. This I did in Malaysia. So it gets me to think about what I describe as the biologic replacement ladder. So whenever possible, I think the best thing to do is to retain the native tissue. We heard some great talks in the last session and a great talk just now on different options in the aortic position. I think valve repair is outstanding there, and we're all learning how to do that better and better. And obviously in the mitral position, mitral valve repair is ideal. When that's not possible, then perhaps replacing with living tissue is best. I like to do the Ross with the technique that Dr. Starnes described. I think that gives you great support in the adults. I haven't tried a mitral Ross, so perhaps we can ask Dr. Starnes about that later. The next option would be to replace with pericardium, such as the Ozaki or partial Ozaki, as you heard about, and pericardial leaflet reconstruction in the mitral position. And then, if not, go to bioprosthetic valves, surgical or transcatheter, and then finally replacing with mechanical. This is sort of a biologic replacement ladder and a way to think about how to approach both the aortic and mitral position. When you get down to it, it's always this argument, more reoperations versus more bleeding and stroke. And many, many years ago, there was at least one of these prospective randomized trials. I really doubt that we're going to have a lot more of these types of trials where we randomize patients to mechanical versus biologic valves. So we have retrospective data and various statistical methodologies as the way to examine and generate evidence. In the 2020 guidelines, there were a variety of changes regarding biologic and mechanical valves. I won't go into those because you can look those up, but I thought one of the most interesting things was this table that was added, which was not necessarily a guideline recommendation, but it did show some other considerations that should be taken into account. And if we just look at the bioprosthesis column, look at some of these comments: access to surgical centers with low reoperation mortality rate, access to transcatheter valve and valve replacement. You know, these types of things are now making it into the guidelines, albeit not as a specific recommendation with evidence support, but something to consider. So when we think about data, we have to realize that sometimes we're really looking at this as opposed to this, i.e. if we're looking at 15, 20-year data, we're looking at older generation devices. And we're not even taking into consideration this. So this is a moving target. And so when we're presenting evidence, we're really trying to look at older generation valves, newer generation valves, and then even trying to think about what the future generation techniques will be. We took a crack at this with the California data. We looked at 20 years worth of valve replacements in the entire state of California, all 142 centers that conduct cardiac surgery. And what we found was that the difference between biologic and mechanical, as expected in aortic position, sort of crossed the line right in that sort of 53-year age group. And this really didn't have a lot of impact on the prior guidelines, but this was an interesting finding that in the mitral position, because of relatively high mitral reoperation mortality rates in our state overall, this crossover didn't occur until age 68. And that did actually have some impact. So mitral valve mechanical replacements, at least, are potentially favorable up until a later age, given the reoperation issue. Now, this is looking at the mitral position. This is Joanne Chikwi together with David Adams. And really, they found no difference looking at all of the New York data. And this is sort of the standard bleeding versus reoperation. And you can just see the blue and the orange lines flip. This is a large meta-analysis conducted by some of our friends at the University of Sydney. And what they showed with this very, very large meta-analysis is that really there wasn't a difference overall long-term. This is the forest plot showing essentially really no difference across all of these for the most part, except for when you stratify by age less than 65. This is another study that was conducted in Europe, looking at isolated aortic valve replacement, comparing biologic and mechanical valves in that 50 to 65 group. And again, they didn't see much of a difference. And what you see here is, again, the complete reversal of the two groups in terms of bleeding versus reoperation. So there's some evidence, some more evidence suggesting that biologic valves over the very, very long term will give you as good an overall result in the patients, despite the need for reoperation, as mechanical valves. This was an interesting study that just looked at the type of valve implanted relative to the size of the center. And if you looked at the volume, the greater the volume, the higher the bioprosthetic valve.
It is infinitely better to transplant a heart than to bury it to be devoured by worms, by Dr. Christian Barnett. Now, more than 50 years after the first successful heart transplant, despite multiple advances in the treatment of acute and chronic heart failure, there is still no equivalent to heart transplantation as an end-stage treatment. Over a period of time, everyone has changed, the donors as well as the recipients. The donors have become older, and because of the seat belts and the various safety options present with us, their traumatic head injury has been replaced more by intracerebral hemorrhage or hypoxic brain death. Extensive resuscitation efforts are being done everywhere. This results in broken ribs with internal injuries and hemorrhagic organs. Likewise, the recipients also have changed over a period of time. They also have become older with multiple comorbidities. Many are on a variety of mechanical circulatory devices like ECMOs, IABP, and Centrimax. End result, surgery is complex, longer, with more increased ischemia times. But what has not changed is the basic determinant of success, and these are the quality of the graft, the procurement process, the preservation and storage of the heart, the ischemia time, the complexity of the operation, and the status of the recipient. The organ transplants are a very unique and controversial area of medicine. It's a chance to provide a gift of life. Even though work begins clinically with the declaration of brain death, the whole process en masse is emotional. It involves the doctors, the nurses, the bereaved families of the donor, equally stressed families of the recipient, and you have a Bahubali on hand. The team usually comprises of a cardiologist, a cardiac surgeon. I have highlighted the clinical transplant coordinator because he is the unsung hero in this whole process of a donor retrieval. the social worker, a dietitian, and of course the financial counselor. A lot of times the whole team gets prepped up for surgery and we intimate the recipients, and then you get a call saying that the donor had a change of heart, or sometimes even the recipient had a change of heart. Sometimes, a lot of times patients say, sir, आज नहीं कर सकते, अगली बार कर सकते हैं क्या? It's as if it's available in the market and you are ready to do it. The pearl number 2, the quality of the heart. So it all depends on donor management. This is something which is not in our hands most of the times, because you get calls from other places or from different hospitals who have no interest in transplantation, and likewise they don't take all the steps which are required to preserve the organ per se. So one of our anesthetists who is trained from US, UK, he said there is a dictum which they follow. Either way, you have to spend time in the OT. Now, you want to spend time with the patient either before surgery or after surgery. So the choice is yours. If you spend time before surgery, then the patient comes off very smoothly and you don't need to spend time with him much. But if you don't spend time with him before surgery, then you have to spend time in the OR. So donor optimization is the most critical part of the whole process. Once an alert is received, the retrieval team usually arrives at the donor hospital. And the goal of donor management is to minimize all the deleterious effects of brain death. Usually a transesophageal echocardiogram is preferable, but many a times it's not possible because you are doing these things in a hospital which is different from your own. So even a transthoracic echocardiogram is fine. You start them on various methylprednisolone as well as vasopressin or whatever inotropes which are required to maintain the organ. The acceptance criteria is all a standardized one, age up to 60 years with ABO compatibility. But nowadays we give more importance to the height-weight mismatch rather than only the weight. Earlier in the beginning, we used to take care of only the weight management part, but nowadays we concentrate more on the height mismatch. And inotropes have to be maintained sufficiently well. And the other hemodynamic parameters also have to be maintained, because most of the organs, it's not only the heart, because it's a multi-organ retrieval system. So all the organs have to be looked after. The patient should not have had any cardiac arrest resulting in prolonged resuscitation, a normal ECG or a normal cardiac size. There should be no valvular or major congenital lesions. There should be minimal chest injury or no chest injury. Smoking history is not a determinant for refusal of a well-functioning organ, but smoking is more important in cases of patients for lung transplant. Infections are acceptable if they are on antibiotics, unless there is a gross sepsis or major systemic infection. Brain tumors may be acceptable for heart transplant. The major contraindications are major systemic sepsis, malignancy with multiple metastasis, HIV and AIDS, hepatitis B, C. But these are also relative now, because some centers take HBs AG also as well as HIV, but they talk to the recipient and inform them of the status. Depending on the urgency, the recipient may agree or may not agree. Now, pearl number 3, you should have a good transplant coordinator, because he is the guy who takes care of most of the action which is happening behind the scenes. You may be the hero in front, but the backdrop action or everything is taken care of by the transplant coordinator. They are the ones who pull up all the resources, the coordination, or the green corridors, and the cross matchings. Everything is taken care of by these people. So you should have or invest in a good transplant coordinator. The retrieval operation is a standard one, a median sternotomy with meticular hemostasis. The thymus is divided, innominate vein is encircled and divided later, pericardial stays. Assess the donor heart, the size, contractility, any anomalies which is visible, coronary arteries, as well as the pressures. Pearl number 4, if in doubt, reject rather than accept. And this is particularly true for less experienced centers, a patient on our wait list who can wait, and an unsettled team with overbearing bosses. Nowadays, transplants have become the in thing. Everyone wants to do it. And every center has got a approval rate. Every center has got patients listed. And everyone has got a bucket list. Like when we were doing general surgeries, everyone said, one Whipples is enough for me. It's something like a dream a surgeon has before he passes out. So now the cardiac surgeons, everyone has a dream that I want to do one transplant, that's enough. I have ticked it, it's something in my bucket list. But the problem is when you have a bucket list where this is just one part of it, you tend to hurry. But instead of hurrying, you should worry, because this is where the whole game changes. Because once you have to choose a donor who is safe, you have to have a recipient who is safe. And in these situations, I would always recommend to have a patient who is in the hospital. The donation should be preferably within the hospital so that you cut the ischemia time and all those other determinants which affect your result. The retrieval operation continues. It's an encircling of the aorta, the SVC, a zygous vein. Heparin is administered, aorta is canalized, and cardioplegia is given. The timing of division of or clamping of the aorta is usually coordinated with the abdominal team, where the liver team takes a huge chunk of the area. So, pearl number 5, when during retrieval, vent the heart, not your feelings. And you should have a good lead surgeon who should be knowing when to take the heart, and the surgeon should be able to take the difficult decision of backing out even when things have proceeded till the last moment. Because if you want to say, all of us have come, let us do it, let us take it, we will take care, it does not happen that way. So you should have a good surgeon who has the skills to and the idea to know when to stop or when to proceed. So once the heart is empty, by venting appropriately, infuse 1 to 2 liters of either a crystalloid cardioplegia or a custodial solution. When the infusion is complete, the cannula is taken out and the dissection is done. Lot of times there is a hurry during dissection that the ischemia time begins, because you have a perfusionist who notes the cross clamp time and then the clock starts ticking. So a lot of times with all the blood going around, with all the fluid around, with all the ice floating around, one from the abdominal side, one from the heart side, the whole field is full of blood as well as all the solutions, the liters of solutions which you have. So the anatomic boundaries are not very clear. So be very sure to take a deep breath, take a step back, clear out the solution, because the anatomic boundaries, once the heart is collapsed, is not as clear as you see when the heart is beating. So complete dividing the IVC, dividing the left pulmonary veins, divide the right pulmonary veins, pulmonary artery, the aorta as high as possible, the SVC. The heart is inspected and then is packed in the box. Pearl number 5. Cold ischemia has to be maintained at a temperature of 4. That's one of the most important. Can we go back? Can we go back one slide? Yeah. Can we play the video? Sorry. So pearl number 5, you should have try to maintain a cold cardioplegia or ischemic time of 4 degrees. So that is why it is always preferable if we can have these donations and retrievals within the city or within the hospital if preferable. Now, this is something which we did a few years back. So just to show a small video of the retrieval process. This is the donor heart. Sternotomy. The pericardium is divided, and then hold the heart and assess it. The contractility is felt in all the segments. Try to assess all the contractility in all the segments. Try to palpate all the coronary arteries which you can feel. Feel for plaques. And once this is assessed, once the donor contractility is assessed and everything is fine, then you inform the team which is present at the recipient center that the heart is good enough and we can proceed to take the patient in. The encircling of the IVC, the SVC, the aorta, and then once everything is ready, we are venting the heart, the IVC is incised, and then the pulmonary veins. It is always advisable or it is always preferable if the gastric, the liver team incises the IVC down below the diaphragm so that all the flush passes through into the abdomen rather than into the heart. Once the cardioplegia is given, suck out all the effluent which is there, and then the dissection begins, where we first dissect out stepwise from the pulmonary artery, the IVC, the pulmonary veins, the LA, lastly the SPC. You assess all the valves and all. Once the heart is taken out, assess the valves for any lesions which may be present, as well as for any ASDs for a bench repair, and then put them into the box.
Sorry to interrupt you, sir. The 15 minutes are up. If you could wrap up.
So the cold ischemia time is more important because prolonged ischemia times has been the bane of transplants, the single most important cause of early graft failure. There are newer developments which I think which are decreasing the ischemia times, which I think will be discussed in the other oncoming topics. The organ care system and DCD. Thank you.
Thank you, Dr. Nagesh, for that crisp and very nice presentation. Since we are running late, we are out of time. Two quick questions before we go on to the next speaker. Any questions? Okay. Thank you, Dr. Nagesh.
That's a relief. Thank you.
Thank you.
Thank you,
We
Dr. Nagesh, for
Move on
emphasizing
to the
that
next speaker.
with the golden hour ticking, we all know the importance of a long-distance heart retrieval. Let us find out from Dr. Manoj Dureraj, who will be speaking about the time for networking during a long-distance retrieval. Dr. Dureraj is the director of Marian Cardiac Care and Research Foundation.
Afternoon, dear ladies and gentlemen. It's a pleasure to be in Jaipur, and I'm happy that the organizers have asked me to talk on this very interesting topic, time for networking for long distance heart retrievals. I don't know whether Dr. Yadav or Dr. Buddha chose this topic thinking that I'm good at logistics or networking in view of the upcoming election tomorrow. But jokes apart, can I have the next slide, please? So what are my credentials for this talk? We've done 35 heart transplants in the last 5 years in the city of Pune, and I've been involved in at least personally 3 organ retrievals to the cities of Delhi, to Chennai, and to Nagpur. That means I've taken out the organs and delivered it there. It's also very important for us to understand that what are the logistics involved in this whole process, and what are the good scenarios and bad scenarios which can come out of this. So this is scenario 1, a patient on Centrimag in Fortis Hospital, Mala. The donor call was in Nagpur, received at around 10 p.m. Retrieval time was 8 a.m. the next day. The pressure was from the relatives to hand over the body as early as possible, and that's usually the problem. And I received a call from Dr. Suresh Rao. I think everybody knows him. He's the president of the ECMO Society and the Cardiac Anesthesia Society. And he said, Manoj, I want you to do me a favor. Go to Nagpur tomorrow and retrieve this heart for me. I never say no. So I said yes. And then after that, I have a very good anesthetic team. They also said, let's go ahead. I got the male scrub nurse, perfusionist, equipment all set. The management of the hospital has to be very cooperative because it is very important. There are monetary things involved, but they have to keep saying yes. So we took the early morning flight to Nagpur. We were in theater by 9:30. The chartered flight from Delhi landed at around 10 o'clock. Now, when you have these long distance retrievals, you need to understand that the flight should have landed before you retrieve the heart. You just cannot imagine that the flight will be en route or whatever. You have to see that the flight has landed, not taken off. Heart was retrieved at around 12:30 p.m. and the takeoff was set at 1:20. You will see the arrival time, it's around 4:20. That means almost 4 hours were already taken to arrive in the port city. So this is what, if you see the time frame very quickly, the left side you'll see Nagpur, we reached around 5 to 9, and then we took off by the chartered flight, and it's a propeller type aircraft. So when you have can you cut off the sound? Propeller type aircraft, so it takes around 3 hours to reach Chennai. And the best part of it in Chennai, what I found was that the transport comes directly to the tarmac, and that saves a lot of time. You don't have to do any check-in, check-out, nothing. They have a very well organized system. This is directly, as soon as the aircraft lands, the ambulance is waiting at the tarmac, and I will show you some pictures later, and you're directly onto the highway and to the hospital. So you'll have a green corridor there. Again, I'm very impressed with Chennai. The middle lanes are always given to the ambulance and to the green corridor, and the traffic just moves aside. And you'll see the time very closely there. It's around 4:30 in the afternoon. And when we release the cross clamp, Dr. Bala is very quick. It was 5:30 in the evening, and you'll see that the ischemic time was around 5 hours. So we need to see that the donor organ gets a repeat dose of cardioplegia in the theater. The second scenario, I got a call from Dr. Anand Sencheti, New Era Hospital, Nagpur, to retrieve the heart and transfer. The donor call was from KEM Hospital, Pune. This was a commercial flight, so we had to coordinate the clamp very, very carefully. We retrieved the heart at 10 o'clock, and the commercial flight was already landed in the airport. Again, you have to ensure that the flight has landed before you clamp. That's very important. And I'll show you the pictures and videos soon. We transferred the heart via the commercial Indigo flight, and we gave a second dose cardioplegia in Nagpur, and that was the first heart transplant which was performed in Nagpur that day. And that's again another important story. So if you have an experienced team coming with the heart, you are able to perform transplants in fledgling hospitals or new hospitals also. It's very important to have logistics under control. The commercial flights and the airport authorities are very important because they gave us the first 2 rows, and you'll notice that all of us are in scrubs. This is around 10 o'clock in the morning in Pune city. We reached the airport within 7 minutes flat, which normally takes around 40 minutes, and you'll see hundreds and hundreds of cars, but it doesn't make a difference. The Indigo guys were also very, very good, but I'll tell you what happened in the next few slides later. So the first 2 rows are booked for us along with the organ, and we had an excellent experience in Nagpur airport also. We had the transport at the tarmac. So this is the first heart transplant at Nagpur, and it was completed by around, you'll see that the monitor at the end of the video, it'll show you around 4:30 in the evening after it was done. This is New Era Hospital in Nagpur. The third scenario was in AIIMS. Professor Milind Hote called me that there is a recipient call, there's a donor call at Rubiol Clinic where I'm working, and I was, I retrieved the heart at around 12:45. Again, he was supposed to send somebody, the person missed the flight. He was supposed to come by Jet Airways and take off by Vistara, but that didn't matter. So what we did is we sent our man with the organ to Delhi. Now, what happened here was that's my perfusionist in the black shirt who went with the heart to Delhi. And inside the terminal, there was so much of issues because intra-terminal transfers and transits are a nightmare, which we need to solve, which I'll come to again a little later. So the heart reached Delhi. This is the actual photo of that heart. And this is Dr. Balram and Dr. Milind Hote, and this is around 6:50 in the evening. Again, a long distance retrieval, but you'll see the heart working very well. The next day, the patient was extubated. Milind had sent me the pictures, but you'll see that the airport authorities, the PROs and all are very, very crucial, as well as the hospital coordinators, especially the transplant coordinators are essential for this kind of thing. They all have a smile on their face. Now, this is a minute-to-minute blowout of a retrieval team's experience of a lung harvest from Chennai to Chandigarh and back. This is my friend Dr. Pradeep Nanashekhar, and I'm just showing you screenshots of the phone. 4:20 a.m. the team left from MGM hospital to Chennai airport. 5 o'clock they reached the airport. 5:30 baggage checked in. So this is another problem. You check in the baggage and you need to take out the baggage. It's a busy hour, so the team has to wait for the baggage to come out at Chandigarh airport. So it's very, very important. And what happens, the empty organ box was there, and there were, you'll see at the end, they waited for almost 25 minutes because one of the staff members was carrying the empty box thinking that it should not get misplaced, and people are hunting for that box in the, luggage console. So a lot of things happen at that point of time. But anyway, they reached the PGI, the theater at around 1:30. ABG samples were taken, bronchoscopy was done, and the lungs were retrieved by around 2:40. They left the airport from PGI at around 2:50. They reached the airport at 3:15, and they took the 3:30 flight to Delhi. Now, they reached Delhi, and the airport authorities were very, very supportive. They managed to get them straight away into the aircraft, and they skipped the security check-in. That is very important on the way back. And the organ was in MGM at 8:30. But imagine the logistics of this team traveling from 4 o'clock in the morning and coming back at 8:30. What if there was a local team in Chandigarh who had taken out the organ and transferred it to Chennai? So this is what the issue is. The other issue is if the recipient anatomy is complex and you need 2 senior surgeons at that point of time to do the actual, That's not me. That's seriously not me. Okay. So this is the first case scenario, LSVC. A 8-year-old girl. she has an LSVC. Look at the complexity of the cardiac problem. And we need 2 surgeons to dissect out, understand the anatomy, figure out where you're going to cannulate. And really at around 2 o'clock, 3 o'clock in the morning, you need to have widths around you. And this cannot be done with some simple PA or something. So this was what we did, a PTFE graft from the LSVC to the RA appendage. And the heart was actually retrieved from Nasik by me, and I'll just show you. We normally use a long innominate vein. So this was the second scenario where it was a redo chest. This patient had a AV canal defect, LSVC at the age of 5, ASD closure at the age of 25, mitral valve replacement, and he presented with end-stage heart failure. This is, I went to Nasik, took out the heart, and you take out a long innominate vein and retrieve it. But I'll just show you the redo. See, when you take out the redo chest, the heart, it's fixed like this. You can definitely injure the phrenic nerve. You have to identify the LSVC. You need to cannulate the LSVC, and trust me, it just retracts and it's a logistical nightmare. But then anyway, and then we have to fashion a bovine pericardial tube like this. And this is again at 2 o'clock, 3 o'clock in the morning. Trust me, it's not a great thing to do alone. So when you have a lean team working around, you need to have networking where you are rested. You have some kind of local team which brings you the heart, and you just do this kind of anastomosis. So this is a bovine tube which we have fixed, graft LSVC to RA. So these are the complexity of the problem. Sometimes you have a redo chest post CABG patient. It takes a while to take out the heart from the recipient. But these are the things I'm trying to tell you is going to be a problem. So if you have a lean staff and having a complex procedure done, definitely networking helps. Donor hearts wasted due to lack of networking. These are calls which I'll just show you, real-time calls. This is a call from Chandigarh on the left side, 13-year-old male. A call from Ahmedabad, 34 male. A call from Artemis Hospital, Gurgaon, 25 male. This is in Pune. The alert has come from Noto to Pune. No recipients in the local cities, and it's come to us. But because we didn't have the logistics of chartered flight or things, we could not take the heart out. This is again Chandigarh, this is Kolkata, and this is again Chandigarh. So you'll find that almost 7 hearts in the last 2 weeks have been wasted because there are no networking possible. Certain issues which I like to tell you, don't arrive too early. Now in this flight for Indigo, we arrived a little too early. And what happened? We were waiting at the tarmac with the heart in the ice box, and we had to wait for the passengers to come and check in. So that becomes a problem. So you need to time yourself. So what we have done is we find out from the pilots, find out from the airport authorities, and see to it that once the flight is landed, the passengers are all right, then we sort of clamp. And we have enough of time at that point of time. They will wait for a couple of minutes here and there. Tarmac transfer is the quickest. You'll find that this is in Nagpur, direct transfer to the tarmac and you exit. This is Chennai. The car has come right at the chartered flight, and we are taking the ambulance from the tarmac, and you'll find that you're literally getting into the highway within a couple of minutes. This is Chennai airport from the back. I'm not sure many of you have seen it, but there is an exit point when you look, when you come out of the glamorous part of it, but then there is a shady kind of exit point there, and you're on the highway. So this is also very important. So the take-home message is, I still have 1 minute, 26 seconds. Networking for organ retrieval is the way forward for long-distance donor alerts. It saves time, it saves expenses, physical energy, definitely. There's a comfort level of the local team which is operating in their own theater. Say for example, Chandigarh, PGI, the surgeons are operating in their own theater, the staff is there, and they are retrieving for a team maybe in Chennai or Calcutta. It makes a lot of difference. The body can be handed over to the relatives in time. That's also very crucial because of social pressures. Retrieval team should always travel in scrubs. Sometimes the passengers in the commercial aircraft, trust me, they just don't understand the seriousness of the matter. They want to exit first and then they'll make you exit last. Once you're in scrubs, everybody understands you mean business. So it's very important for us to be in scrubs when we transfer, So it's easy for public and authorities to understand the doctors and expedite the transfer. The transit time between the flights is also important. The time from exit from the airport is very crucial, especially like Mumbai airport or Delhi airport, where it takes 2 kilometers to travel from one, the check-in point to the checkout point. So intra-terminal transfer, maybe they should arrange a green corridor within the terminal. That's very important, like a buggy or something. That has to be done, which we need to work around. Or a tarmac transfer where you have important, exit time. Organ wastage can come down by 80% if we network. And it opens doors for newer centers like Nagpur or any other centers to start heart transplant programs. Say, for example, you have Dr. Julius Punnan, harvesting heart from Narayana Vidyalaya and transporting it to Calcutta and helping you with the transplant. I'm sure it makes a big difference for the center. So it opens doors for newer centers to start heart and lung transplant programs. Thank you very much for your patient hearing, and I thank the organizers again.
Thank you, Dr. Manoj, for a nice talk. Any questions from the audience?
Hello. I am Manoj Sahu from Cardiac Thoracic Center in All India Institute. I know Dr. Manoj very well. He is my contemporary. You have a lot of experience in retrieving and particularly outstation hearts. My question, two queries. In your experience, outstation hearts and till, as you suggested, a lot of suggestions like cooperation or coordination in different parts of the country is going to help in a very big way, saving the time, ischemic time particularly. So in your experience, the stretchable time limit, ischemic time limit, if it exceeds, how much have you seen and what is the problem? Do you face some problems like PGD post-operatively? What is the percentage of cases in your way? And one more second question is, do you think this, as we start from the point of retrieval at a 4 degree centigrade so-called in the box, triple ice box, so is this temperature supposed to change by the time you reach after 5 to 6 hours or whatever it is?
Very valid points. I'll start with the second question. See, what happens is you are storing the organ in the ice container and you have no method at the moment of even measuring the temperature at the moment. You don't have a thermostat. What we are proposing is that you should have a thermostat inside where there is a Bluetooth connect with maybe a mobile phone so that it can actually calculate the temperature drift in the organ. So what you're saying is absolutely right. That technology doesn't exist. At least we are not using it. We are presuming that the organ will be at 4 degrees. We are presuming. But whether it's at 4 degrees, it's God's guess, right? Anybody's guess. So 4 degrees is maybe a very optimal temperature in an Indian setting, but when you have a long distance transfer, it's very, very difficult for us to keep taking it out and checking. So a thermostat inside the ice box, which is what I feel, with a Bluetooth connectivity outside to check the temperature is the way to go forward. I think that's the technology. It may be existing, we are not using it. Second thing is, what is the second question? About the ischemic time. So ischemic time, extending ischemic time, of course, what we do is if it is like exceeding 3 hours, 3.5 hours, we give a second dose of custodial cardioplegia in the recipient theatre. It has helped for us and we have been able to extend the ischemic time to almost 4.5 hours. The Delhi heart, if you look, we had retrieved it around 12 o'clock, 12:30. By the time it reached the theatres around 4:35 and by the time they finished it was 6:30, but the heart was beating very well. So organ selection, if you get a young heart for long distance, I would choose it. So if you have anywhere between 20, 22, 23, I would take the heart irrespective of the distance because it will work very well. Once you start going above 35, 40, 45, you are expecting trouble with PGD. And we are not looking at simple things, Dr. Sahu. We are looking at long-term results. So any heart which you are taking out which is young, 2022, you will have excellent long-term results irrespective of the long ischemic. This is what my opinion.
Thank you very much. Exactly, you are very right. Actually, we do not have exact mechanism right now to know the temperature as the time passes. Say, as you pointed very clearly, if it's a young heart, okay, it sustains probably better. And most important thing, long term. So we don't know. Even if the early post-operatively we cross over, what is going to happen if the ischemic time is longer? We need to have more data on the in-station and outstation hearts. Probably we need to know better about it. And as you pointed out very nicely, if more coordination different parts of the country happens, retrieval, one surgeon retrieves and sends the heart rather than team going there and bringing, probably this things will be better as far as results are concerned long term. Thank you very much.
Thank you, Dr. Saul. Thank you, Dr. Manoj, for a nice talk. We can proceed.
Thank you, Dr. Manoj. It was a very nice talk on networking. We all know importance of networking in a heart transplant. Now imagine you have a patient in front of you with his chest open. We have retrieved the heart, we have transported the heart, and now it is ready for transplant. Oh wait, did the patient really require a transplant? While we ponder upon the dreaded question, let us now invite Dr. Dhiren Shah to speak whether all heart failure patients require transplant.
Good afternoon, my dear senior colleagues and my dear friends. At the outset, I would like to thank the organizing committee, Dr. Rajkumar Yadav, for organizing this fantastic conference and much needed conference after a gap of almost 2 years, and everybody is longing to meet in person to each other. So it's a fantastic city, fantastic venue, fantastic gathering on the first day. It's a very surprising thing. So my talk is, are all heart failure patients a transplant candidate? A very pertinent question, very important questions when you are starting a heart transplant program or already you are an established heart transplant program. It is almost now more than 50 years of first heart transplant done by Christian Barnard, and the science and the medicine of the transplantation evolved over a period of 50 years, and now a lot of things are very clear. Now we are at a stage where we can say yes and no to certain patients for transplantation or not. We have reached a stage wherein the results of heart transplantation are in comparison or at par with the kidney and the liver transplantation in terms of 5-year, 10-year and 15-year survival. So this is the evolution of the heart transplantation over a period of last 50 years. And these are the few patients who have lived almost 35, 38 years post heart transplantation. So is it possible that we can also achieve that results in India or anywhere else? Yes, it depends on very two important questions out of many questions or many important aspects that needs to be taken care when you are doing a heart transplantation procedure. Important question is my patient a candidate for heart transplantation? That is foremost first question that needs to be asked. And second is which patient will be a good candidate for long-term outcomes? So these two questions, if you answer it nicely, then definitely I am sure you can run a very good successful heart transplantation program. Landscape of heart failure unfortunately has become very complicated with lot of things in the frontier, lot of things there are in for the treatment of heart failure, right from the medications, RNEs, LVADs, CRTDs, transplants. So you have a whole array of armamentariums to treat heart failure patients, though even the patients are confused, the cardiologists are confused. That is where you need to have a clear answer for this. And recently, European Society has come out with this guideline for the treatment of acute and chronic heart failure. It is very exhaustive. You can go through that guidelines, and a lot of points I have taken from their guidelines. As per this guideline, heart transplantation is class 1 indications for all advanced heart failure patients. So advanced heart failure patients, important thing is identify which are the heart failure patients, which you would stamp as an advanced heart failure patient. So these are the list of the things: LVF less than 30%, repeated hospitalizations, BNP levels are high, 6-minute walk test is less than 300 meters, VO2 max is less than 14 ml, non-operable severe valvular abnormalities, persistently high pressures, pulmonary and systemic congestions. So these are multiple things in a patient that you find out. And that is in spite of being on optimal medical management. That is very important. That patient should be on optimal medical management for at least 3 to 6 months before you can stamp a patient that it is an advanced heart failure patient. So we are very clear in patients who come in acute heart failure or intermix 1, 2 or 3 heart failure, wherein you don't have any other option. You have to identify the cause. If it is treatable, it's fine. Otherwise, you have to straight away put that patient on LVAD or temporary or permanent LVAD and then plan a transplantation. But the question always arises when the patient is an ambulatory heart failure patient. And unfortunately, issue comes up because this advanced heart failure patients who are ambulatory will have good periods in between. They are feeling, personally they feel that I am absolutely okay. Even the cardiologist will also feel the patient is doing well, he is walking, he is doing his routine activities. But then intermittently they again deteriorate, and sometimes they deteriorate so much that they lose their life also. So that is very important to identify that patient has reached an advanced heart failure stage, maybe in between fine, but still he is a candidate for heart transplantation. So we have to identify that group of patient in between. And how to identify that patient? There are 3 important things which needs to be done in ambulatory patients of heart failure. One is VO2 max. Another is, if there is still a confusion in VO2 max, then you can go for the tools which are the Seattle heart failure score or heart failure survival score. These are the 2 tools which can help you to really stamp that patient that this patient needs a transplant. VO2 max, I would say, is one of the most important parameter which each transplant center or a heart failure center should have in their center. Because there is always a confusion. Patient and cardiologist will always say that we are in NYHA class 2, I am doing all the activities, but when you do an VO2 max, you will really identify that these patients have an VO2 max of less than 12 ml or 10 ml or 8 ml in spite of their subjective feeling that they are okay. So VO2 max derivation is very important, and it is a very objective thing, not subjective. When you are talking about NYHA class, it is very, very, very subjective. I may feel this way, that person may feel that way, but VO2 max is a very objective thing, and that is where you can identify that patient is a transplant candidate. And that is the reason, if you go through the ACC/AHA guidelines, if you look at the absolute and relative indications of heart transplantation, they have not mentioned NYHA class anywhere. It is always VO2 max or arrhythmias or patient on inotropic or LVADs. Insufficient data, that what they have mentioned is NYHA class. So it is an insufficient. So don't go on the symptomatic base of the patient. Still you are in doubt of the VO2 max, these are the 2 very important tools that you can use, Seattle heart failure score and heart failure survival score. You get the good data out of it, and if both the scores are low, then definitely that is a strong indicator that this patient's overall survival is not good and should be subjected for heart transplantation at the earliest. Now coming, once the patient has been stamped as an advanced heart failure, now what? Next, what is the etiology of that patient? And the most common etiology is either the ischemic or idiopathic dilated cardiomyopathy. Valvular congenitals are a small quantity of patients. Retransplantation, obviously in India, we may not be seeing it in coming years, but after 10 years or 15 years, we may be seeing many patients. Myocarditis, viral myocarditis, who are not improving. So that again is a small chunk. And very important point to be mentioned over here is infiltrative cardiomyopathies, because take with a pinch of salt with this, all this sort of patient, whether it is an amyloidosis or sarcoidosis, take with pinch of salt. If you are starting a program, may not enter into that category of patients for subjecting the transplantation. And this is the work volume of according to the etiology. according to INSHLT. Now, after the patient has been identified, his advanced heart failure needs heart transplantation. That doesn't mean that patient will need a heart transplant or is a candidate for heart transplant. Still, you have to screen that patient and find out, are there any other contraindications for heart transplantation? So screening of that patient's needs, a battery of investigations are done, almost from hair to toe, all investigations have to be done, and that is almost in the tune of 2 to 3 lakh rupees investigations. At that point of time, you will find out there are certain contraindications also, wherein you can deny that patients for being a candidate for heart transplantation. So what are the contraindications? Irreversible severe pH, advanced age, systemic infections, metastatic cancers, diabetes mellitus with end organ dysfunction, marked obesity, severe PVD, and obviously if there is irreversible other organ systems, that is liver, kidney and lungs, and psychosocial factors. Initially, I used to think that psychosocial factors are not very important in India, but let me tell you, in my practice, in last 5 years, I have seen that it is still a very, very important factor even in India, where we always feel we are a social people and there is not an issue. So recipient age, obviously, some data have already shown that the patient of older age may not have a rejection, but still the overall survival in the patients who are more than 65 or 70 years age is still not good. And this is the INSHLT data. If you look at the 1-year mortality and the 10-year mortality in the patients who are more than 60 or 70 years of age, still high. Even in the younger age group also it is high. It is in the middle age group that you have a fantastic outcomes at the end of 10 years. In that category of patient, then definitely you need to subject that patient either on medical management, maybe a milrinone therapy, home milrinone therapy, or that patient can be given an option of LVADs, that is the permanent LVAD implantation. Obesity, again, a very high risk category. There is mortality, twice the mortality as compared to a normal patient. Issue is again to get an heart for that particular size of the patient is always a big issue, and infection rate is also very high. So if you are planning to give subject a patient for heart transplantation, patient is obese, weight reduction is must for that patient. This is again a linear correlation with the mortality of the patients at first year. Once they cross first year, then definitely the overall long-term survival is the same. If you look at very important point is the renal insufficiency. Any patients of heart failure will always have cardiorenal syndrome. And cardiorenal syndrome is the point where you should not have that patient in that category of patient. Patients needs to be identified of heart failure before they enter into that cardiorenal syndrome. Because once they enter into cardiorenal syndrome, then the overall outcomes, they really reduce significantly, because majority of the patients post-operatively as such will have increase in the creatinine level, and then management of the immunosuppressive drugs then becomes very difficult. If the creatinine is already 3 or more or 2 or more, then you can subject that patients for medical management, or LVAD is a good option for that heart failure patient. And this is data which shows that any patients of heart failure, if already has a small element of renal dysfunction, within no period of times, 5-6 months, that patient may end up into a CKD situation. So if you identify a patient with creatinine slightly higher, transplant him immediately so that he doesn't end into a CKD category of patient. This is a linear correlation at the end of 1 year and in 10 years if the patient is subjected for transplantation with higher creatinine level. Diabetes, again, a very, very important aspect. In ischemic dilated cardiomyopathy, you encounter a lot of patients with diabetes. And in diabetes also, if the patient is having end organ dysfunction, that is a renal dysfunction or retinal issues, or they have any other end organ issues, then definitely they are not a candidate for the transplantations, because overall mortality is almost 20 to 40% higher as compared to the non-diabetic patients. So that patients may then be subjected for LVADs, or then can be kept on medical management, and good medical medicines are there on Frontier, which can help these patients. And if you look at the burden of the diabetic patients who are subjected for transplant, they are definitely very low number of patients across the world also. Pulmonary artery hypertension, obviously when you do right heart cath, if the PVR is more than 5 or TPG is more than 16 or 20, and if the mean pressures are more than 20, then definitely high risk category of patient. But by subjecting that patient with Milrinone, by giving Pulmopress and all these medications, if the PVR comes down, then the overall outcomes are good, then that patients can be easily subjected for transplantation. So this is very important aspect also. Hepatic dysfunction, yes, it has a renal correlation with the more higher mortality if the bilirubin level is more than 2.5 or 3. Severe peripheral vascular disease, again, a big mortality factor. So important thing is balancing the game. The worse the heart or the worse the other organs. You have to find out the right time. The heart has started deteriorating before the other organ starts deteriorating. Subject that patient for a transplantation. That is the golden period during which you can get the best outcomes, long-term outcomes. These are the, so at the end I would just like to say that transition of care beyond the front door looks very simple, but it is not that. It is not that all heart failure patients will get a heart transplantation. The frontier is very complex, and ultimately we have to take a call and take a wise decision before we subject a patient for transplantation. Thank you very much, and I appreciate it.
Hello. Thank you, Dr. Dhiren. It was a very eloquent talk. You covered almost everything. As you told very correctly, this is a point, balance, before the end organ starts in end stage heart failure patients. Are we reaching there? Are we getting the patients listed well before the starts, the end organ starts affecting? And my second question is it the right time to address those bunch of patients like single ventricle physiology patients, Fontan patients, lot many patients are there. Are we, is this the time we should address them or list them? Because I think they have no life after that.
So first question, I think so, getting a patient in that golden period wherein there only heart is deteriorated significantly, but the rest of the organs are fine. It is very difficult to get that sort of patients because most of the patients are referred by the cardiologist. And cardiologists, with the advent of this ARNIs, they feel this ARNIs is a magical drug, and they pull on these patients on ARNI for a long time. And when they refer that patients, their creatinines are already above 2. So they are already in a bad shape. Important thing is right now, I think so, it is our forum which needs to educate and aware the cardiology society that which is the right time to refer a patient for a heart transplantation. They always feel I'm sending the patient in Intermax 1 and 2 or 3 and you transplant that patient immediately and get that patient out, which is absolutely out of question in India. You cannot put that patient on LVADs and then retransplant that thing in India. You have to look it in a perspective. US, yes, definitely that can be done, but in India, we need to have patients who are in very good conditions. Apart from the cardiac deterioration, rest of the things are fine. Your second question is regarding the single ventricle physiology. Yes, it is a very challenging category of patients who needs a transplantation. I think so that transplantations needs to be reserved only to few particular centers across India. Not all centers should venture into the single ventricle physiology patients because there are a lot of things that needs to be taken care of. So if a person is doing 2 or 3 transplants a year, that center should not venture. But yes, that category of patient is a huge chunk now that we are going to foresee. And we should have 4 or 5 centers who are expertise in managing this sort of category of patient.
Because why I asked is this is in your hand. You have in your circle your patients. You have to refer, you have to operate. They are young.
Yeah.
Have a life. long life. Thank you very much.
Thank you.
One more question, Dr. Dharin. What is your experience that the patient is for good candidate for heart transplant, but creatinine is borderline around 2 to 3. So what do you prefer to go for heart transplant or kidney and heart, both?
A very important question, and recently I faced that same issue with one of the patient. So first you optimize that patient, keep that patient in ICU, give them inotropic support, melrenon, dobutamine, dehydrate that patient. If the creatinine comes down, then definitely that patient seems to be a candidate for only heart transplantation. But if still the creatinine is hovering around 2.5 range, then it becomes very important to stamp that patient as a CKD patient or hepatorenal syndrome. Then what you have to do is you have to do a renal biopsy. To do a renal biopsy, stamp it that there is irreversible changes in the kidneys also, because recent patient I had, and he was been listed for combined transplant, has severe fibrosis, interstitial fibrosis. So that patients are definitely now end stage renal disease. So that patients will definitely need combined kidney and heart transplantation.
I think this is an important thing. I should make a comment on this one, Dhiren. So somebody who has a cardiorenal problem and we try to optimize, patient may not optimize. The kidney function may remain low, and it doesn't necessarily mean that this is an irreversible kidney disease. It still might be cardiorenal, and that's why the role of LVAD comes. Because your medications can improve the cardiac output to an extent. And unless you increase that cardiac output, and still if the patient continues to be in renal failure, and obviously there are definite parameters to see that this patient actually has a sort of a end-stage renal disease. So before you decide for that this patient also need renal transplant, you have to see whether this patient may benefit from the mechanical circulatory support and the kidney function may improve.
Yeah, I totally agree. That patients, sometimes you even can give an option of temporary LVADs, put them on Centrimag, and if the creatinine comes down, then you can subject that patient for transplant.
Thank you, sir.
Thank you.
Our next speaker would not be able to be here today. He'll be joining us virtually live. Dr. T. Sundar, Senior Cardiothoracic and Transplant Surgeon, Director of the Transplant Program at Apollo Hospitals, Chennai. He'll be here to discuss about the extended organ criteria and marginal donors. Can we connect to him, please?
Good day to all of you. I apologize, I have not been able to come in person, and I will get away straight away with my talk. I'm going to share the screen. Yes, I'm aware of the time constraints, and I'll try to keep within the time limited. I have been asked to talk on the organ criteria, extended organ criteria and marginal donors as far as heart transplant is concerned. And I would like to thank the organizers for inviting me to give this talk. To give an overview, I will talk about the standard donor criteria, move on to extended donor criteria, marginal donors, a word about donation after circulatory death, and organ care systems. First and foremost, the point I would like to make is for any given donor, we've got to match it to the recipient that we have in mind. So the donor-recipient interaction is what is the most important. Yes, we are talking about marginal donors, but that again, the outcome depends on, not in small part due to the profile of the recipient. Most often marginal donors are given to high-risk recipient profiles, such as recipients who are older age, sensitized recipients on mechanical circulatory support, peripheral vascular disease, renal impairment. So the standard organ criteria, the ISHLT guidelines in 2010 talks about the guidelines for the care of heart transplant patients, where they discuss about the standard criteria. And there was a good review article in the Journal of Thoracic Diseases in 2014, which again talks about donor selection criteria. So the standard donor criteria, this mentions as 55, although recent papers say a standard criteria is less than 40 years old, no history of chest trauma or cardiac disease, no prolonged hypotension, hypoxia, mean of 70, CDP of 10, minimal inotropes, normal ECG, echo, and no positive virology. Yet another review article discussing the donor evaluation and transplant. Now, this article talks about the burden of end-stage heart failure, and we know very well that the number of heart transplant done is far less, and there is a substantial unmet need for more organs. I have some startling figures and statistics here. Notwithstanding the unmet need, there was a recent analysis, and in 6 European countries, 25% of potential donor hearts were not identified. On top of that, 22% of identified hearts were not referred for procurement. Now, comments where the range of declining were from 40% to 80%. So yes, this is another thing which could be improved upon to help with patients on the waiting list. So coming to the extended criteria donors, this lists the various criteria which we could relax a little bit and increase the donor pool. The donor age, the size, gender, cause of death, left ventricular function, ischemic time, and presence of infectious diseases. Now, this was a wonderful review article in the current treatment options in cardiovascular medicine just a few months ago in March 2021, which talks about the new approaches to donor selection and preparation for heart transplant. There they discuss 4 verticals: donor selections, again, as I told you, accepting marginal donors, medications, optimizing donors, looking at new transport system to manage long distance recovery, and of course, consider DCD to improve the donor pool. So there was this conference in the American Society of Transplantation talking on the donor heart selections in adult cardiac transplantation. And the 37th Adult Heart Transplant Report in 2020 of the ISHLT focused on disease donor characteristics. There was a consensus paper in 2020 focusing on organ acceptability criteria in pediatric heart. And yet again, in 2010, there was a multi-institutional analysis talking about various donor characteristics which affect the outcome. Now, my talk and all the slides are going to be data which have been extracted from these 4 papers that I just showed you now. So talking about donor age, young donor with good heart function is the only thing to be thought about. It's favorable on all counts, irrespective of other condition. Like Manoj Duraraj said, it doesn't matter if your ischemic time is long, if it's a long distance, a young age with a good heart function is what we need. The median age of donors has increased from 31 to 35, and the increase is large to the transplant surgeons in Europe taking on much older donors. Less than 40, the outcomes are good in terms of 1 and 5 year survival. However, the young donor age helps only recipients age 40 and above. Surprisingly, it doesn't help younger recipients. And when the donor age is greater than 50, there is a heightened chance of CAV, chronic rejection, chronic allograft vasculopathy. Ischemic time, the 34th Adult Heart Transplantation report had a focus team on allograft ischemic time. Ischemic time less than 4 hours is very good. You have better 3-month and 5-year survival when compared to those beyond 4 years. So the report showed the graph, the survival graph at various ischemic time, and you can see when the ischemic time exceeds 6 hours, there is a decline of survival at 5 years. Now, combining the two, there was an article in the Annals of Thoracic Surgery where the interaction of an ischemic time and donor age had an impact on the outcomes. So if you see the slide here on the left side, you have donor age less than 18. The curves are all together. It doesn't matter. There is no difference between a short ischemic time or a prolonged ischemic time. You go to the right hand of the slide, when the donor age is more than 34, the curves diverge. And at 5 years, the survival is less when the ischemic time is greater than 6 years. Size matching. A lot has been talked about size matching. Commonly, oversizing is done in hypertension to help the new heart recover the high PVR. Numerous studies have looked at height, weight, BMI, BSA. There has been no difference between normal size and undersized heart. Of late, PHM, which is a predicted heart mass, has been used to compare the donor and the recipient, to match donor and the recipient. Now, that is a calculated formula using the height, the weight, and the sex. and undersize, wherein the donor is less than 10% the predicted heart mass, and the oversize, where the predicted heart mass is greater than 10%, have poor survival in terms of 1-year mortality, which is increased. Now, this is the paper which shows that there's a heightened mortality when the alteration in the predicted heart mass is more than 10%. Gender mismatch, generally a male receiving a female has inferior survival rates. However, there is conflicting evidence on the incidence of acute rejection and chronic allograft vasculopathy, some studies quoting higher and some studies quoting no difference between the two. Now, this is a nice review article quite recently on the influence of sex mismatch on prognosis after heart transplant. Now, the most important thing is the direct heart function, looking at left ventricular ejection fraction. Oftentimes, we see transient left ventricular ejection fraction being less. These most often recover completely. It is thought to be due to the catecholamine surge in brain dead person causing reversible dysfunction. And we have papers which say a low ejection fraction in donor hearts is not associated with increased mortality. There was a recent study looking at 30,000 dividing into 3 groups. Greater than 50% is normal EF, 40 to 50 borderline, less than 40 is reduced. And they say there is no difference in survival, 1-year survival between the 3 groups, providing they are quite carefully selected. Left ventricular hypertrophy, you have mixed results in different studies. LVH, the left ventricular wall thickness greater than 12, portends a worse survival with a high CAV incident. There was a study which divided into 3 groups, again from the UNOS database. Less than 11 millimeter is the no left ventricular hypertrophy, 11 to 13 is mild LVH, and greater than 14 is severe. Surprisingly, there was no difference between the 3 groups when all other parameters were the same. But there was a significant difference between these groups when the heart, the hypertrophied heart, was from an old age donor and there was a longer ischemic time. So if you are choosing a person with the left ventricular hypertrophy, you need to watch out that the age is not too high, or you need to try and avoid long distance travel. This was the study which found, analyzed the 3 different wall thickness of the left ventricle. So coming to donors with the infection, the 3 main infections are Hep B, Hep C, and HIV. Now, we do know that hepatitis B donor can be given to recipients provided they are vaccinated or those who are on lamivudine prophylaxis. Hepatitis C, the times are changing now. Initially, the transmission rates from the donor positive H heart, 80 to 100% of the recipient become seropositive. Until 2014, only interferons were available. Now we have got specific antivirals with sustained virological response. The Vanderbilt University has the largest series, about 80 patients, where they have a series of 80 donors with Hep C transplanted. And the 30-day and the 1-year survival is the same as those of non-hepatitis C donors. However, there is an increase in the incidence of chronic allograft vasculopathy in 1 year. Hepatitis, human immunodeficiency syndrome virus has been done from HIV positive to HIV negative recipients sporadically for hearts and quite a lot in the renal transplant. So this paper in the Journal of Heart and Lung Transplant is from Europe. It devised a scoring system, data of about 3,800 patients from 7 countries, and they had 13 characteristics. And sum total of that gives you the donor score. The median value is 17. If that is less than 16, it is a low risk category. Higher than 17 is a high risk category. Organ care systems, these allow long distance travel. It could be of 2 types. One is the normothermic ex vivo perfusion, where the temperature is regulated and you give oxygenated blood and keep the heart beating. The other one is an ex vivo hypothermic perfusion, which help in taking care of long distance travel. DCD, donation of the circulatory death. It's been practiced in the UK, Australia, and the USA, of course. There are 2 types. One is a direct procurement followed by an immediate ex vivo perfusion. And in Papworth, Cambridge, in the UK, it is NRP, which is normothermic regional perfusion. Soon after the DCD has been done, after a period, they quickly go in and clamp the aorta so there is no cerebral perfusion, put the patient on ECMO, try and get the heart to beat again. And that allows evaluation of the heart. Once that is done, they explant the heart, ex vivo perfusion, and transfer it for the recipient. The results between the two are comparable. So matching high-risk recipient with a marginal donor is always a high-risk, efficient strategy. If you have got a low risk or an ideal donor, no question, we're going to use it for a good recipient. It's only when the patients are unstable or quite unwell, quite critical, the implant team is willing to even accept a marginal donor. So we need to look at the anticipated donor-recipient interaction. There are, of course, two opposing points of view with this. One school of thought is transplanting a high-risk donor heart into a patient who is already high risk means you're irresponsibly accumulating the risk with a high likelihood of death. But in terms of survival benefit, what is the net risk of death without transplant? And if you do the transplant, what is the risk is what one has to see. And in such cases, the risk is not so unfavorable. So to conclude, the choice of a desired donor profile is in the hands of the treating physician, and that also includes the patient's consent. Thank you for your attention.
Any questions from the audience?
Dr. Sundar, for a very informative session. While we have retrieved, transported, and transplanted the heart, don't we want to know what's the pre and the post-operative outcomes at the pre and the post-operative care for the patients? So now we invite Dr. Julius Punnan, who will be joining us virtually online. He was kind enough to post a video about the whole session. He'll be discussing about the interesting things that we can do during the pre and the post-operative transplant care and for a better patient outcome. He'll be joining us live to take questions also. Thank you. Over to you, Dr. Punnan.
Good afternoon, everyone. I can start with the video. This may have been better addressed at one of the informal parts of the evening functions, but unfortunately, that is not an option. I would like to briefly cover some of these areas, maybe some in little more detail than just headings. What we are trying to achieve is to improve the outcome of a given patient, not a given procedure. In that light, the best outcome would be cure without a transplant, because transplant cannot be thought of as a cure by itself. There are many reversible causes for heart disease or heart failure. Some of them recover with treatment. Some are self-limiting, and we need to keep the patient alive till recovery. Acute fulminant myocarditis may require mechanical circulatory support in order to keep somebody alive, but they recover quite well. Allergic hypersensitivity myocarditis, drug-induced, such as tricyclic antidepressants, antipsychotics, some cephalosporins at times, get better once the causative agent is removed. Giant cell myocarditis and some autoimmune myocarditis may respond to treatment with immunosuppressants. Immunoglobulin may be effective in pediatric myocarditis. Temporary or even durable VADs can work as bridge to recovery in severe reversible causes of heart failure, such as postpartum cardiomyopathy. Bromocriptine is thought to help in postpartum cardiomyopathy. Every newly diagnosed heart failure patient should get supervised trial of guideline-directed medical treatment. Remember, lots of new medications have come after the rematch trial, devices also. One should assess the risk of deterioration or of sudden death and use AICD as indicated. AICD can contribute a lot to keeping a patient alive to reach the transplant OR. Picking the right recipient involves selecting someone with the presence of indications and absence of contraindications. Pay close attention to other organs if they will affect the transplanted heart. Example, lung with high PVR, liver, kidneys, if they will tolerate the rigors of the operation as well as insults that may follow, including low cardiac output, graft dysfunction, ECMO, or other mechanical support. Consider diseases that can recur in transplanted hearts, like some muscular dystrophies, may best be avoided. In amyloidosis of the AL type, you may require an additional autologous stem cell transplantation. And for the familial TTR cardiac amylosis, patients should be considered for combined heart and liver transplantation. Not sure what the impact of tafamidis is on these recommendations, since the drug was introduced only in 2018. Why I'm saying this is sometimes you have to calculate the expenses that may be related to another transplant before we plan the whole thing. ISHLT has laid down the criteria for listing a patient in 2006, and it was revised in 2016. Every transplant personnel should familiarize themselves with these very well-written documents, which need to be read together. Keeping the patient recipient alive and optimized can be a big challenge for our cardiology colleagues. Quite a bit of the budgeted funds may be spent at this stage, particularly when it gets prolonged and you might require an AICD or other expensive equipment. Adequate control of heart failure with medications, long-term use of medications like milrinone, which doesn't depend on receptors and therefore has no tachyphylaxis. Temporary mechanical support are ways to keep the recipient alive till a donor heart is available. The risk of primary graft dysfunction is higher when the right atrial pressure is over 10. Remember that the donor heart is going to be put into an immunologically and inflammatorily hostile environment. Only a few things can be optimized, which should be done diligently. Many of the other factors are not strictly under one's control. Medications such as cordron causes vasodilatation, primary graft dysfunction, and pulmonary toxicity when used with high concentration of oxygen on ventilator or ECMO. The toxicity onset is much sooner than what you would imagine in an outpatient setting. Other heart failure medications such as Bimada can lead to a lot of vasodilatation at the conclusion of the operation. NOACs and other anticoagulants are drugs which are also very painful at times for us. Now, the radial score shows us that the chances of graft dysfunction is dependent on some of the donor factors and recipient factors, but mostly on donor factors. Take the time while you're waiting to improve the nutrition of the patient and get them into a proper rehabilitation program which is supervised. Professor John Walwork made this important quote: "The transplant operation starts with the donor heart. Optimizing the donor and preserving the donor heart translates into improved outcomes. You cannot make chicken out of a fried egg." This book is probably the most comprehensive textbook on thoracic organ transplantation, covering every aspect of it. Unfortunately, the latest edition was published in '96. The chapter on donor selection really emphasizes on the importance of getting a right donor. Today, we try and maintain the heart at least as good as we found it. There may be a time in the future that this may no longer be acceptable, and one is expected to improve the donor organ prior to implant, to extrapolate and quote what Dr. Shaf Keshavji said about lungs. Preserving the donor heart is a great responsibility of the donor team. Often, there is a lot of rush by various teams at the time the flush is delivered. It is important for the donor surgeon to keep checking the adequacy of aortic pressure digitally and ensure that the LV is not distending while delivering the flush. The coronaries should be inspected for color change as they turn from sanguinous to asanguinous perfusion. This step has helped me once when I realized the absence of the color change was from the clamp on my side of the circuit not being removed. When the heart is packed, one should ensure that that is fully immersed in the solution and the apex isn't floating upwards in a pocket of air. It is okay not to rush during the retrieval and packing. Various flush solutions are used. I'm not sure if one is better than the other, but what is generally used is custodial. We use 2 liters of custodial at 4 degrees Celsius delivered over a period of 8 minutes. If I were asked to emphasize on one aspect of making transplant safer, it is for everyone to remember that heart transplant is a knowledge-intensive area. Dr. K.R. Balakrishnan, who spoke about heart transplant extensively in the last decade, when the operation just got started being done in many new centers, always said that one should spend several hours every day reading about it. Surgical steps in standard orthotopic heart transplants haven't changed in 50 years from what was originally described, except for a small modification made by Dr. Bernard in the first transplant itself. So anyone wishing to do this should be willing to go back to the books, journals, and read extensively and keep oneself updated. For the initial period of poor outcomes in the 70s, leading to a moratorium on heart transplant, it was the biopsy and its interpretation which improved the outcomes. Sadly, not much knowledge support may come from our physician colleagues, except in a few places. One good thing about the transplant community in India is that everyone is willing to share knowledge and troubleshoot. It is important to plan your operation in a manner that you would reduce the ischemic time at whatever point you can. Do whatever you can before the donor heart arrives in the OT. Sometimes you can explant the donor heart, prepare the field, stay sutures. And if you have a patient who has had a VAD before, you must plan that ahead. Warm ischemia is the time which is under your control. So consider releasing the clamp after the LA and aorta. Some people even do the right side of the LA off clamp. I'm not sure if additional dose of preservative or cardioplegia is the answer. It is just shortening the warm ischemia, which is going to help you the most. At the conclusion of surgery, diligent de-airing is very important. If the RV is not working at the end of the operation, you have to make sure that it is not because the RCA is full of air. You may require pacing. Inotropes and systemic vasopressors may be indicated. Sometimes for graft dysfunction, you can use IABP and ECMO. Remember, the denervated heart works very differently with drugs. Atropine may not have any effect. Adenosine generally requires only half the dose otherwise. In the immediate postoperative management, remember, Peter Drucker said, if it cannot be measured, it cannot be managed. Perioperative monitoring should include hemodynamic monitoring with continuous cardiac output PA catheter. That is the way we can generally deal with the cardiac output in the immediate postoperative period. There are a host of problems that can happen during this period, particularly RV failure and vasoplegic syndrome. Hyperacute rejection is extremely rare, but acute rejection can happen at that time. Do not hesitate to use ECMO. When you are having to use a lot of inotropes, it is much better to institute some form of mechanical support than depending on drugs. Don't look at ECMO as a failure of your procedure. Just think that you're taking a little longer to wean off CPB. The time may be in days than hours. So there are a lot of things to be concerned about in long-term care, about the immunosuppression primarily, if you would want to use induction or not. About half the people use induction when you look at the ISHLT data. But from my understanding, most people in the country prefer to use induction. Maintenance is standard triple drug therapy. There are ways of doing renal sparing and steroid sparing immunosuppression as indicated. Now, the last thing is cardiac retransplantation, and the cycle repeats itself. Thank you very much for your attention.
Be happy to answer any questions.
Thank you, Julius, for nice presentation.
One of the problems in recipients we receive when these patients first, they are in very low output and needing lot of drugs. We treat them, and quite good number of those patients, they improve by medical management and quietly slip out of your transplant list. That is one of the biggest problem we are facing, and any new center where you are going to start, this you face. Well, about your center, you are regularly doing it, and they understand. But initial few cases, how did you tackle them when you started this?
So I would think that is a very happy. If you were to treat them medically and they improve, that's the right thing to do. But there are patients who will not improve, particularly if good part of their myocardium is damaged with earlier infarcts. That is one group. And those who improve also with cardiomyopathy, at a later stage, they start deteriorating because this improvement doesn't last forever. There are some which are reversible. There are many which are not reversible, but yet you can postpone the transplant for some time and see if they get into a better state before you take them for transplant. So as I mentioned at the beginning of the talk, we should be looking at the outcome for the patient and not for the procedure.
One more question, Dr. Julius. What is your experience about the sinus tachycardia more than 120 or 130 heart rate in the post-transplant patients? What do you prefer, whether codron, calcium channel blockers, beta blockers, or ivabradines? And what is your experience, sir, about that?
So in a denervated heart, you have both problems. Some are bradycardic because of the denervation of the sympathetic system, and also some are tachycardic because the parasympathetic system is gone. So generally, if the heart rate is around 110 or so, I don't really do anything to it. You try and optimize filling and everything and see that. And I really don't like to give codron for sinus tachycardia. That is a drug which can be quite dangerous in this setting, because when patients are on oxygen of any form, the toxicity from codron increases a lot because of the oxygen-free radicals. So one should ensure that they are not on more than 0.5 FiO2 if codron is used in any dose at all. So that includes patients who've had codron preoperatively, which this drug hangs around in the system for ages. Most of the times the heart rate will settle down somewhere between 90 and 100. That is the usual heart rate for a transplanted denervated heart. So beta blockers are probably something which can be tried, but all of these don't work the same as what we expect them to work. Not hear you.
If the heart rate is more than 130, 120, then?
Yeah, first of all, you would want to see if there is an additional problem in terms of output. So that should be addressed. If the cardiac tachycardia is a compensation for low stroke volume as it happens normally, those are the things which should be addressed first. Maybe once you've addressed the factors outside of chronotropy, you may get a better heart rate. So generally what we use is beta blockers if that is required. But I would use a lot of caution in using drugs for this purpose. Ivabradine has also been tried, but we don't have a lot of literature about ivabradine in this setting.
Thank you, Dr. Poonen, and thank you all the moderators for your time. Over to Dr. Sufina.
I now invite Dr. Alok Mathur, Director Cardiac Surgery, Rukmani Birla Hospitals, Jaipur, to present the Dr. P.K. Sen Memorial Oration this year. I kindly request Dr. K.S. Iyer, President IACTS, and Dr. C.S. Hiramet, Secretary IACTS, to kindly take over the session.
Good afternoon, everyone, and thank you. And first of all, from the organizing committee, as I'm a part of it, thank you everyone for showing up for this conference. It's the first physical conference in a long time. And like we say in our dialect, Padharo Mara Desh. Thank you very much, everybody, for coming. I want to thank the association for giving me this honor and this opportunity to be doing this. I see a lot of faces who deserve it more than I do, and I'm not sure why I was selected. And when I asked the president, he said that I am the only one who applied, so I got it. And so you will have to suffer for some time, and maybe a lesson for the next time more people should apply. But what is done, and so bear with me in a pre-lunch session for a few more minutes. So we always start this oration by paying our tribute to one of the legends of our time. And can we start PowerPoint? So this oration is held in the honor of Professor Praful Kumar Sen, who was one of the pioneers. And we always start, and as time passes, the memories fade. But it's our responsibility, and I think the association is doing a great job of keeping him and honoring him, keeping his memory with us and honoring him. This has been going on since 1993. And I'll tell you why. We did a little research on him. And if you look at his achievement, he was born in a slave India in 1915. And look at the first on his CV. And he was a surgeon clearly much ahead of his time. Like this shows, he was the first to perform aortic surgery, first to perform intracardiac procedures, coarctations and atrial septal defects, and also the first in the world and sixth in the world, first in India and the sixth in the world to do a human heart transplant. So not only did he rub his shoulders with the best, he trained in the University of Pennsylvania after his KEM education, but he also brought the science back to his home country. And much ahead of his time, he also started working on TMRs. He was, of course, awarded with the Padma Bhushan by the Government of India for his contribution. And we are really grateful for his contribution, and the association remembers him. What I want to highlight is that he's attempted the first transplant in 1968, and it was only 25 years later that my mentor at my alma mater was successful to do a transplant in 1994. So he was practically 25 years ahead of technology. And this is what is going to be. An oration is not about my surgical skills or a show off or about technical aspects of cardiac surgery. An oration is about a problem that our colleagues and the association is facing now. And I think I based my topic to this newspaper article a few years back, which said that the cardiothoracic and vascular surgery MCH seats out of available 185 in that particular year, 130 were vacant. We thought it would be a 1 year thing and just, some irregularity somewhere which caused it to occur. But this is a problem that has persisted. Somehow, our specialty is not attracting new talent. And if that is not a concern for us, then there's no way forward. Till new talent joins us, the old people can only run the show for so much period of time. So there have been a lot of brainstorming about this, and there have been a lot of blogs, and the people have written, and we all know all this. It's a long period of training. The large team and infrastructure is required to function as a cardiac surgeon. We are competing with intervention cardiology. Our working hours are obscene, and lately the new generation worries about pay grade, and the pay has not been comparable to other specialities or to other branches of profession. I want to add a couple of things which I think are missing from this list. The first is that we have to take it upon ourselves about adapting to new technology. I find ourselves and our association and my colleagues wanting in this aspect, and that is probably one of the things which is making our specialty unpopular. And the other thing I think is important is that we don't factor in the economics required for research and development. I had the good fortune of spending some time at IIM Ahmedabad with healthcare experts, and I saw their approach to healthcare, and it is very different from us. And I have spent a couple of slides trying to highlight what I think is very important for a specialty to survive. So let us start by highlighting what changes have occurred. So if we see CABG, then and now, I arbitrarily take a year in 1990 and this year, and I apologize, there is no effective database in this country, and all these numbers are approximations at best, and quite a few from the industry, which I can't claim are very accurate, but they are an approximation anyway. So CABG, Lima plus Bain, was done in 85% of patients back in 1990, and now maybe more than 90%. OPCAP hadn't come in at that time, and is about 92%. Multiple arterial grafts have grown. MICS, minimally invasive, has picked up, but only about 3% of the procedures are being done minimally invasive in the country. Robotic assisted has just started, and flow assessment has really not kept. And these are the points I took after discussion with a lot of colleagues who thought what has now grown in CABG. Now, I want to address them one by one. Are they really new things? Look at this. OPCAP, surgical reverse correction without CPB. Is it new? We published it in the year 2000, 22 years back. Radial artery, arterial grafts, is that new? Again, published in 1999. Not really a new development. Minimally invasive, this is the study which was published in 2009. 450 cases, not a small study. And it's been more than 13 years now. Intraoperative assessment, very comprehensive article by Randall Wolf in 2003 says that real-time ultrasound and transit time flow monitoring are essential and should be done, and they are very informative as far as revision of grafts and a proof of a good graft are concerned. Haven't really picked up. So I don't think the technology is new. I think we are very slow in adapting to this technology. Let us look at valve surgery. Repairs, less than 5%, 5 to 10% now, a little bit of pickup, but we are not really repairing. Aortic valve repairs with the new Azaki technique, still we are at about 5 to 10%. There is no change in design. There is no technical advancement in the processes available. MICS has picked up a little bit. Industry says about 8% cases are being done minimally invasive in India. And robotic is yet to come. But if you look at mitral valve repair, this article has been published in 800 cases from AIMS has been published 20 years back. If you look at aortic valve repairs, this article by Dr. Ozaki, 800 patients, almost 7-8 years follow-up, 95% reoperation free survival. I would think for a young rheumatic population and for older calcific aortic stenosis, both would hugely benefit if this technology was adopted at least to some more extent than what it is now. But somehow, for some reason, cardiac surgeons in India are not adapting to new technology. Congenital, the major chunk of congenital heart surgery are these 6 diseases, 5 diseases, and there is no change in treatment. ASD, VSD, tetralogy, coarctation, the same. The only new procedure now I see being discussed are root transfers, which are really applicable to a very small percentage of congenital heart defect patients. No real change in technology. The fear of litigation and excessive regulation have got a role to play. They have shackled surgical innovations in almost all fields, and so cardiac surgery is not a way. However, I want to add that the mindset of cardiac surgeon is very important factor in the list, and I will like to explain why. Look at other specialties for the last 30 years. Look at the procedures added in cardiology. You're all aware, we are competing with these procedures. There's a huge list of procedures which the cardiologists didn't do 30 years back, but are doing now. Okay, you don't like a medical branch? Here is a surgical branch. Urology, has practically gone totally endoscopic. You hardly see a skin incision in a urology operating room. And so is true for ophthalmology and orthopedics. They are adding procedures all the time. Cardiac surgery is not. And even if cardiac surgery is adding procedures, somehow we are not adapting. Let me highlight a few technologies which are readily available in our country but are being seriously underused. 3D printing. They are using echo and CT images to print real-time 3D models. It is very, very easy to do. It is not very expensive. For congenital heart disease, where it is being mostly used. It is very useful. Senior surgeons may not need it, but surgeons with lesser experience would definitely benefit if they were to have a model of the heart that they are going to see the next day in the operating room, about routability of VSTs, about actual practicing the procedure before going on to a live patient. The implications to adult cardiac surgery are also huge. Intramyocardial LADs, the length of chordae, you can actually measure and go in the operating room prepared with loops of the specified length and be very confident about it. Somehow we hardly use it. A beautiful multicolored 3D graph available, just echo and CT images are needed. Ozaki procedure. It's with a template and a little bit of practice, it is very, very easy to do. And it is a huge competition for a TAVI procedure if we are able to do with the expanding, indications of TAVI in young adults and low-risk patients, and the surgical associations not raising any objections to these modifications of indications. This Ozaki procedures has not really taken up in India, the country which needs it most. Long-term results may not be good, but it will give a good life and a good quality of life without anticoagulation for our young patients and for our older patients, calcific. But we are hardly using it. MICS, I personally have been doing this for almost 12 years now. It is a technology that has been standardized. We do all our valves through minimally invasive approach, and a lot of CABGs are not being done on minimally invasive. Somehow it is not, only 8%. The industry says only 8% of valve replacements or repairs are being done through a minimally invasive in this country. We have presented our own personal experience in multiple international conferences and multiple conferences in India. Me and my colleague who started here, Dr. Goyal, our combined experience now crosses 1,500 cases. We have done double valves, mitral valves, bypasses in India, and if I can do it, I'm sure it is applicable to most of the surgeons in the country. The technology is not picking up, seriously underused. We have started endoscopic robotic program. This is from Apollo Hospital who started their program, not really picking up. Endovascular aorta, and this is from Dr. Bashi's center, very much in India. They have such nice results with hybrid endoscopic vascular surgeries, very acceptable mortalities. Not many centers I see doing endovascular aorta. Arterial grafts, something as basic as multiple arterial grafts. It's been proven beyond doubt in the study of 6,000 patients published in way back, 10 years back by Dr. Brian Buxton. And his conclusion was that the patient benefits immensely if we use multiple arteries. To the best of my data, 2 arterial grafts or more are used in just 22%. Bilateral memory are used by just 4% of surgeons in the country. So technology available, but we are not seriously using it. Intraoperative flow assessment by high resolution ultrasound and transit probe, to verify your graft and also to give an authentic thing to the world, to the patient, to the cardiologist that you put in a good graft. Very easy to use technology, not very expensive also, not really used in this country. So that was about technology, and I think the mindset has got a serious role to play about this. The other point today I want to touch is that we have tried to control the cost of surgical procedures. Initially, it was a competition with cardiologists. We thought CABG is not going to survive when stents came in. So we brought down the cost. We tried to keep our costs really low. And at the base of it, for some of us surgeons, compassion was also, for patients was also a factor, because we are a poor country, and so keeping cost, and we did a lot of charity, and we did a lot of charity congenital programs, and we tried to keep the cost very low. But this has required a blatant and ridiculous reuse of things. We use octopus stabilizers for multiple cases. We think we are helping the patient. Well, actually, we did help ourselves. We survived the challenge by cardiology. CABG numbers have never gone down in this country. But what is the collateral damage? We suffered a lot of collateral. They advise us to the government, and I appeal to all the government doctors and senior doctors sitting who work for governmental organizations. They advise low prices to the operation. So Bhama Shah and Chiranjeevi and Ayushman Bharat will traditionally have low cardiac surgery price. What is the advantage? They get, they seem to get appreciation from government, and they think more patients will go to government. Actually, that is not true. What is happening is the private institutions have started compromising on quality to justify these low packages. And so we reuse everything, and this is what the corporate sector gives you. The cost of bypass, 22,000 rupees, cost price of disposables and medicine. Ridiculous level. So we have managed to keep the cost low. But please answer my question. Where is the cost for R&D factors? And if we don't do research and development in Ablant, how is the technological advancement going to help our branch to survive? We are not going to be tech savvy, and the newer generation is not going to come till we get the money for R&D. So this cost control has got two collateral damages. There are two losers in this sequence of events. Our specialty is losing, and it is not, let's stop being in denial. Our specialty is not really very popular for newcomers. The quality of care for the patients is also deteriorating. Nobody's talking about quality. So those things have suffered as a collateral damage. A little bit of about positive reactions, what we can do. We need to involve the industry. We need to give them more business so that they can finance our research and development. We need to encourage and support the younger generations to adapt to new technological skills. There should be programs during MCH in which they spend time in cath lab and learn wiring skill. Don't expect us 50, 60 years old to go and learn skills now. But we should support our younger surgeons and the MCH residents to go and learn skills which are new. Go to centers which do minimally invasive. Learn those skills. And the training program, it is high time that the association intervened and said that we need to standardize a curriculum for training. There has to be an X number of cases, X number of variety being done at a center for it to be able to give an award, a degree for cardiac surgeons. We have to break these two myths. We have to use the technology available. Cardiac surgery, we have to break the myth that cardiac surgery will survive without tech advances. We have to break this. I don't think it is going to survive till we advance technologically. And we have to break the other myth that cardiac surgery should be the cheaper option. Not true. We need money for R&D, and that will always come from the industry. Our specialty is struggling, my friends, and denial has never worked for anyone. But I will end at a positive note that this forum probably has the smartest minds in the country. I'm hopeful that they will get together and find a solution so that for the next generation, we are better equipped to give them a technically sound and advanced specialty. And with that, I would like to end my oration. Good luck to us, and Jai Hind. Thank you very much.
Good afternoon. The Indian Association of Cardiothoracic and Vascular Surgeons, by virtue of authority in it, recognize and felicitate Dr. Alok Mathur, the Praful Kumar Sen Memorial Oration, for his innumerable and noteworthy contributions to the subspecialties of cardiothoracic surgery. His commendable services to the nation, society, and progress of cardiothoracic surgery have been recognized in manners befitting the virtuous memory of Dr. Praful Kumar Sen. In testimony whereof, we have subscribed our signatures and caused the seal of the association to be affixed hereunto. Awarded this 7th day of April 2022, duly signed by President of ICTS, Dr. Krishna S. Iyer, Secretary of ICTS, Dr. C. S. Hiremat.
The luncheon symposium sponsored by Merrill, we have Dr. Josh Chako Periapuram, HOD Cardiothoracic Surgery, Lisi Hospital, Ernakulam, present the evidence and experience of daffodil tissue valves. Dr. Josh Chako Periapuram, HOD Cardiothoracic Surgery, Lisi Hospital, Ernakulam, will now present the evidence and experience of daffodil tissue valves. And Dr. Hiremat, Secretary IACTS, will chair the session.
All right. So good afternoon to all of you. Respected Chair, Dr. Hiremat, my dear friends. I'm going to talk about the tissue valves and my experience with daffodil valves, which is purely an Indian-made valve. And always we have doubt about which valve has to use. I think valve surgery has got various variables with age, with indications and contraindications for anticoagulation and various factors which may make a surgeon, however senior he is, to choose which valve he has to use on a particular patient. There is an increased amount of interest in using tissue valve compared to mechanical valve recently because of a multitude of reasons. Mainly the quality of life of a patient, freedom from anticoagulation, and even the new generation valves are much more longer lasting. I remember when I was a trainee surgeon, most of the time we used to tell the patient that the tissue valve is going to last only for 5 years. And Carpentier valve was only tissue valve available at that time. Now we have valves which last for 10 years, 15 years, and even the companies claim that the valve can last up to 30 years. So the longevity of the valve life and freedom from anticoagulation and the quality of life is an important factor in choosing which valve has to be used. There is an algorithm of valve choosing, and obviously most of the surgeons will be familiar with this algorithm, and I don't want to expand into that. Now, whatever the indications or contraindications, I don't think a surgeon should venture into doing something which is rare for him, which is strange for him. I think the best valve is the valve which is most suitable for that particular surgeon to use, and mostly familiar. The surgeon should be familiar with the valve or the product which he is using. Now, our experience with the daffodil pericardial bioprosthesis, I have no disclosures to make. It's a simple study, retrospective study of 18 months usage of daffodil valve, which I will come to it now. The the salient features of daffodil valve. It's a highly durable valve in vitro test which is proven, and it has got optimum coaptation. It has got a unique delivery system for mitral valve. It is MRI compatibility. It is a latex-free product as well. There is multiple features which are positive features for the usage of daffodil valve. The device description, it's a tri-leaflet valve, and it has got a fabric which is a polyester fabric for suturing, a good sewing ring. The suture markers are there as the usual valve, and Elgiloy is an alloy which is used for the valve studs as well. And it is kind of a standard valve which is not much different from the gold standard valves which we use nowadays in our current practice. It has got a high durability because of the anti-calcification treatment which they have devised on their own. Not only glutaraldehyde, there is a glutaraldehyde removal, and proper anti-calcification measures are being done on this valve. In Lissy Heart Institute in Cochin in Kerala, the last 18 months we have done 226 tissue valves altogether, which includes 123 aortic valves and 103 mitral valves. And this is a distribution of the valve usage. About 30% of our valve has been daffodil, made by the Merrill. We have got about 20% peri-mount valve. About trifecta valve is about 20%. Trifecta LPL valve is about 24%, and the porcine valve forms 4% of the total usage of tissue valves. In the mitral area also, we have got about 29% of daffodil valves. I have started using daffodil valve only in the last year and a half. The perimount valve about 33%, and the pericarbon more 34% in the mitral position, and few porcine valves as well. That is the distribution of the valves. In the total number of Merrill valves in aortic, we have used in 36 valves, out of which 11 were 19, 21, 21, 4 valves 23, and the mitral position 13 27 millimeter valve, 14 29, and 2 31 millimeter valves. We have 6 double valve replacement using daffodil valve. The demographic characteristics include age. A mean aortic valve replacement, the mean age is 68.9, and for mitral it is about 67. And gender wise, about 60% are male population and about 40% forms the females. Concomitant procedures with aortic valve replacement, 55% are isolated aortic valve replacement, while 27.8% had CABG, 13% had an attached mitral valve replacement, and 2.8% had concomitant MVR plus CABG. On the mitral valve side, we have done 29, out of which isolated MVR was 41, with the tricuspid valve replacement with CABG is about 7%, CABG with MVR 27, and Bendal 3.4%, AVR along with MVR was 17.2%, and AVR with CABG was 3.4%. Coming to the hemodynamic performance of the daffodil valves which we have used, we have good clinical outcomes. We had a mortality of 3 patients, and all the 3 were unrelated to the valve per se, or the valve procedure per se. There was multiple comorbidities which I have not expanded. Major and minor bleeding, there is only 1 in mitral. Valve thrombosis nil. Re-exploration 2 in the aortic and 1 in the mitral position. Atrial fibrillation 6 and 5 each. Pacemaker implantation 3 for aortic and 2 for mitral. There was 1 trivial paravalvular leak in a non-aortic patient. Valvular regurgitation 1, and no infective endocarditis and CV on 1 patient at the end of an year. The hemodynamic performance, I am not going into the individual characteristics of it, but there is a definite regression of LV mass in grams at the end of an year in patients after aortic valve replacement. The peak gradients of aortic valve replacement at postoperative phase, 3 months, 6 months, and 1 year is given, which is very acceptable for the respective sizes in colors which we have used. The mean gradients of aortic valve also at 3 months, 6 months, and 1 year is quite acceptable in comparison to the gold standard valves which is available in the market. This is the graphic representation of comparison of hemodynamic performance of different daffodil valves 19, 21 and 23. We have got peak gradient, the mean gradient and effective orifice area which is quite matched. This is an aortic valve. Just I am showing the aortic valve on its holder in preparation for implantation. And the first picture shows the preoperative picture of aortic stenosis, and the second picture shows the nicely placed aortic valve in the respective position. In mitral valve replacement also, the hemodynamic performance was excellent, with a big regression of the LV mass at the end of 1 year. And the other parameters are also quite acceptable, including the ejection fraction and the diastolic and systolic diameters of the left ventricle. The peak gradients of mitral valve also at 27, 29 and 31 millimeter from post-op immediate and at the end of 1 year is being given, which is extremely acceptable figures, and also, as I said earlier, in comparison with any valves available in the market. Mean gradient also remains much acceptable. Now this is the daffodil mitral valve which is available now. It is very nicely structured valve which has got a holder, which has got a rotator, and which has got a nice rotator which you can push down into the valve leaflets to prevent any suture entrapment. It is easy to use, and the annulus is extremely flexible, and it really merges with the patient's mitral annulus at the end of the suturing technique. It has got all the features which is needed for a valve safety implantation, and easily slides through the sutures, and obviously once you use it you realize how easy it is to be implanted. The mean effective orifice area in aortic valve and mitral valve is extremely good. As you can see, the graph shows the effective orifice area and the index of the valve at various durations of post-valve implantation. Now this is one of the first papers published by our respected chair, Dr. Hiramet, has led an aortic valve first in man human trial in 2020, and he has given the comparison of effective orifice area of different valves. As you can see, the first part, the 3 columns belong to daffodil, and the next one is Magna East of Edwards, then Medtronic, Biocor, etc. And you can see the effective orifice area index is much better compared to many valves available in the market now. You have got only one red column on the left hand side which belongs to the daffodil Merrill valve. That is less than 65%. So it is very comparable, and actually even much better than the parallel mitral valves available in the market now. And we have seen it in the clinical as well as post-operative follow-ups, the same findings in our series of patients as well. Our patients at the end of 1 year has got a NYHA bars which you can see both aortic and mitral compared to the preoperative. Almost complete patients are in NYHA class 3 or 4 at the end of an year, both in mitral as well as an aortic valve. And the quality of life after aortic valve replacement in PCS score, physical score as well as mental score, as you can see, is about 55% and 52% respectively for the aortic and the mitral valve, which is quite appreciable. And the hemodynamic performance of aortic valve both pre and post-operatively at the end of 12 months is given there in comparison with the daffodil, trifecta and perimount. And you can see there is a substantial improvement, and in comparison also you can see the daffodil valve is much better in many aspects, especially in the effective orifice area index, which is probably the standard factor which we follow in long term for post-valve replacement patients. The quality of mitral valve replacement, as I said, in the aortic valve by PCS as well as MCS score is quite good. And here again, in comparison with Perimount, here I've compared only with the Perimount, the mean gradients of 25, 27, 29 and 31 is same as the Perimount, but as it comes to the effective orifice area, I think there is a substantial increase in daffodil valves. That's very striking. The second half of the graph, if you look at it, the effective orifice area in comparison with the Perimount is very, very high, and so is effective orifice area index as well, as I have shown in the chart which is being published in the National Journal. So in conclusion, on daffodil tissue valves, it has got a good architecture, it has got good durability, nice implantability, as I have shown, excellent hemodynamics, and it is affordable as well. You can see it's only half of the price of the standard imported valves, and it is made in India. So with multiple factors, I feel that a daffodil valve is something which we should entertain, and we are quite experienced in the valve, and we are quite happy with the patient compliance, the cost, as well as the post-operative follow-up using daffodil valve. Thank you very much.
Thank you, Dr. Jose. In fact, there's a very good collection of your bioprosthetic valves, and in your studies, you have you utilize around 30% valves of aortic and 29 of mitral, the first make in India valve. It's very good to know it. Any questions from the audience we have regarding the valve? Yes, Dr. James Thomas, please.
Jose, thank you for that presentation. You know, the concern is that we have a lot of young patients in India who need valve replacements. How are you comfortable in putting these tissue valves in the 40s and 30s, or is the redo, is it a issue later years? Because we have put a lot of prosthetic valves, you know, maybe a few thousands, but then tissue valve usage has been. The second has been the cost of the valve. In the US, when they have $5,000, we get valve for 1,500 here. So an effort should be made to reduce the cost of these valves. Now, since they are implanted in India, I think if the cost can come down, it will be a great.
Yeah, okay. Thank you, Dr. James. And both are valid points. The selection of valve is very important for young people, especially the age group between 40 years and 60 years is a gray area, where I think we should explain to the patient about both valves in detail, about the implications, advantages and disadvantages of using both tissue and mechanical valves. When I presented a tissue valve paper in Chennai some years ago, I was told by most of the surgeons that they never had more than 10 years of life with the tissue valve life. But our experience is very different. We have got tissue valve patients, a young patient, 29 years, I put a LabCorp valve, which is not, I don't know whether it's available now, and 25 years down the line, he is doing extremely well with a normal sinus rhythm and low gradients. And we have got a huge collection of tissue valves in all makes, who is living well 10 years, 12 years, 13 years, and the re-exploration or redo rate is much lower, provided the implantation is good, good excision of the valve, and usage of anticoagulation was 6 months at least, followed by dual antiplatelet for 1 year, followed by at least one antiplatelet, and definitely statins. And regular follow-up with them is very important. I think we will get very good long-term results with the tissue valve in young people. The quality of life which they enjoy will be tremendous. They can go into sporting activities and they can live as if they are living with their own valve. And about the cost, I think it is something not comes in our purview. But definitely the Merrill valve, I think it's somewhere around 1.3, 1.4 lakhs, maybe even less than that, maybe 1.5, while the Perimount is somewhere around 2.5 plus, you know, depends upon institutions, and the trifecta is maybe a little cheaper. So it's almost half of the valve which is price of the valve which is imported with excellent results, and as I have shown, and we have to wait for the long-term results, but having an excellent result with the short-term, we expect that long-term result also is going to be good. Thank you.
Any other questions? In fact, as Dr. Jose pointed out regarding the valve, I happened to use it around 46 cases way back 4 years back when the first trial was the first human trial in our country. It was done, and in fact, I was called by the DCGI team, when they got the valve patented, the amount of questions they asked was quite extensive. And they got DCGI approval, and subsequently it was in the market. Wherein I happened to do a root enlargement procedure using this valve, body weight of around 76 kgs, wherein we ended up putting annulus of 17, ended up using a 23 size valve aortic position. 4 years, 3 months till date. He's doing quite well. Not much of gradient, around less than 10. And even the Wheats procedure, that is, if required an aortic interposition graft after following an aortic valve replacement, even that was done and follow-up is adequate. So I don't think there is a concern regarding the valve per se, irrespective of the best part is we need to support the Make in India concept. And even Chitra, today we have 1.6 lakhs Chitra valve implanted. And after 29 years, patient Muralidhar is still alive, Balakrishna. Surgeon also is alive after 29 years of implantation of the valve. We had issues like this, and Chitra is a living example. And seeing that countries like Bangladesh, Pakistan are using Chitra valve today. Similarly, I do not find any reason, because yes, I have done the maximum in the clinical trial. It was challenging. It was not easy. We do have ethical committee challenges. We lost around 4 cases in the follow-up also. And but not valve related. Other discussions were there. We have a presentation subsequently in the next 2-3 days. Any questions regarding this valve per se, I am ready to answer. Dr. Jose has used them good number of cases. We are ready to clear any doubts on usage of this valve. I beg your pardon for my voice. I lost my voice today morning.
I think all secretaries lose their voice during conference times. I would say very reassuring that the surgeon also is alive after 39 years of valve implantation as well as a patient.
Yes, sir.
And this valve, to add on another point, it's very much suitable for in-valve TAVI procedures as well. It can be cracked easily.
Very important point. Valve in valve TAVI, they can go with their own valve. That is my valve. Wherein, if I ask, even my valve, I end up recommending cases, elderly patients whom associated coronary artery disease, who do not want a surgery. Recently, 2-3 patients we referred, where the cost comes, they give a package, you request, and they work out a package of around 13 to 14 lakhs for my valve. Whereas you go for Edwards Effins or the other valve, which goes up to 30 to 35 lakhs. Every Indian can't afford. It's a big challenge. So one has to really relook into it when we advise a patient to go for a bioprosthetic valve, whether it is transcatheter procedure or an open procedure. If patients are affordable, you explain both the risk and advantages of these valves to the patients, and I think they can take a call on this. Yes, please.
I'm sorry, I might have missed. When was the first valve implanted in India, this particular doctor?
In my center or in India?
No, in India. So when was it officially?
The first valve was implanted by Dr. Hyramat and their team. That is 2018.
Before me, the first valve was implanted in Ahmedabad. Any Amaril team is here? Can you clarify the doubt? First valve implanted, yeah. Vinith, you can just make it clarifications. Take a mic, please. We can't hear you.
Yeah,
2017.
2017, and how many implants so far? 1,500. And I hope we do have a registry of these valves, because see, there were few valve malfunctions which were reported even in our group, and which was communicated to the company. In fact, I think I had discussion with him. There were 3 cases reported in a span of 6 months. One patient had presented with severe gradient just 4 or 5 months post implant. And I think company had taken a note of it. What I'm basically trying to understand is what is the long-term data as of now we have, rather than just having this small study which was conducted.
The long-term data is 110 cases, which first was approved by the DCGI. In 1 year, they were allowed to do only those number of cases.
Okay.
60 mitrals and 60 aortic. That was the division given. And various centers across the country. That is the long-term follow-up of 4 years plus. if I am right, Maril.
Yes, sir, you're right. So if you see even the prevalence or the statistics on it, I've said that 1,500 has been implanted so far. Out of that, 3 reported cases which has been found. So
Amazing.
Hello.
Thank you.
I want to clarify. I lost a case when I was operating for a mitral valve. I took it immediately. In fact, I am open for discussions. I went inside, checked the valve, sent the valve midnight to Ahmedabad for an analysis. The report came that there is no damage in the valve per se. Patient was prothrombotic. After that, I started my patient analysis before including this clinical studies to get protein C, protein A deficiencies. And in that study, I found I picked up one case with protein A deficiency, which I did not add him in the clinical trial group. In fact, the ethics committee is a DCJ ethics committee at our institute. In fact, they took me left and right for the classes. I had prepared a booklet of 400 pages and I read all the articles coming from bioprosthetic valves, whether what all they have undergone clinical during Edwards valve or any bioprosthetic valve which we import today. If you see their clinical trials, they have deaths. It's not that Merrill has a death or Chitra has a death. No, we need to look into those clinical trials. And I presented in front of the ethics committee. They appreciated that even in clinical trial, we do lose cases. The reasons for what? 1, 2, 3, multiple reasons. You explain them that this is the procedure for any human clinical trial. If you ask me, this was the first clinical trial in the country in a heart valve, apart from prosthetic, the bioprosthetic valve I am talking. So they accepted and I was allowed to continue the clinical trial in our institute. Otherwise, they had asked me to stop. So 1 death here, 2 deaths here. In the follow-up also they have lost cases. In drop they have lost cases. All bioprosthetic valves today in the market are run. Some were stopped because of certain issues. So those things are always there. We should keep our mind open and look into these facts. How many patients have benefited? TTK Chitra is not FDA approved. FDA refused the Chitra valve approval. Have we stopped it? No. Every Indian has a Chitra valve. In fact, I have a maximum replacements of Chitra valve. Why? It is 1.7 lakhs have implemented today. Design is not changed. Nothing is changed, but it's going on. Similarly, we have to look into those aspects. We need to change our own attitude. Yes, a valve has given a problem. Find out what is the reason. Give a feedback to the company. The first mitral valve I replaced, I had struggled a lot. I gave them entire feedback. They changed the design of the valve. And subsequently, it was taken care wherein while inserting the valve into the mitral position, you had to struggle to tie the sutures. The sutures were getting stuck in the studs, which I told them. I think within 3 months, the company came forward with a change of design, and after that, there were no issues as such. So one has to look into handling of the bioprosthetic valve, which is another challenge. One should never touch the leaflets. They have got their own tester which has to be used. These are the minute details which you need to take care. And I think, and failures are there. Even if you take an import, any other valve also, definitely we do have lost cases. Thrombosis have occurred. All these things are there in reports, in literature.
In this context, I just wanted to mention about a porcine valve which I placed in the aortic position. The patient came back 3 months later with some breathlessness, and when we checked the aortic valve, the gradient was 230 across the prosthesis. Unbelievable high gradient across aortic valve. And one of the daughters was in States and a nurse, and the cardiac surgeon in America said immediately he need to have the valve replaced. And I said, no, you just wait. We added anticoagulation on top of it because anticoagulation was stopped at 6 months. And I told him, I kept him in the hospital, gave heparin. And after 1 week, when he left, the gradient came down to 150. And he was discharged home, and then it came back to 70. And now, after 2 years, his gradient is only 30. I don't know how it happened. There may be some mechanism where the leaflet approximating areas stick together, either the thrombus or something which is very rare for, it may be patient related than the valve related. So high gradients probably do happen with every valve once in a while.
In fact, the patient whom I referred, I want to express this, wherein I asked for an Edwards valve, bioprosthetic valve and all. The cardiologist who works in a high volume center, who never come across in contact with the industry, recommends me to use my valve, which is he already their experience is 4 years plus, and they've seen the results. I was surprised because I was using daffodil valve when the cardiologist is referring, telling that Dr. Hiramat will go for my valve, which will be done in 13 lakhs, whereas 30 lakhs, 35 lakhs is the adverse events valve one has to face. So I think we need to relook into this and then plan. Any other questions from the audience? We are happy to answer. And one more thing, in my institute, we don't meet the industry, they meet directly the administration. And my job is only to replace the valves.
So thank you.
Any other questions? We are ready to answer them. Yes, thank you. Thank you.
Thank you, Dr. Chako, for highlighting the importance of evidence in the practice of medicine. Thank you, Dr. Hiramat, for their engaging discussion. For the next session, we will have a pre-recorded presentation on surgical implantation of sutureless aortic perceval valve by Dr. Ajit Bana. Dr. Ajit Bana is the chairman, CTVS Eternal Hospital, Jaipur. I welcome the moderators, Dr. R.M. Mathur, Dr. V. Devaguru Velayudam, Dr. Shiva Muthukumar, Dr. Ashwini Pasarath, and Dr. Bhupesh Shah to the dais. The talks in this session will be timed at 10 minutes, followed by a discussion of 3 minutes. I request the speakers and moderators to kindly adhere to time limits.
Good afternoon. Welcome to Jaipur. We all surgeons know that TAVI has changed the scenario of aortic valve disease treatment. Today I'm going to show you a surgical treatment of aortic valve disease which is better than transcatheter therapies. This is with the introduction of Perceval sutureless valve. It is a pericardial valve with a double sheet design, carbofilament coating on stent, and the superelastic stent. It has proved that structural valve dysfunction is less than 1% up to 11 years in this particular valve. It facilitates minimal invasive surgeries, and our procedure time can be reduced from 25 to 60%. And it is indicated in all those patients who are sensitive to cross-clamp, like older patients, high-risk patients, patients who have a challenging anatomy, like calcified root, small aortic annulus, or patients who need a minimal invasive procedures. Important to note that for this particular valve, the sinotubular junction to annulus ratio should be 1.3 or less. Means aorta should not be dilated. Number two, patient should not have a true bicuspid aortic valve, means Sievert's type 0. These are contraindication for Perceval sutureless valve implantation. Now we have one more important thing, that Perceval Plus is available. Perceval Plus valve is the latest development which has a less ventricular protrusion. It means less chances of permanent pacemaker implantation. As well as this valve, in this particular valve, the phospholipid has been removed from the pericardial, capping of aldehyde is done, and it is stored in aldehyde-free solutions. It means that this valve have less calcification in duration of, in course of time, and it is going to last long. Let me show you the minimal invasive aortic valve replacement through upper partial stenotomy, and this is the first Perceval Plus implantation of India. In this particular patient, we have opened the groin vessel through the right femoral artery, which we usually do always. Minimum dissection is required, bursting sutures are taken. And important to note that whenever you cannulate either a femoral artery or the venous, always check your wire. Like in descending thoracic aorta, for vein, we always check wire into the superior vena cava, because we are going to advance our venous cannula up to the superior vena cava for the better drainage. Upper partial stenotomy up to 4th intercostal space is required. And after doing stenotomy, proper hemostasis is secured. After securing a proper hemostasis, we open the pericardium. It is important, when we open the pericardium, keep doing hemostasis then and there. Do not leave it for later on. A complete pericardium is open in the incision, only into the incision length, and it is hooked up by multiple stay sutures as well as into the retractor, so that the aorta comes into the surgical field. Tape the ascending aorta, and patient is on full bypass, and then we cannulate the right superior pulmonary vein and vent the LV. It should be properly placed into left ventricle, which is very easily can be advanced. And after doing this, put a cardioplegia needle into the ascending aorta, which is little higher because our aorta is going to be high. Put a cross clamp give cardioplasia. In this particular patient, we have given cardioplasia. After resting the heart, we are doing a transverse aortotomy. Important to note that in this particular valve, aortotomy should be transferred. It should be high. For the small and medium-sized valve, the aortotomy should be below the fat pad of ascending aorta, whereas for the large and the extra large valve, the aortotomy should be at the fat pad or just above the fat pad. The transverse aortotomy is very important for perceval suture as well. After doing aortotomy, we can take multiple stay suture of silk so that the aorta is well opened and we can see the aortic valve. It is important because aortic valve is placed deeply into the incision. We take three sutures to pull this valve up into the aorta. And after pulling this valve up, we remove all the diseased valve and do decalcification properly. Sometime during the process of decalcification, we can open the annulus or we can, muscle is exposed. If the muscle is exposed, put a fluoroproline matter suture to secure this. After securing the proper annulus and cleaning everything, then we put three guiding sutures. These guiding sutures are always placed into the center of sinus. Three guiding sutures for three sinuses. After placing proper three guiding sutures, we again clean the aorta and remove the sutures which we have taken onto the commissure to pull the aortic valve up, because it is important. If the aortic valve is pulled up, we cannot place the valve. So after removing all the sutures, cleaning the aortic valve, now it is important to size the valve. How to size it? We have two operatives. One is a transparent, it should cross the annulus, whereas the white one should not cross the annulus. This will just stuck above the annulus. It means this patient is requiring larger size valve. This is the collapsing of the valve into the collapser, and then inflow cannula is tightened, and then after tightening this inflow, we put a smart clip so the valve holder is properly placed the valve. And after completely placing the valve into the valve holder, the valve is checked, and it is, you can see by this picture which is taken from the TV, that the three guiding sutures are in place. Aortic valve, you can see in the picture, and the guiding sutures are now being passed into the eyelets onto the aortic valve prosthesis. There are three eyelets onto the aortic valve prosthesis for all three guiding sutures. After placing the guiding sutures, we advance our wire holder downwards into the ascending aorta. It is important when we advance our valve into the ascending aorta, our guiding suture will remain taut and straight. Otherwise, we will not be able to deploy the valve. You can see that our guiding sutures are tightened and straight. The valve is being advanced into the ascending aorta, and when this valve will reach to the annulus, we can clearly define it. We should always check that whether the valve is been sitting properly into the annulus, which we are doing right now. The valve is checked, whether it is placed onto the annulus. After checking the valve, we deploy the inflow portion of the valve first. After complete deployment of the inflow portion, we remove the smart clip, and after sometime it takes a little pressure to remove the smart clip. After removing the smart clip, we remove the inflow guide. And after removing the inflow guide, you can see the valve is in place at the annulus, and stud is in the ascending aorta. Check the valve position where it is properly, should be at the annulus only. After checking the valve position, we place a balloon. This balloon is inflated at the 4 mm mercury of pressure, and it should be inflated for 30 seconds. And during this time, we place a warm saline into the ascending aorta, because nitinol stent will expand further by warm saline, as well as the patient's body temperature, it will further expand. We have checked the aortic valve, it is placed properly, and then remove the guiding suture. So there is no suture left into the ascending aorta as well as the annulus. And now we are closing the aortic aorta as usual. You can see post-operative echo and perfectly functioning valve with a gradient of only 9. Perfectly functioning valve. Closure of the chest is done in routine fashion. The second patient, minimal invasive aortic valve replacement using a perceval valve through the right anterior thoracotomy. And this particular patient, again the femoral vessel are exposed, as I told you, with a minimum dissection. Pursing sutures are taken, and after taking pursing suture, we make an incision right into thoracotomy. Always for the perceval sutureless valve, it should be onto the second discourse space, because our aortotomy is going to be a little higher. We can cut the rib either by a saw or by a scissor. Now place a soft tissue retractor so that our incision, all soft tissues go away, and put a retractor, expose the thoracotomy, and then you can see open the pericardium. Take as many stay sutures as required so that the aorta come to the operative field properly. it is important that always bring your aorta into your operative field. Cannulate the femoral artery and vein. Femoral venous cannulation is important. As I told you, always check your wire into the superior vena cava and advance your cannula into the superior vena cava for broader drainage. Sometimes right renal appendage is very big. In that case, put a right pulse string and pull the right appendage away. After pulling this, patient is on full bypass. Now put a right superior pulmonary vein vent, and which will go into the LV, and vent. Heart should be vented properly. After this, cardiac needle, aortic cross clamp, arrest the heart, do a transverse aortotomy. As I told you before, after putting multiple stay sutures, you can expose the valve, and after exposing the valve, now remove all the diseased tissues as well as the calcium from the aortic valve. In this procedure, sometimes we can open the annulus muscle exposed, that should be fixed by the mattress poroprolene suture. After doing that, we take 3 guiding sutures in the center of every sinus. These guiding sutures are fluoroprolene, and the needle should be from inside out. These guiding sutures are the sutures which are going to take the valve into the annulus. Now, after sizing, collapsing of valve done, after collapsing, we always check the valve, and you can see the eyelets for the guiding sutures are here. Now pass the guiding sutures into the eyelets which are present on our prosthesis. These guiding sutures will take this valve into the aortic annulus. You can see now the guiding sutures are tightened. We are advancing the valve into the ascending aorta and through that into the aortic annulus. Or when the aortic valve reaches, prosthesis reaches to the annulus, always check whether it is sitting nicely at the annulus. And when we are sure about it, deploy the outflow ring first. After deploying the outflow ring, remove the smart clip. As you can see here, removing the smart clip. After removing the smart clip, outflow ring guard is removed. After removing the outflow guard, valve is deployed. It takes hardly few minutes. After now, put a balloon inside and dilate it, as I told you, 4 minutes of mercury for 30 seconds, and put a warm saline into the same aorta, so a nitinol stent should be dilated properly. After this, check your valve. Always check whether the annulus is visible or not. Annulus should not be visible at all. We are sure that the valve deployment is good. Now, close the aorta in a routine fashion. Remove the vent. Dearing process is the same as we do for the routine bypass surgeries. And after removing vent, we check the hemostasis of the aortotomy and remove the cardioplegia needle or aortic vent needle. And now the heart is beating properly. You can see there. And through our incision is very small, and you can see the gradient is only 7 post-operative, and valve you can see through this echo is functioning very well. So this sutureless aortic valve replacement with minimally invasive AVR is a direct visualization, annular deployment, shorter cross clamp, and fast aortic implantation. This procedure has addressed the limitation of both surgical aortic valve replacement and TAVR. So I have experience of about 31 patients with mean age of 67, ST score around 3. Few patients had RBB and LBB. Mean gradient was 50. Isolated aortic valve replacement were 20 patients. Mini stenotomy and RET in majority of patients, with the AVR CAVG in 11 patients. You can notice here the majority of patients have received either medium or large size, means 23 to 25 size. It means the surgeon can place a larger size valve by using a Percival sutureless valve. We are following these patients very well, and you can see that 1 year the gradients are well maintained. There's no parallel leak, and which few of the patients have shown improvement in their left ventricular ejection. So to conclude, this is a choice of bioprosthesis in aortic valve replacement. It will help reduce the complexity even in challenging and time-consuming procedures. Percival will allow precise positioning in minimal invasive procedures, as well as it valuable option if we want to reduce our post-operative complications and post-operative time, especially in high-risk patients. So, best option for a small aortic root, minimal invasive aortic valve replacement, faster implantation to reduce CPB and cross-clamp time, and excellent hemodynamics. You want use Percival sutureless valve. Thank you very much.
Dr. Ajit Bana is not available here. We have Dr. Anuj Sangal, Associate Consultant at Eternal Hospitals, Jaipur, in his place to take questions, if any.
Anup, how do you select the patient? Which are the patient you will offer this?
First of all, the inclusion criteria is if the patient chooses the sutureless valve, then the exclusion criteria for sutureless valve are dilated ascending aorta, bicuspid valve, the patient is not opting for a sutureless valve, or the aortic annulus is less than 18 mm. Then these are the... And patient above 60 years of age.
Okay. Above the 60 years of age only. And do you encounter any bleeding from your LV vent site?
No, sir. In all these 31 patients, all the procedure went smoothly. We only encountered left bundle branch block in 4 patients, which also recovered in the hospital stay itself. One patient has right bundle branch block in pre-operative phase only, who went into complete heart block post-surgery. And he also reverted back to right hand bundle branch block during the discharge of the patient. So no PPI was required in any of the patients.
And what is the cost?
Cost, in better, George is from the Percival.
You're too junior to tell.
George,
the cost.
can you tell what the cost of the one?
Bicuspid aortic valves were included in your insertion? Here.
So in the bicuspid, this is George. My name is George Dakash. I'm a Medical Affairs Director for Corsyme. Regarding bicuspid valve, is contraindicated with the bicuspid type 0. For bicuspid type 1 is good when we have 1 Raphe, and with bicuspid type 2 with 2 Raphe. So treating 1 and 2. Regarding PPI,
No, they were asking about the cost.
For price, my colleagues will.
So the Percival Plus is around 3.5, 3,50,000, and Percival, the previous generation, is 3,20,000. This is the MRP.
For upper mid sternotomy, also use L-event or P-event?
Sorry, sir?
For the upper mid sternotomy,
Ji.
do you use P-event or right?
No, we use L-event.
I'm Dr. Srivastava from Narayana. What is your mean cross-clamp time for this?
Sir, for isolated AVRs, the mean cross-clamp time was around 42 minutes.
42 minutes. I think a good surgeon, an average surgeon, in 40-minute cross-clamp time can easily insert any sort of valve. So I do not understand what advantage are you going to give. Because what aortic roots we see, hugely calcified, very difficult to take out the calcium, and when you are not putting, and in fact, after suturing the valve, we see that there is no paravalvular space left around. In spite of that, you do get some paravalvular leak, and I am surprised that out of these patients, none of the patients had paravalvular leak, first thing. And so, 40 minutes time is a very, for routine it is normal. Isolated aortic valve, you take just 30-35 minutes for that. So I do not know what advantage are you giving. In addition to that, there is always potential chance of paravalvular leak, plus the chance of heart block, like you get in TAVI. So that is my perception about this valve.
Excuse me. Move to the next talk.
Thank you.
If I remember, the incidence of paravalvular leak during your first generation Percival was supposed to be high. Was there any change in the design that has happened in Percival Plus, which is now reducing the paravalvular leak? Because for a period of time, it was out of the market.
Percival Plus we have just implanted last week, and the only advantages of Percival Plus was mentioned about the less protrusion into the left ventricular cavity, and the incidence of PPI is less in Percival Plus. The long-term effects of Percival Plus are yet to be studied.
You just said that it's a patient who selects the valve. But how does the patient select the valve unless the patient knows everything about the valve? So first you have to tell everything about the valve to the patient, then only he will select. So what do you actually tell the patient so that he selects a Percival valve?
He's been given all the choices about the valves available.
Pardon?
So he is given all the choices about the valves available.
So you are saying that he selects a valve, he should know what advantages that he has on this valve, then only he will say, okay, I want this
The time
valve.
is being overshot for this session.
So I just wanted to know what you tell them that they choose.
I think the person who is implanting it's not here, so he's, I think, just a junior fellow. He can't answer your question. Just
If you
one
allow me-
question. Last question.
If you
Yeah,
allow
hi.
me, I
Hi,
can-
I'm Dr. Wasim from NH Kolkata. I just wanted to know if there is if these valve can be retrieved and re-implanted if such a situation arises. Thank you.
Dr. Bana is not a good veteran.
He wants to know whether you can retrieve this valve and reimplant.
So,
Okay.
if you allow me, for any question where we can address this paravalvular leakage, why is the benefit of cross-clamp time, bypass time shortening, and about PPI? We can address it tomorrow in our wet lab workshop.
Thank you. We move to the next talk, and that will
Thank
be
you.
delivered by Dr. Lalit, I believe. Lalit is a young budding cardiac surgeon in Jaipur and doing maximum minimal invasive surgery. Every time he wakes us with his some new innovations and new surgical techniques. So Lalit, you're talking on beginners.
And first of all, I would like to thank Secretary to give me this talk on this topic. I think this topic is very attractive to young younger surgeon to start MICS program. And this is a beginner guide to setting up a MICS program. So why is MICS program is needed? If we talk about patient benefit, the speed of recovery, less pain, early discharge, better cosmetic, and better clinical outcome, and more importantly, maintain integrity of thoracic cases better in minimal invasive cardiac surgery compared to conventional surgery, and is better for surgeon benefit also. So it is increase to skill enhancement or learning new technique, hospital revenue, increase your referral, and sometimes you give to alternative options or TAVI, MTM, or multiple PTCA to the patient, and so you will get sometime patient from your contemporary, your cardiologist. So execute a MICS program, you have to focus on training, mentorship, instruments, patient selection, technical knowledge, and teamwork, and we discuss one by one. Training is very essential for this program, and we all know this is very technically challenging and long learning curve, and we have to go some higher center where a good number of MICS case will be done in a year, or you go to some short visit to multiple surgeon to learn MICS technique, or you will take 12-month or 6-month fellowship from nationally, internationally from good center. This is a triangle designed by Martin B. Bodwell that this is a 4 stages of learning any new skill. If we are motivated or we want to learn a new skill, then we are in yellow line in conscious incompetence. This means you know that you don't know how to do something and it bother you. So we continuously learn and we go to up to this triangle where is unconscious competence, and this is a second nature, and this is the habit to doing so the same thing. This is same Dreyfus model in skill acquisition published in University of California in 1980. If this continuous competence and proficiency lead to mastery in new skill. If we combined in both theory, then we found that with time, with the continuous learning, tricuspid valve repair replacement, ASD closure, atrial myxoma removal, aortic valve repair and replacement, and CBG. If you talk any MICS surgeon, then he will be very comfortable to do CBG or mitral valve through the thoracotomy, because if we talk about mitral valve conventional surgery, we open the sternum and after cannulation we go posteriorly for mitral valve, and but in thoracotomy incision, if we go for third or fourth space, there is a direct vision for mitral valve. It is very easy to do. mitral valve for this approach. And same for CBG. You go for a lateral thoracotomy, you easily do LAD, OM graft, or PDA graft. Sometime you face problem with the proximal PDA or RCA. So this is a preoperative preparation. Other than routine investigation, check all arterial pulses. This is mandatory check by the surgeon. Color Doppler, most of the cases, if you found there is monophasic or biphasic flow, then go for CT angiography, PFT for COPD patient, smoker patient. Otherwise, you do room air ABG. Then if PCO2 is more than 50 or PO2 is less than 65, this is not a single lung case. CT chest to check if any doubt in lung in X-ray, you have any doubt in about lung, or to check the calcium or thickness of the proximal aorta for proximal graft, or for aortic valve, you have to check this is thoracotomy incision or upper partial ostomy. HB1AC is very important. If more than 9, is very difficult for anastomosis in CBG, little difficult for, This is X-ray, this is our routine to mention in our OT to CT ratio and validity for CBG patient. Is for CBG patient is always better, is CT ratio is less than 5 and LVD is less than 5 centimeter. If CT ratio is between 5 and 5, then little difficulty, but after 5.5 is more difficult to handle for OM or PDA graft. In the left side case, I did is a smooth case, but on right side there is some difficulty in PDA grafting. CT scan, I already mentioned. We know the thickness of calcium for proximal or for right and for AVR. For if patient is rightward more than 50% is for right thoracotomy operation, or alpha angle is more than 40. I mentioned this one thing is bilateral is better than chronicle is, because in left side patient is bilateral is better, is more active. In right side patient is biological is more because of comorbidity like smoking or diabetic. So the left side patient is better for beginners. Intraoperative preparation, about position, mark the incision line exactly. Patient should drap for any emergency stenotomy. Both groins should be draped and prepared. Send back to lift the chest 30 degree external depression. Pad T is mandatory. Without T is no MICS program. Pericardial suture is mandatory. If you take maximum pericardial suture is very easy to AVR or CBG case. You pull the heart to the suture line and ready to handle any surprise or you prepare your mind to ready to handle any surprise or complication. If any complication then key is patience, and you can handle this or complications. This is a team game, need a dedicated team. It's better to two surgeon if we are a small hospital, then for you have dedicated physician assistant, anesthetic, good in T, neckline surgeon on single lung ventilation, very important, perfused familiar lung cannula, vacuation and cardioplasia, and scrub nurse also familiar. So size is not important for beginners. Patient safety is very important. Experience grow incision size reduce. Always spread gently. Intraoperatic any nerve blocker and post-operative pediment very important, because initially 4 to 5 days there is more pain. And chest removal is very important. Not so early. If fatty patient is better to second and third day or before discharge. So in conclusion, I think it's a technically challenging with a long learning curve. Start with simple cases. Proper planning and evaluation of the patient is the key of success in MICS program, and never prioritize access over outcome, because minimum cardiac surgery is cardiac surgery first, and do not fear failure, rather fear not trying. Thanks. This patient I did last month, enjoying their life. Thank you.
In your experience, what is the conversion rates? What is the threshold for conversion?
Sir, I'm very lucky enough. There's no conversion rate till now, but 2 or 3 emergency when basically we put our instruments, keep in ready for 3 or 4 hours in OT. Sometime one case I am bleeding, and one time I take pacing wire. The bleeding from pacing wire side is come, then and this easily handle in OT.
Good talk, Dr. Malik. In mixed CABG, do you advocate the juniors to go for single vessel graft, or when you have multi vessel disease, will you still recommend mixed CABG?
So for MIC-CBG is better for first start with for beginner is start from Lima to LAD, and then I think, sir, first you have to command on in conventional surgery. You have to command for Lima Y and Lima radial grafting, and you have command to this sequential grafting. Basically, this all this all grafting is needed in your MICS surgery. You need basically you put 1 or 2 proximal graft, and then you cover all the vessels. So it's better to learn first this in conventional surgery, then go one by one.
Any question from audience? Dr. Prateek.
See, first of all, I commend you for a very good work that you're doing, and very nice to see young surgeons doing such fantastic work. My question is not only to you, but to all other surgeons who are doing minimal invasive coronary bypass surgery. When you make a small incision, maybe 5-6 centimeter or 4 centimeter or whatever, and then you make cuts in the legs or cuts in the forearm for harvesting the vein graft and the radial artery, do you think still it's minimal invasive? What is the exact length of all the scars together? Until unless you're doing a bilateral internal memory artery through that incision only.
Yeah, sir, you are very right. Basically, my point is same like you. We use interrupted. We have not endoscopic harvesting till now, but we use this interrupted incision for vein grafting, not for radial. This is definitely not a minimal invasive if you cut the whole radial artery, radial incision.
I think the term minimal invasive is a little deceptive. I think it should be minimal access rather than invasive, because anyhow you have to make a cut, and how small you make it's a minimal access rather than invasive, unless you have a port surgery, which still I don't believe that it is still minimal invasive, because you are invading the heart anyhow.
Yeah, and then if we say that cosmetic benefit is one advantage of mixed, and then if we make cuts here and there, and even if we make interrupted cuts on the legs, there are multiple cuts here and there, it's not really that good cosmetically. If someone is sitting on the beach wearing shorts and with multiple small cuts also interrupted on the legs, one can see. On the other hand, if you're doing bilateral internal memory arteries, and you can do that with whatever, best is if you can do 3 minimal invasive bilateral internal memory artery, that's fantastic. So if someone is really talking about cosmetic surgery, making cuts here and there everywhere, it's not cosmetic, it's not minimal invasive. Minimal invasive is only bilateral IMA.
Last comment from Dr. Meherwal.
I think the definition obviously may vary from one individual to another individual. I think definition is not important. What is important is what we are giving to the patient in terms of the early outcomes, the long term. The early outcomes, we talk about the mortality, the ICU stay, the hospital stay, the transfusions, the pre-opening and all. In the long term, obviously, is the long-term survival and the event-free survival. And when we talk about the minimally invasive, I think cosmetic first is one thing which is talked about. Whether we compare minimally invasive with standard surgery, we have to look at the parameters where one scores over the other. In my own practice, I think the minimally invasive through the right thoracotomy through a small incision is quite routine, or can be routinely done by most surgeons for mitral valve, tricuspid valve, and for ASDs. I agree with Prateek that unless you are doing a bilateral memory through the thoracotomy, and if you are using the radial and the vein, it doesn't remain minimally invasive. But bilateral memory, if you are doing, I think it's a good operation.
Thank you, and we move to the next talk.
Thank you, sir.
Which will be again recorded.
Yes. So, Dr. Kita Kikuchi, consultant cardiac surgeon, Tokyo Bay Urayasu Ichikawa Medical Center, Japan, will now join us virtually to discuss surgical techniques for use of bilateral internal mammary artery in minimally invasive CABG.
Hello. Excuse me, I can't share my PPT. Okay, so please. I try to share my PPT. Okay, thank you. Okay, thank you, Chairman and the Society. I'm honored to be here to present my topic, surgical technique and tips of minimally invasive bypass surgery using bilateral mammary artery. So far, we have a lot of clinical examples of fecal garbage using ether. We also report papers. And these are advantages of mixed garbage. We can preserve structure. This is very important. We have no need for inflammation. And we also can go down arterial. And we also can do garbage with the usual transplantation. So I would like to say the advantage of mixed garbage, good long-term result, less invasive. So let's move on to my topic, technique about mixed garbage. These are contents of today's topics. And patient selection is very important. I strongly recommend to do mixed for audience. If you do mixed garbage, you select the candidate. The small harm and good other function, train the body, make the basic, and the bit is possible. And we always do preoperative. We always do preoperative contrast CT scan. So we can assess ascending GL, the subclavian artery, ITS, length and location, and heart size and location as well. And we also can detect a very coronary artery using with the contrast CT scan. So we already check the length of mammary arteries and RGEA as well. So these are techniques of how to take down bilateral mammary arteries. So a patient need to be put on the appropriate position. And these are techniques of right mammary artery harvesting. I prefer to use long shaft harmonic scalpel, and right lung is always disturbed our surgical view, so we need to press down the right lung using Octopus Nuvo stabilizer. So after open the chest and spread the lips with using a Satrac retractor, we need to dissect fat tissue beneath the sternum completely to increase the mobility of the heart. And this is the setting to harvest right mammary artery. I usually use a metal surgical pot and put a harmonic scalpel by a metallic pot. And this is long shaft harmonic scalpel, which is 32 centimeters. And these fine forceps are also very useful to graft the mammary artery very gently. These are techniques of ITA harvesting using harmonic scalpel. So basically, we use sweep techniques. And when you cut branches of ITS, I prefer to use hook side of harmonic scalpel. and press the branches around 10 seconds to seal the lumen of the branches. So this is a video on how to harvest mammary artery. After open the chest and spread the lips with a sutural retractor, put a metal port by same intercostal space. And I also put octopus nubo stabilizer by a subsequent incision to depress the right lung. Okay. So we can get a good surgical fit beneath the sternum. Then I use harmonic scalpel, long shaft harmonic scalpel to dissect mammary artery. I prefer to do skeletonized technique to harvest mammary artery. So you can see right mammary artery very clearly by a direct vision. Okay. So these are my graft configuration. I prefer to use bilateral mammary artery as in situ graft. And I also prefer to use right gastroepiploid artery as well. These are our result of mixed cabbage using bilateral mammary arteries. So I prefer to use like this graft configuration. I put 6 bypass graft with this patient, for this patient, using a bilateral mammary artery and 2 vein grafts. And I also do Y-composited graft like them. So this is very, I do bilateral mammary artery, Y-composite graft using bilateral mammary artery and use right gastroepiploid artery for this patient. And I also do I-composited graft using bilateral mammary artery and radial artery as well. Recently, I shift to neolytic graft configuration, the 3 bypass graft. I put 4 bypass graft for this patient using bilateral mammary artery and radial artery and GEA as well. So these are techniques of displacement, how to displace the heart for distal anastomosis. So I prefer to, initially I use this kind of heart positioner. I call this technique direct retraction technique. So you can see the circumflex artery very clearly. But recently, I prefer to use 3 deep pericardial sutures, like a usual open bypass surgery. So we can save cost because we don't need to use heart position. You also can see circumflex artery very clearly only using 3 deep pericardial sutures, like usual open bypass surgery by a sternotomy. Okay, you also can use heart lung machine during your running curve for the patient safety. So this is a home mixed cabbage using bilateral mammary artery and GEA as well. After opening the chest, need to dissect beneath the sternum, fat tissue beneath the sternum completely to mobilize the heart. And I put 2 or 3 sutures to place the fat tissue to make more space beneath the sternum, and put octopus nubo stabilizer to press down right lung. So you can see right mammary artery very clear. This is right mammary artery. I sometimes use hemoclip for the big branch. Now you can see right mammary artery very clearly. This is right mammary artery. Then after harvesting right mammary artery, I usually harvest left mammary artery. Before harvesting lemur, need to cut and remove fat tissue and muscle completely to visualize the left mammary artery. Then I do same fashion to harvest left mammary artery. After then, in this case, I harvested GEA for the third arterial graft and introduced GEA into the pericardium. And this is PDA. You can see PDA very clearly. So I put 3 deep pericardial suture to displace the heart. And this is GA for PD anastomosis. This is PDA. You can see PDA very clearly. I only use 3 deep pericardial sutures and usual octopus stabilizer. This is GA. You can see GA very clearly. I prefer to use 8 or surgical and put shunt tube into the coronary artery. Okay. This is GA to PDA anastomosis. And next, I did return to LAD anastomosis, put the octopus stabilizer on the LAD. And this is right mammary artery, which can lead to LAD. We can see LAD very clearly. Is it right mammary artery? LAD. Going to finish. I put 7 or monofilament suture to fit the right mammary artery, just in case. And last, I did liter to peer anastomosis. You can see distal OM very clearly, even by a small left thoracotomy. So I did a 3 bypass graft for this patient using an NLTIC strategy with total arterial grafting. So this is my conclusion. Beta can be safely harvested under direct vision without the robot or scope system. Beta can be used with usual graft configuration, even in mixed cabbage. NLTIC manner is also feasible with multi-arterial graft in mixed cabbage. This approach has the potential for further optimization with hybrid revascularization strategies. Thank you for your attention. Thank you very much.
Are there questions? No, he can. Yeah. Good evening, Dr. Kita Kikuchi.
Yes.
Can you tell us about tips and tricks of how to use this harmonics? I know that using regular cord would be very difficult to harvest bilateral memory.
Yes, I have to say that you need to familiar to use harmonic scalpel via sternotomy, by surgery. So this is very important. And after that, once you get used to use harmonic scalpel for the sternotomy case, I think metallic port is very important for harvesting mammary artery by thoracotomy, because if you do this kind of technique, I mean, if you want to do if we want to use harmonic scalpel by a same incision, your right hand and left hand always disturb your surgical field. So port is very important. And Octopus Nuvo stabilizer is also very useful to depress the lifeline, which always disturb your surgical field. Once you can get a good surgical field beneath the sternum, I think harvesting mammary artery using harmonic scalpel is not very difficult, but I think you need some proctor for the harmonic scalpel. Thank you.
Use the hook of the harmonic or the tip of the harmonic to cut the branches?
I prefer to use hook type harmonic scalpel.
Congratulations for the amazing work you do. What is your take on hybrid CABG?
Yes, I think hybrid CABG is also a very important strategy for us, especially using bilateral mammary artery for hybrid strategy or a multi-arterial grafting for hybrid CABG will provide a very good long-term result. So I think hybrid is very important for this field.
Initially, you said that you have some selection criteria for this bilateral memory. You have to have good target vessel, good memory, and then only you'll do. But this is not the case in every patient. You do get the diffuse disease. You do get the smaller IMA. And then what do? Do you sequence the graft or just forget about the remalima or go for conventional venous grafts?
I have to say, I do many cases for this technique, not only good cardiac function case, but also poor cardiac function case and big heart as well. But this is a congress, so many young surgeons also listen my presentation. So I don't want to say you can do mixed cabbage for the poor heart function case or something like this.
Many times you do get mid LED lesion, a significant lesion, mid LED in addition to proximal lesion. So in fact that needs two grafting or a big endarterectomy in that patient. Then only you can completely revascularize the LED territory. So
yes, I do long onlay patch with endarterectomy. Yes.
What is your selection criteria for pump-assisted minimal invasive CABG? One pump.
Basically, I don't want to use heart run machine for mixed cabbage. But if I do mixed cabbage for emergency or big cardiac function case, maybe I will use cardiac revival to assist cardiac function during surgery.
Dr. Pratik wants to.
First of all, I would like to congratulate you for a very good presentation. And use of bilateral internal memory artery through a limited incision is the true minimally invasive surgical approach as far as I'm concerned. So well done. Now I have two questions for you. First is, in a patient you say you showed using the RGEA along with the bilateral internal thoracic arteries. So my question is, what was your experience? I mean, RGEA is more spasmodic and more thinner a vessel as compared to the bilateral internal memory arteries, and sometimes just pulling it up to graft the PD a bit higher can cause a little bit of more tension, and the IMA is up a bit more, acceptable in such situations. So what was your experience regarding the use of RGEA in such situations? That is one question. And the second question is, you have been anastomosing the right internal thoracic artery to the LAD. I have a little bit of concern regarding this operation. I know it is very well done and you have shown it, but when a redo situation may come sometime in the future, there are some apprehensions with the right internal memory crossing the midline.
Yes, thank you very much for the question. It's very important. So that is the reason why I do CT scan of like so you can assess GA and bilateral memory. This is very important. And after harvesting GA, I infuse Primacore or Millinone PD3 inhibitor into the GA and mammary artery to dilate the graft. And I also asked anesthesiologist to increase the blood pressure around 150 to dilate mammary artery and GA as well. And the second question, yeah, I prefer to do REMA to LAD anastomosis cross the ascending aorta because right mammary artery actually is bigger than left mammary artery for right-hander on the majority patients. So I want to do the best coronary artery bypass surgery for all patients. That's one reason. After doing REMA to LAD anastomosis, I covered right mammary artery with fat tissue, which I cut after harvesting right mammary artery. So I covered right mammary artery with fat tissue. So fat tissue protect right mammary artery if the patient need to be done a second sternotomy.
Sometimes the right internal memory artery can be bigger in size as compared to the left, but when the left internal memory artery is going to the LAD, the route is shorter, so a bigger size lima can go to the LAD. But when the right internal memory artery goes to the LAD, it has to cover a longer distance, and by the time it reaches the LAD, it may be near its bifurcation, a little bit smaller in size. So, Yamana, that's another small point.
Okay. Then, yes, thank you very much. Then I do extension right mammary artery with radial artery for circumflex territory. So I can do REMA to LAD anastomosis and REMA plus radial artery to circumflex artery.
We'll go to the next talk.
Next up, we have a pre-recorded session where Dr. Vitaly Alexandrovich Sorokin from National University, Singapore, highlights on the emerging technologies in hybrid aortic surgeries. Dr. Vitaly will not be available to take questions.
Hello, hi. My name is Dr. Vitaly. I'm from National University of Singapore. I would like to share our hybrid aortic surgery experience, which we are doing from Singapore from 2005. The history of hybrid surgery started quite some time ago and mainly published by a Japanese group in as early as 1998 and for type B dissection in 2000. History of Singapore started 2005 where we reported our first case using hybrid surgery for type A acute dissection. Why do we talk about hybrid here? Number one is most of our patients elderly. This is a typical example where a patient is even community independent but have multiple risk factors, and he's age 82. And once you have his CT thorax shows distal arch 6 centimeters, what are you going to offer to patients? This is one typical example we use for hybrid surgery. Altogether is most of our patients 65 and above. Tissue quality is questionable and difficult to access distal arch. Most of the patients and some of our elderly and fragile patients would not tolerate cardiopulmonary bypass or hypertonic circulatory arrest very well, and in some cases we have to avoid it. So what's the pros of hybrid surgery? Number one, in sometimes shorten operation time, allow to avoid cardiopulmonary bypass if we aim to, and easier our access to distal arch, and it's probably the best way to deal with arch surgery if now cases team doing is not very high. But what the disadvantages, additional cost you need? Yes, you need hybrid theater, and of course it's everything in life. It comes with set of additional complications. So what do we use hybrid surgery for in our hospital? It's a type B dissection, which is residual after operating long time ago, type A dissection. We do use it for acute type A and B dissection. I will talk about it later. We use it for chronic type A and B dissection, and we use it for ascending aorta and arch surgery, and sometimes we use it for traumatic transection. So anatomical consideration is very important when we do hybrid surgery. So anatomy of arch have to be understood well before we start to proceed. And when position of your arch vessel is important in orientation to the midline. So hybrid surgery is a very well classified. One of this example is a hybrid approach described by Joseph Bavaria, which divides from type A, where the side bite used for ascending aorta, to all the way to type 3, where you use total arch, and later you extend it with additional endovascular procedure. This is another way to classify hybrid surgery, is where you land your stent. So it can be landing in zone 0, can be landing in zone 1, or even zone 2. So this is an example of zone 0 landing, where you just simply side bite ascending aorta, you do double or triple debranching, and then you can deliver stent at the same setting. This is a good approach, but your ascending aorta have to be perfect to do that. So this is a typical result after zone 0 landing, with double debranching done, and then a stent is delivered, which completely covered arch aneurysm. So zone 0 landing can be done when your ascending aorta is not ideal, but in this case you have to do graft interposition and replace your ascending aorta. Where do you have to do it? When your aorta is more than 40 millimeters for sure, when you have intramural hematoma extending from this type B dissection, or you have severe calcification, or your ST junction enlarged, of course you have to do it for type A dissection. So this is an example where the debranching done for type A dissection followed by endovascular stenting in the same setting, where this is a regional picture where patients come with type A dissection. So when we replace ascending aorta, we done only one debranching, in this case, innominate artery, when we have very good long landing zone here to put a stent on, and extra anatomical debranching is complete the surgery. So landing in zone 1 or zone 2 is also can be done, and most of the time done for distal arch. Distal arch aneurysm or distal arch pathology. If you want to land in zone 1, then you have to do double debranching, and it's usually done by subclavian bypass followed by subclavian carotid bypass. If you do land in zone 0, when you need to do only one debranching, which can be done, of course, extrathoracic, and it's done by subclavian carotid bypass. So your technical consideration for hybrid surgery, you should plan ahead. You should use your multidisciplinary team to plan. For example, this is a case where we don't have abdominal aorta, is absolutely blocked. So when you do your proximal part, when you have to do it intrathoracic, and when you do it intrathoracic, we use additional branch to put stent on a antegrade way instead of retrograde, because it's not possible in this case. So it's all about planning in hybrid surgery. So in NUH, we've done so far about 76 cases up to 2020. As you can see, most of our patients 65 and above. And what we have, about 34 of our patients is done in emergency setting, and most of our landing in zone 2. So our 30-day complications are about mortality 6.2%, and our stroke rate is about 4.2, with paraplegia about 4.4%. So if you look at the literature, so National University of Singapore doing quite well in using hybrid surgery and debranching. What do we have after when we follow the patients? A few complications, a specific set of complications might arise after your hybrid surgery and debranching. So, and the leak is of course branch stenosis, distal emboli, even aortic esophageal fistula. Let's talk about few. This is one of the potential problem. As you can see, patients have type B dissection. So when intrathoracic aorta will debranch, stent deploy, a patient looks fine on discharge, but look at this CT scan on the right side, low part. So after 3 months, we can see type A dissection where the proximal part get dissected. So this is one of the potential complications. And from our experience, we see it more and more in patients who have type B dissection. So another type of complications when we're done extra-anatomical debranching, as you can see, subclavian carotid bypass here, when you deliver the stent and patient is fine, and 6 months later you see type A dissection. There's a large false lumen in ascending aorta. So when you do distal arch aneurysm, for example, so these patients have a large ascending aorta. Before surgery, we do replace it. We put 2 debranching for these patients. We leave subclavian artery behind. We deliver the stent. Looks perfect, good flow to the stent. Then 6 months later, as you can see, one side, left common carotid artery is not perfused antegradely. So few factors, few things can go wrong. Number one, position of your branch should be ideal and straight, no kinks. And another thing what might happen, so when you do your distal anastomotic line, please make it long and oblique. If you do it 90 degree, it's sure not gonna last. So another potential complication is when you do graft-to-graft anastomotic technique and you don't use complex like plexus graft, what happens? So it starts to leak later on. Hard to say, high pressure infection, but what we see here in the red arrow, this is a false aneurysm with large intrathoracic hematoma, which required second surgery. Overall, what we can say is hybrid approach could be excellent additional tool to support arch surgery, especially patients who is elderly, especially a patient who is fragile. In type B dissection, if you do debranching or hybrid approach, please look at ascending aorta very carefully and always consider to do ascending aorta graft interposition to ensure a long-term result. Key is not a hybrid theater for hybrid surgery. Key is multidisciplinary team which provide planning and additional support if it's required. Thank you very much.
You, as this was a recorded talk, we move to the next talk, and which will be on hypertrophic obstructive cardiomyopathy. Dr. Mohan Raj has to deliver.
Next up on stage is Dr. Mohan Raj, Director, Medway Heart Institute, Chennai, will be discussing about the management of hypertrophic obstructive cardiomyopathy. Over to you, sir.
Good afternoon, everybody. I thank the organizers for giving me this topic, HOCM, hypertrophic obstructive cardiomyopathy, a topic which is under surgery, which is very, very close to my heart. Thank you. And these are my disclosure. There is no financial disclosure. And I thank Dr. Prem Shekhar from Brigham's Boston, because the video is the one I borrowed from him, and this was a recording which was done in Amrita Institute of Medical Sciences, and I thank the Amrita Institute for giving me this video as well. Because it's very, very difficult to get a good video of a HOCM surgery, even if you have a headlight camera. So the prevalence is 1 in 500. It's not, HOCM is not 1 in 500, but hypertrophic cardiomyopathy is 1 in 500. It is grossly underreported, but of late we have more and more patients coming up because of widespread availability of echo even in the smaller cities. It was first described by a German pathologist, and he described 2 patients. He said there was an asymmetric hypertrophy of the septum, which led on to the heart working more, and even more hypertrophy was being caused. In 1958 was the first modern description by Thierry. Braunwald was the one who standardized most of the pathologies, and he analyzed 64 patients. Moreau was a surgeon working along with him, and they worked together to establish the pathology and bring out a proper treatment for this. And Braunwald called it hypertrophic subaortic stenosis. Now, it is always an autosomal dominance, and most of the cases are actually mutations. There are 14 genes and 1,400 mutations described. And the phenotype of the disease, the clinical presentation, and the severity depends upon the type of mutation, and those are the common genes involved. Now, what happens is, when these genes are affected, it directly goes and affects either directly the sarcomeres or the protein synthesis, and that leads on to a significant amount of muscle tissue growing in there, and that leads on to hypertrophic cardiomyopathy. And rarely does that disease develop before adolescence. And patients who have a very severe spectrum of disease could have more than one mutation. The clinical types are non-restrictive, where the LVOT gradient is less than 30. The next type is basal, where the gradient is more than 30, or the labile, where a provocation test can bring it up to 30. Now, surgery is indicated when these patients' gradient becomes about 50. And the pathognomonic things in HOCM are LVH, MR, and SAM. Now, hypertrophy of the septum basically occurs in the basal part, where the anterior basal part and the contiguous free wall is involved there. And predominantly, it is in the basal part. A small percentage of patients can have a mid-cavity gradient, and a very, very small percentage of patients can have a apical HOCM specifically. Now, the septum is usually more than 20 millimeters. Anything more than 18 millimeters is significant. Now, how do you differentiate a septum of HOCM from a regular primary hypertension? A regular primary hypertension patient never has a septum more than 18 millimeters, whereas the HOCM patients always have a septum which is usually more than 20 millimeters thick. Now, mitral valve regurgitation is usually associated in most of these patients. There's a sudden pressure drop at the basal part of the septum because of the LV hypertrophy. This causes a Venturi effect, and the AML is pulled into the LVOT. There may be associated anomaly or abnormalities in the mitral valve. The AML may be elongated, the mitral valve area may be more, and usually when the AML is pulled into the LVOT, the PML doesn't move along with the AML to go up there. So there's a gap between the AML and the PML which causes the mitral regurgitation. And this regurgitation jet is usually directed posteriorly. If you see a patient with HOCM and has a central jet or an anterior jet, we will have to think about an associated mitral anomaly like a myxomatous degeneration there. LVOT is pathognomonic, and the components are, as I said, LVOT obstruction, SAM, and mitral regurgitation. Cardiac MRI is coming into more and more play now, and the MRI shows very clearly the level of obstruction and the thickness. In fact, a good cardiac radiologist can even tell you what are the mitral valve anomalies there, the length of AML based on the cardiac MRI. Echo is very, very a mid-esophageal long axis shows the septum and the mitral regurgitation in a single view. A good TE person should be able to tell you the exact dimensions of the septum at each level. That's showing a SAM, MR, a posterior directed jet, and the LVOT being obstructed there. Now, surgical treatment. The surgery started at Hammett's Hospital. And Moreau subsequently redefined it and did a proper surgical myomectomy. And now we do the extended surgical myectomy. Most of us would have seen Dr. Schaff, who comes to our country and demonstrate these cases, and they from Mayo Clinic have one of the largest series. A short video here. Oh, sorry. Can we get back and play the video, please? Yeah. Usually it's approached through a median sternotomy. There are descriptions of upper partial sternotomy or a mixed surgery. And we do an aortic and a double-stage venous cannulation. The aortotomy has to extend obliquely into the non-coronary cusp so that the exposure is good. Good stay sutures are placed so that the aorta is exposed properly. And when you retract the aortic valve, you do have special retractors, or can be done carefully with our regular retractors. We have to make sure that the aortic cusp do not get injured by the retraction. So if you end up having AR, then sometimes there are instances where you may not be able to repair the valve vessel. So the incision starts at the basal, at the nadir, about a centimeter below the nadir of RCC. The suture with the 4O or 5O prolene is really helpful because the best resection is the first resection. Once you've missed it in the first resection, it's very difficult to get the suture holding to the endocardium in the subsequent resection. So the second incision is usually placed towards the mitral valve. The initial Morose incision, it was just placed between the RCC and NCC. With an extended septal myectomy, a second incision placed much more laterally, so that a good amount of tissues is resected. The points to take care is, you got to be very careful. What I do is the breadth of a 15 knife is about 4 millimeters. So if you want to excise about 8 millimeters, you aim at having 2 bits of the knife. So you have to be really careful. The areas to be taken care will be the membranous septum, avoid a ventricular septal defect, and carefully avoid injury to the aortic valve. The success of this surgery is, at the end of this resection, you should be able to see the heads of the papillary muscle. You can see that the heads of the papillary muscle are seen down there. Now one more little bit of resection is done. Once again a 5O prolene or 4O prolene suture is held down to the endocardium, pulled, and then it's resected. It's just beneath the membranous septum, so you'll be a bit careful with the membranous septum there. So you could see, carefully if you can see the heads of the papillary muscle inside there. That is the level of resection it needs to be done. You don't try to get the septum back to normal limits, it's just to have a proper resection of the LVOT. Aortic closure is done in routine fashion, and we wean off these patients, usually trying to avoid inotropes. And mitral valve interventions are very, very rarely needed. Even if there is gross or severe MR, even if there is a slightly elongated AML, better to avoid mitral valve replacement. If significant regurgitation is present at the end of your surgery, that means the resection is basically inadequate. The complications are complete heart block, ventricular septal injury, mitral valve injury due to papillary muscle injury, and aortic valve injury. So that's the end result. You have the LVOT beautifully opened and the MR is totally abolished. And that's the thickness of the septum you get at the end of surgery. So this is a personal series. I just wanted to highlight that none of these patients had a mitral valve replaced, and one patient we lost who had a baseline creatinine of 2.4 and a LV dysfunction with an EF of 38%, and his aortic valve was actually injured. We had to go back, replace the valve, and it was a prolonged bypass run. And one word about Dr. Andrew Morris. He's the one who standardized the surgery initially, and it's unfortunate that Dr. Brownwell diagnosed a HOCM for him. And Dr. Morrow refused an intervention and died at the age of 60. And being a genetic disorder, his second generation and third generation siblings, his kids also got the disease. And after a successful resection, you got near normal survival. And basically these patients have to be on regular follow-up, watch for arrhythmias to be developed, and these people are kept on beta blockers lifelong. The carry-home message is it's a grossly underestimated prevalence. Surgery is near curative and survival is near normal. Mitral valve replacement is not usually indicated. In fact, you can get away all these patients without replacing the mitral valve. And a lifelong follow-up of these patients is needed. And surveillance of first-degree family members is a must. Thank you.
Thank you, Dr. Mohan Raj. I just want to know, how do you decide how much to resect? Do you have any upper and lower, some landmark that you decide about it?
No, we get a basic idea of the thickness of the septum, and the maximum dissection should be done at the where the mitral valve goes and hits the septum. You can see a whitish discoloration there. As I said, we don't aim at getting a near normal septum here, and once you've resected, if you're able to see the bases of both the papillary muscles, that's an adequate resection, and you can see a roomy, wide open LVOT through the aortic valve.
Any way we can see that the dissection is adequate now during surgery? I mean, the aorta is still open.
We could feel we could get our fingers in and feel the thickness of the septum, and we can see how much it's been adequated. There are two instances where there was a significant, not acceptable mitral valve regurgitation. So I had to go back in these patients. Two patients I had to go back in and do a bit more of resection. And at the end of surgery, the MR had really been abolished.
I don't have much experience, but I did 2 cases, and in the last one which we did, my assistant kept on insisting, sir, why can't we try like we do in RVOT? Just put your Heger dilator inside and see how much it goes. So I think it worked. Initially when I was doing it, it was hardly 12 or 13, 14 millimeter, but in the end he insisted for dissection, and believe me, we could insert 20 size Heger in that. I think it's one of the way to discuss it.
And one little trick to help better visualization is your assistant keeping a sponge on the RVOT and pressing it down so that the septum is pushed down and you can do a better resection.
For better visualization, you go for a complete transection of the aorta or conventional
It's like a oblique aortotomy, and the lower end of the incision goes towards a non-coronary cusp so that you can see the visualization is really good.
Shiva, can I make a comment on that?
Thank you for your nice presentation. Do you do any preoperative transesophageal plan or MRI plan to resect? How much to resect?
The transthoracic echo gives you a fair idea of the thickness of septum. We don't do MRI as a routine, but off late we've started doing MRI for last couple of years.
But preoperative TE?
Not preoperative, it's intraoperative TE.
Intraoperative TE.
We don't aim at a pre-op TE.
Okay.
Shiva, can I?
Dr. Chandrasekhar.
On the adequacy of resection, I think Sanbu pointed out it's the contact lesion. The contact lesion will be seen on the septum as a whitish area, like a fibrous tissue. You have to go beyond that. It is more on the length of the incision down towards the apex of the ventricle that's more important than the thickness as much as you excise. And preoperative transesophageal echo will give you a clear guidance on the length of the septum you have to resect. But always we have to go, after coming off pump, we have to check the pressures, which we can do perioperatively with a needle in the aorta and needle in the LV. See a post-ectopic induced gradient, which is very important because it's a dynamic obstruction. And once the post-ectopic gradient is high, more than 20, we have to go back and fix it. And sometimes if it's a mid-cavity, we have to go open the apex of the ventricle and fix it. So adequacy of resection, we have to go well beyond the contact lesion.
Thank you for that presentation. We have done a couple of cases, and the rule was 1 centimeter, you go incision and about 1 centimeter square, sort of. First you resect that, then the septum falls off, you know. You can literally see the septum. Dr. Mathu's question, how do you know? Dr. Cooley used to do the same thing, 1 centimeter, and we follow that, and we can see literally the septum falling off.
Thank you.
Thank you very much.
Next talk is by Dr. Meherwal, and he'll be talking on left ventricular assist devices.
Next on stage, I would like to invite Dr. Zile Singh Meherwal, Executive Director of Cardiovascular and Thoracic Surgery at Fortis, Scientific Chairman, Senior Vice President ISCTS, to speak upon the LVADs a rapidly evolving alternative to transplant. Over to you, Dr. Mehra.
Chairpersons, friends, very good evening to you all. First of all, let me congratulate and thank the organizing team for making excellent arrangements for this meeting, which is a physical meeting after a long time. And I can tell you the team has been working day and night because I have been interacting with them for the last 2 months, and they have really worked hard. So I think I'll take this opportunity to thank the whole organizing team for organizing this conference, which I'm sure is going to be useful for everyone. I'll be briefly speaking on the role of left ventricular assist device in today's scenario as a rapidly evolving alternative to transplant. So far, we know that short and long-term outcomes following cardiac transplantation, which is the treatment for end-stage heart failure, have been exceptional, with a median survival of more than 10 years, and survival of the patient conditional to surviving for 1 year of more than 13 years. And more importantly, the quality of life has greatly improved, particularly because the immunosuppressive agents, they have become more targeted for the rejection process, which used to be, or still is, one of the challenges after transplant. And therefore, the heart transplantation still remains the gold standard for end-stage heart disease in adults. However, because of the paucity of donor hearts and multiple common contraindications, this option is available only for a small fraction of patients. This is the data of number of transplants from ISHLT from US, and as you can see, the numbers, of course, they are growing for the last few years. They have remained close to 3,000 and between 3,000 and 3,500, which obviously is a small number considering the number of patients who are in end-stage heart disease. If you look at the heart transplants in India, we do less than 200 annually last year, and in general, it has been less than 300 over the last few years, though I must say that the number of centers have increased, and also the number of transplants, as you can see, have significantly increased, and I'm quite sure in the coming 10 years, the number are certainly going to be much, much bigger than this one. And therefore, the use of LVADs has grown steadily over the past decade since their initial approval for use as a bridge to transplant and as a destination therapy. Also, the technology has evolved a lot over the last 2 decades, from pulsatile and pneumatic devices to the non-pulsatile pumps and the pumps with the internal pumps. Also, the axial pumps now have been used for a long time, but now we have the centrifugal pumps which have given much better results. The complications because of the hemocompatibility certainly have reduced, both in terms of the device malfunctions, in the adverse events. Also, the patient survival has improved, and the global experience of these devices is also increasing. And over the last 2 decades, there are a large number of publications looking at the comparison of the transplant with the LVAD. And as I mentioned, the patients who have contraindications to transplant, either because of the age or because of PVR, which is a very important consideration for transplant, or because of comorbidities, some of these patients, they can be candidates for LVAD as long as their right ventricular function is okay and as long as they don't have contraindication to anticoagulation. There are multiple publications showing the long-term and mid-term results of the LVAD over the last 2 decades. These are some of the publications. If you look at the survival of these patients who have received LVAD, it is gradually improving over the years, and in the last few years, the survival after left ventricular assist device implantation actually is very close to heart transplantation. A few years back, the Momentum 3 trial was published, which is a comparison of the HeartMate 2, which is an axial pump with HeartMate 3, which is centrifugal pump, which is fully magnetically levitated. And this HeartMate 3, which now is being used for the last few years, is a centrifugal flow pump which is fully magnetically levitated, and it has been engineered to minimize the destruction of the red blood cells and also to decrease the thrombosis. It has wide passages to reduce the shear stress. It is frictionless, and it reduces because there are no mechanical bearings, and there is an impinging pulse which has been created to reduce the pump thrombosis. And this study, the Momentum 3, was a long-term study which was designed to ascertain the success of this device to optimally support the patients who are waiting for extended period of time for transplant, or they were ineligible for transplant for one reason or the other, and they were offered this as the destination therapy. The primary endpoint of this study was survival at 2 years, free of disabling stroke or reoperation to remove or replace the malfunctioning device. The survival at 2 years, free of disabling stroke or reoperation to replace or remove a malfunctioning device was 77.9%. The overall survival was more than 82% as compared to 76% in HeartMate 2. The freedom from disabling stroke was 92.8%. And this is the comparison of freedom from reoperation to repair, to replace or remove a pump as compared to the HeartMate 2. It was 97% as compared to 75% in HeartMate 2. The conclusion of this Momentum 3 trial was that the HeartMate 3 is clinically superior when compared to HeartMate 2 axial flow pump at 2 years, and these benefits were primarily driven by a lower reoperation rate in the HeartMate 3 arm. And they also noticed a lower rate of stroke with HeartMate 3. This is a contemporary, this is a review of the outcomes of the LVADs, which has been published. And this shows that the outcomes after continuous flow LVAD are excellent, with short-term survival which is comparable to the heart transplant. But the long-term survival, it still remains limited due to the incidence of post-implantation adverse events, which unfortunately even now are significant, though they are improving. But despite these complications, the quality of life and functional status, it improves significantly post-implantation and remain improved over the long term. This is a systemic review and a meta-analysis of the heart transplantation, comparing with the left ventricular assist device implantation as a destination therapy or as a bridge to transplant, looking at 1 year mortality. This is the forest plot for 1 year mortality, comparing the continuous flow LVAD with the heart transplant, and there was no difference in the 1 year mortality. And this is the comparison of the LVAD as the destination therapy with the heart transplant, and again there was no difference in the two therapies. This is another systemic review and a meta-analysis of the continuous flow LVADs with orthotopic heart transplant in adults. This forest plot shows the mortality at 1 year, 2 year, 3 year, and 5 years with LVAD as compared to the transplant for patients who received LVAD as the bridge to transplant, and there was no difference in the mortality in these patients. When they looked at the adverse event, the stroke rate was higher in the LVADs. The other adverse events were comparable. They also compared the LVADs as the destination therapy with the heart transplantation, and again at 2 years, there was at 1 year and 2 years, there was no difference in the mortality between the two therapies. And this review concluded that continuous flow LVAD as bridge to transplant results in similar outcomes as the heart transplant within 5 years. The continuous flow LVAD as destination therapy is associated with similar 1 year and 2 year mortality, but a higher risk of stroke as compared with transplant. So the take-home message would be that despite the ongoing measures to increase access to donor organs, the organ availability still remains a major limitation to heart transplantation. The LVAD technology is improving with better patient survival and decreasing complications, and therefore the number of patients receiving LVAD as bridge to heart transplant or as destination therapy is increasing. Now currently, the algorithm for screening patients for advanced heart failure is that these patients are initially evaluated for heart transplantation, and the LVAD is offered if they are not candidates for LVAD. But in future, I think this strategy might change. One would look at the LVAD maybe as the first line of treatment, and the heart transplant might be reserved for patients who can't have an LVAD because of one reason or the other. Thank you very much.
Thank you, Dr. Meherwal. I think you're right. LVAD is the future. I have two questions for you. What are the follow-up protocols for this patient? And in layman terms, what do we tell the patient that these are the early signs you have to immediately rush to the hospital?
So I think the follow-up is a major challenge. In fact, I'm giving another talk on the challenges of LVAD, the LVAD implantation, the challenges and the opportunities. I think this is tomorrow, day after. And in those challenges, follow-up is one of the challenges. So these patients can't be followed in a routine cardiac clinic. They can only be followed in a heart failure clinic, because you need to evaluate their data of the last, for example, 3 months when they come to you, which can only be analyzed in the heart failure clinic. More importantly, these are all pulseless patients. You can't measure the pressures. And just to give an example, one of my patients, one of the initial patients, he became unconscious. He was from Rajasthan, and near Jhalar, I think. So he became unconscious, went to the local hospital. They obviously started doing the cardiac resuscitation, as anyone would do, while he actually had a stroke. And the LVAD was functioning absolutely normally, because when he got transferred to our hospital, we realized that he had a stroke, and the LVAD was functioning normally. So these kind of challenges one can obviously face in the follow-up. But in general, these patients basically, they are not only the patient, but the caregivers. They are giving a kind of a training before the implant and after the implant as to how they have to look after the device, and how often they have to come for follow-ups. And obviously, if there is any time they have an issue, they have a number of the dedicated doctor from the team to talk to, and whether they should come to the clinic or they can stay at home.
Excellent talk, sir. You said 6 months and 1 year results between destination therapy and bridge to transplant or similar. So how do we select, sir? What is selection criteria to decide it's going to be a destination therapy for that particular patient?
How to decide whether it should be a bridge to transplant or as a destination therapy? So any patient who is in advanced heart failure, or so-called class D heart failure, obviously is evaluated first for heart transplantation. Because even today, I would say, I think this is still, the results are better than the LVADs, though the LVAD results are improving a lot. If the patient is not a candidate for heart transplantation, because, for example, the patient is elderly. One of our patients was 75 when we implanted that. He was not a candidate coming in the age bracket when we could offer the transplant, or because of comorbidities, for example. Then you evaluate these patients for LVAD, and then it will become a destination therapy. Now, if the patient is not a candidate for transplant, but you feel that certain conditions can improve, you will use the LVAD as the bridge to transplant. For example, some patient has a kidney dysfunction or something else, then you you give them a LVAD as the bridge to transplant. Secondly, a lot of the patients which come to you in the advanced heart failure stage, you put them on the heart transplant list, but they can't wait for the heart because it's taking too long. So these patients are given LVAD as a bridge to transplant. But having said that, in India, almost all the LVADs have been destination therapy.
Wonderful talk, sir. Any patients required RVAD, sir, temporary RVAD in your experience? Any predictors?
I think RV function remains probably the biggest challenge in these patients. And though there are obviously sophisticated ways to look at the RV function and evaluating, but 10 to 30% of patients will develop RV failure post-implantation. Majority will recover with your routine supportive therapy of nitric oxide or milrinone and the other drugs. A small number of patients will need short-term RVAD. We use Centrimac as the short-term RVAD therapy. The ECMO also obviously can be used, but most people use, we use Centrimac as the RV support for patients who have RV dysfunction post-LVAD. The biggest challenge is that if the RV does not recover, there is no approved long-term device for the right ventricle, then the only treatment you have is the transplant.
Thank you. With this, we end the session. And
thank you, Dr.
I thank you all the speakers and my co-chairperson for the meeting. Thank you.
Thank you, moderators, for your time.
Infinitely better to transplant a heart than to bury it to be devoured by worms. Christian Bernard. The greatest gift you can give someone is the gift of life. So pass it on. With this in mind, I welcome Dr. Kumud Dittal, a Program and Surgical Director in CTVS, as well as Heart and Lung Transplantation Program at Sparsh Hospital, Bangalore. He'll be joining us online. Can we have the link, please? We are pleased to have on stage Dr. Thakkar as a moderator, Dr. M.L. Gupta, Dr. Anil Sharma, Dr. Gaurav Goyal, and Dr. Gurjeet. Over to you, Dr. Kumud.
Thank you very much. Good afternoon. Now. So we know what the problems are. Increasing burden of cardiopulmonary failure in India, where significant number of deaths, in fact, cardiopulmonary causes are responsible for the top two all-cause mortality in India, third being cancer. Organ donations are still abysmally poor, and often even the few organs we have available are poorly managed, or sometimes usable ones are being turned down. And we have to accept that there's considerable hurdles, and from referral patterns to the time period of counseling for the primary consent of the donor, and sometimes the time period of consenting the recipient as well, and not having enough time to build trust. These are important time periods. And of course, if you don't have a proper consent in the donor, it can result in a poor conversion in the number of organs that are consented for and therefore transplanted. There is no mandated accountability in terms of organ acceptance and allocation practices. And of course, there's always the problem of the economically disadvantaged that cannot even get on the wait list, which I believe is the worst situation. There are discrepancies in the extent and nature of state-level funding, that people are having to rely on crowdfunding, philanthropy, and other measures of selling their own home and property. Whilst outcome we know is related to volume, there are many centers still that are not that active, but continue to list complex, risky patients, and understandably have a fear to proceed with, disadvantaging that recipient with potential mortality on the wait list. And of course, while we accept donor organs are a national resource, by the fact that we refer unplaced organs to Noto federally, there is no funding to get that organ to the recipient, and it is left to the one with the fattest wallet to be able to mobilize things within the family. Further hurdles are, of course, in terms of the wide variation and lack of adherence to established and protocols that are there for how to look after a multi-organ donor in the best possible way to safeguard all organs for eventual donation and successful transplantation. The competitive and rival practices that are arisen from largely corporate establishments instead of collegiate supportive relationships is, of course, a problem in itself. Then there are institutional priorities and the absence of clinical governance in many institutions to allow internal local oversight to safeguard those transplant programs. And then it's all about, in the sense of our need to put forward and submit data, it's fairly short term. And I ask you whether or not the same donor recipient matches would have taken place if the patient was in a corporate hospital as in a public hospital and without any consideration of the actual finances. So this is your ideal situation. We have a responsibility to look after the recipient, to be alive as long as possible, as much as we have that to the altruistically donated organ, to keep that alive as long as possible. And sometimes we forget that by transplanting a donor organ that could survive for many years into a salvage patient that probably has no chance of survival. And so we have to face, through our choices, recipient injustice against allograft injustice. And finding a balance becomes difficult. And in a time-based allocation priority system, it is all the more depressing. And this sort of system disadvantages rapidly progressive disease. It disadvantages acute non-reversible decompensation and assumes that heart and lung failure in its advanced stage can be managed almost like chronic renal failure, although we have just heard how good the mechanical assist programs are becoming in respect of heart failure and delaying transplantation, and how we might soon be approaching equipoise in those two management strategies. And of course, the time-based allocation system also disadvantages the wait list. And so we also need to understand when to say no, and to stop doing things that are entirely futile because of the overwhelming number of patients who would benefit otherwise from that same transplant, given the shortage of organs that are available. So we all agree on what we should be doing in terms of increasing organ utilization, striving to improve outcomes, and stopping those futile procedures. But to give you some sense of where we are in terms of the number of transplant centers there are in the country, but only to give you an example from Karnataka just over a few months ago, if you look at the top two columns of heart and lungs and the number of organs that were retrieved over the last 14 years, and assuming that all the centers are active and all the organs were all transplanted, you would end up with less than one heart transplant per center per year. It would take almost 2 years for a center to do a transplant and almost 10 years to do 10 transplants. For lungs, that's abysmal. You would do a third of a lung transplant per center and wait 33.6 years to do 10 transplants per center. And if you add the number of patients that are on the wait list or were on the wait list a few weeks ago, you will see for yourself, I do not have to extrapolate, that majority of these patients are on a sad hope, a poor hope, false hope that they will ever get transplanted. And if I look at Kerala, the same sort of situation where if all the centers were active that are licensed and authorized and all the offers were used up, you would get less than one lung transplant per center over a 9-year period. And similarly, it would take to do 2 years to get one heart transplant done per center. So we are increasingly, of course, doing heart and lung failure surgery with conventional higher risk surgeries, but we also have newer toys, and our practices are becoming far more complicated. ECMO strategies, and we've only heard today of a remarkable success with ECMO over 159 days in a lady at Yashoda in Hyderabad, which I think is phenomenal, and the team should really be congratulated. And hopefully we'll have plenty to learn from the longer survivors on ECMO to find out what are the metrics we need to be following to make sure that our patients can survive long enough to get over the COVID, for example, as in this situation, rather than an untimely a fast transplant when in fact the lungs might actually come good, as also explained by the Toronto series. We have other toys in terms of heart support that you've just heard about in the last lecture, and of course, even more in respect to total artificial hearts that are coming to the market, and we'll have more to play with in the next few years. But what it has done is turned our simple clean skin transplants into more complicated procedures. And we've got now the choice of single, biventricular, total artificial hearts, and faced with late referrals, poor protoplasm to have to get through and deliver a good outcome. And it is important to note that the heart and lungs are not the same as certainly as the kidney. And we do not, certainly for the lung, have any way of maintaining these patients on mechanical assisted home. We have increased precision medicine all the way from our HLA immunology studies to post-transplants, donor-specific antibodies, and so on. But what that does is make life even more complicated to us, because we're moving from a patient-driven to a data-driven practice where it was so easy to look after and give prior to the single recipient, but not looking later at the distance in terms of whether or not that is beneficial in respect of maximizing the survival of the allograft and that recipient. And so precision medicine means more data. It means more decision points, more forks in the road, and that increases complexity, and complexity gives opportunity to gain. And of course, whether you do it consciously or unconsciously, this act of gaming, which is universal in our practice in cardiothoracic surgery, probably started off in the United States, in New York, gaming the risk for even routine cardiac surgery to manipulate so that you can be afforded a greater morbidity and mortality. Yet this is done too at the individual level to try and get some sort of advantage to safeguard that particular individual, but it's seen in that context as being ethical. Similarly, the increasing the risk of an individual in a time-driven allocation process can also, by some units, be seen as ethical, although I personally feel that neither is truly ethical. So where do we go from here? I think we have to accept common goals, as stated before. I'm not going to go through all of those individually, you can see them for yourself, but it's all about a balance of equity and utility for the patients that we are serving and the larger community. So I want to come now in terms of this whole issue of crossing the chasm and refer you to Geoffrey Moore, who coined the phrase in 1991 by drawing upon this bell curve, which I use for lots of analogies, where you look at in respect of technology adoption, you have the innovators, the early adopters, and so on, and the laggards of the way later on. How does this apply to what I'm talking about? Well, let's just go through, because it's not such a continuum. This line gets broken down with gaps, and this phenomenal gap between the innovators and the early adopters to the majority is the chasm. We have that problem across all our discipline in every format, from heart failure management to referral to the transplants that we do, including the donor and recipient separate timelines. So just to give an example, for the DCD heart transplantation, there we were in Sydney in the blue bit, and then the UK came on board. And it's only recently with the FDA approved DCD trial in the US that 25 centers have taken on board, with a smattering of other centers in Europe, to make it still the early adopters. We're not in the majority yet, but it requires an incredible amount of hard work. And so I referred to this top line as the bell curve, the actual bell curve. That's what's called the line of continuous management, where things flow seamlessly. So the patient with heart or lung failure that is deteriorating after this peak here is referred in a timely fashion, because they're goalposts that everybody respects, and there's a timely listing. And then we know that between this yellow and the blue bars across to the red, we can perform surgery with reduced risk and avoid these futile ones. But that's not what's happening. We have got these gaps because it's a discontinuous management we're facing at the moment, where there isn't the adequate education, sometimes information, or just intransigence from the people who are meant to refer in a timely manner, and it's not. So every single gap becomes a chasm in itself. And to try and do that individually becomes a real struggle. And we need to be able to jump these chasms in unison, together, and ideally with somebody across the way that's already jumped to be able to give us a holding hand and lifting us across. That can only happen when we all agree to do this in unison, and that requires the much more difficult task of becoming collegiate and working together for the same common cause. So what is the way forward? Well, I think we have to be at the table. The table is definitely empty at the moment. And our status quo simply reflects our inability to resolve even our own shared common purpose, common problems, to come up with common solutions. And this can be done we don't need to reinvent the wheel. It's done around the world, the consensus between the stakeholders. We have important societies with very eminent, experienced people working on them, from INSHLT to Society for Heart and Lung Failure Transplantation, the Transplant Committee of the ICTS, relevant to this conference, and of course, all the other multidisciplinary bodies that we must not forget, from ICU intensive care to anesthetics to the NGOs and so on. We need to be able to lobby. We can't lobby from a position of strength if we're not united. Any problems voiced without such unity just falls on deaf ears, because there are better things to do. When the regulatory authorities and the government see that we're not united, they will just not listen. They will not do anything. National consensus documents. We should in India by now be having these, and I'm seeing more and more of them, which is a fantastic news, but we should be having them from A to Z topics across management of advanced organ failure and transplantation. The need to continue our education of the referral base and patients and communities themselves continues, and we must take greater action through these bodies that I mentioned earlier to see transparent programs that are going on and audited results of those programs to see what progress we're making and what we need to change to make it more effective. And of course, registry, we have to capture far more than we're capturing at the moment, because the data has to be prospective, it's got to be relevant and necessary for auditing purposes. There's got to be auditing and policing programs of the programs, the outcomes, and it has to be fit to allow Indian experts here to then evolve the practices by huge volume of figures and facts to then put out the clinical and academic outputs that I think is deserving of this nation. And furthermore, we need to team up with those agencies that I mentioned before and the NGOs that do a phenomenal amount of work so that everybody's on the same page. Funding for training, we need to bring on board new blood, younger blood. We need to enthuse them by encouraging them, training them, empowering them with actual, letting them do things. We have to delegate, we have to teach them how to do these procedures that few of us know how to do, and we're not, in my mind, allowing others to train appropriately in the speed of time necessary to make sure India becomes sustainable to safeguard all those patients that are dying of organ failure when they could be transplanted and go back home to earn their wages, pay their taxes, and look after their families. And I mentioned about the registry, and the final thing is multi-center collaboration, which I think the enormous benefit, not only in terms of training, but in terms of actual collaborating over clinical research in all aspects of heart and lung failure, as well as transplantation, at state level, at national level, at international level, so that more and more Indian units are out there obvious and visible in our fields academically, and also to encourage, just to go back on the training slide, to encourage allied health. That means nurses, perfusionists, and all the others that are involved in the transplant program to be also encouraged to attend the conferences, to start contributing, which I know is happening, but it'd be nice to see that at a much greater level. So I think jumping the chasm is a necessary step to make this better in terms of heart-lung failure management and transplantation in India. I think jumping the chasm requires us to do that, holding hands with all of us together, jumping it, and those that have jumped across should be there, not continues to go forward, but turning around to pick up the pieces and let the others come across more safely. Thank you very much. I'm happy to answer any questions or queries.
Excellent talk, Dr. Kumud.
For those of you who don't know, Dr. Kumud is one of the pioneers in the world to do a DCD heart transplant. He's the first one in the world to do DCD heart transplant. What he has given us a description of the bridging the chasm, the gap between the donor and the recipient and the need for transplantation is phenomenal. He's drawn a whole panoramic view of what all things that are needed, like education, training, funding, and teamwork. If there are any questions, we'll be happy to answer them. If there are no questions, then we can go ahead with the next presentation. Our next speaker is Dr. K.R. Balakrishnan. He is he needs no introduction. He is one of the leading, most experienced heart transplant surgeon in our country. He is also recognized as the one who did the first lung transplantation on a COVID patient, and he is one of the pioneering surgeons for COVID ARDS in the world. I would now request, since he was not able, because he was doing a transplant, he was not able to be present in this meeting. Consequently, he has recorded his presentation and sent it to us. There are going to be more than 100 transplant programs in the next 10 years. So it is very important we listen to him, because what he has to say about how to transplant programs in India, establish transplant programs in India, will be very useful to all of us.
Thank you, sir. We have definitely come a very long way since the first heart transplant in 1967. But seems like we have miles to go before we sleep. So let us bring upon Dr. Balakrishnan for his speech.
We are ending building transplant programs nationally. Heart transplantation started in India in 1994 until the year 2009. The progress was slow because of lack of a well-organized donor program. There's been a considerable progress in organ donation in the country over the last decade, and the circles represent states with clever donor programs. Interestingly, if you draw a line right across the middle of India from Gujarat on the west coast to Visakhapatnam on the east coast, over 95% of organ donations happen south of the line. The smaller red circles represent states with donations happening in smaller towns and mofussil towns, where this is for transplant activity in general. It imposes logistic challenges for those of us doing heart and lung transplant, because transporting organs from these towns to big city centers is not often easy. Despite a decade of heart transplant activity, patients continue to be referred late, so a lot of patients are in transplant level 3 with deranged renal and hepatic function, and often have high PVRs and high PA pressures. HeartMate 3 and other long-term beds are not of great use as a bridge to transplant because of their cost, and ECMO and CentriMag are the mainstay mechanism of support. Pediatric organs are scarce, and donor coronary angiograms are virtually impossible. And unfortunately, the cost of organ transport and transplant has to be borne by the patient. Waitlist mortality was a huge challenge when we first started, and we had to overcome that. And since this was the most easily available modality, ECMO was used. Our first success with this as a bridge to transplant was over a decade ago, and that lady, after being on ECMO for a week, underwent a successful transplant, was a long-term survivor. So ECMO is used very commonly as a bridge to transplant in our setup. Sometimes it leads to recovery of ventricular function, as shown in this child who had viral myocarditis. We have learned how to ambulate patients while they're waiting for an organ on ECMO, like this boy on VA ECMO, awaiting a heart and lung transplant. ECMO is also a very useful modality for use for primary graft dysfunction. There's young girl with some CentriMag BioVac for 3 weeks following cardiac arrest. We got a hypertrophy donor heart from Gujarat, and after 4.5 hours ischemic time, the heart did not have any contractility, and she was in central ECMO for 9 days with the chest open, and was eventually weaned off ECMO, and the heart discharge looked very good, and she's long-term survival now, more than 1 year later. We used also impeller pump as a bridge to transplant, and if beyond a week of ECMO support, where donor organ is not available, we prefer to implant a short-term VAD through a left thoracotomy. We use Centromag in pediatric patients as well, and the youngest has been an 8-month-old child. We've used a Berlin heart in one instance as a biventricular support. Long-term VADs, as I mentioned, I think we've done 7 transplants with previous long-term VADs. Majority of these patients prefer to wait on their VADs as long as possible because it's expensive. The longest hardware support has been 9 years, and I think close to 10 years for HeartMe 2, which is still being followed up. The other challenge was transporting organs. The concept of Dream Corridor was started in the city of Chennai in 2008. Now it's used all over the country. Long distance procurement imposes huge challenges because hiring air ambulances is expensive. So we started using commercial aircrafts, and we did a study comparing air ambulance with commercial aircrafts. We found the difference to be more than in terms of cost, and this is published in Journal of Heart and Transplant. And the box has to go through the usual security checkup. And increasingly now we have taken the last couple of months organs from Chandigarh, I think 6 times, with an ischemic time, sometimes as long as 8 hours. If you choose the donor organs correctly, and outcomes can be good with excellent ventricular function. Challenges in transporting patients are also huge, especially during COVID times. We used a road ambulance for very long distances on ECMO. These are practices which may not be seen in other countries. We've had patients transported from the Punjab on ECMO over 4 days using a road ambulance because it was cheaper. Where patients can afford it, we've used air ambulances. And we've also used trains if they were not intubated and then not on mechanical support. What are the outcomes? We published our results in the Indian Heart Journal last year. We've done close to 475 transplants, out of which I think more than 360 are transplants. The overall 90-day survival was close to 83.5%. And the risk factors for 90-day mortality was a lower intermax category with an odds ratio of 0.4, a high serum creatinine with an odds ratio of 2.3, and interestingly high right atrial pressure. The median survival has been good with a 5-year survival of close to 65%. We've had close to 100% follow-up with 2 dedicated data people who track outcomes very rigorously. And the risk factors for poor or long-term outcomes have been higher CVP, interestingly. CVP more than 15 has had poorer outcomes, and creatinine more than 1.5 has poorer outcomes as compared to creatinine less than 1.5, as you can see from this log rank file. But interestingly, this seems to be age dependent. If the age is less than 50, the gap narrows, and age less than 30, the gap is very, very narrow. So in older patients with high creatinine, transplants have poorer outcomes. So either they have to be referred early, or a VAD could be an alternative. We've done close to 120 pediatric transplants, and we published the results of the first 97 of them in the Annals of Pediatric Cardiology. Our outcomes in pediatric transplants are better than those for adults, as you can see from this Kaplan-Meier curve, comparing age less than 18 versus more than 18. Donor age more than 25 was a risk factor for poorer long-term outcomes in pediatric transplants. And older donor age was also associated with less event-free survival as compared to younger donor age. We also looked at a study of cost of heart transplants, and this is published in our journal. We looked at 163 consecutive heart transplants with varying risk categories, and we found that patients who had mortality, had much higher hospital costs as compared to those who lived. And interestingly, if the patients died within 7 days of surgery, their cost was equal to surviving patients. And if the patients died after 7 days, the cost increased exponentially. And we found that lower Intermax category and higher creatinine were major risk factors for higher cost and hospitalization. What about functional outcomes? We've had excellent functional outcomes. This young man was an ECMO airlifted, underwent a transplant, is now a CEO of a 2,000 crore company. This man had 1 year post-transplant, finished first and a half marathon. He's now doing well 5 years later, and these two children had a heart transplant. The girl to my left was trekking in the mountains of Coorg, of Munnar, looking for mountain goat, and she was an ECMO 1 year prior to that. So you can see excellent functional outcomes are possible. And 5 years ago, organs were available for overseas patients because the number of transplants was less. And this boy to my left underwent a transplant and was now playing for the Ukraine soccer team, for the national team last year. Unfortunately, in the current scenario, I'm not sure what happened to him. So in conclusion, excellent outcomes in terms of survival and functional capacity is possible today with heart transplantation. More heart failure cardiologists are needed for widespread penetration of this therapy. I think even today, significant number of donor hearts are left unused because of lack of suitable recipients. And this scenario needs to change. There's no dearth of patients who require this therapy. There's been, as I said, majority of patients undergoing liver transplant, for instance. Liver and transplant in this country started just 2 decades ago in early 2000. And yet, very large number of liver transplants are done as compared to heart. Of course, they have the advantage of living donation, but despite this, more hepatologists are involved in this. So we need to involve cardiologists in this activity. And more state funding and insurance coverage is needed for the cost of transplants to be covered so that it becomes more affordable. The government of Tamil Nadu actually funds heart transplants at 16 lakhs and heart lung around 20 to 22. And recently there have been attempts to increase that coverage based upon the costing study we have done. And hopefully others, and including central agencies like Ayushman Bharat, if they start funding, this activity will increase, and India has a potential to be one of the leading number of transplants done in the whole world, because the rate at which the organ donation is increasing. In the not too distant future, I expect over 1,000 transplants to be done annually. Thank you very much.
It is interesting to note that Dr. Bala has modified a lot of things which are taught in the West to an Indian setting, and he has published his results also in Journal of Heart and Lung Transplant, like carrying organs in regular airlines instead of chartered flights, like it's done in the West, and without virtual cross-match, and many other limitations. He has shown good outcomes in spite of a lot of restrictions in our country. My question to him would be, Bala, there are a lot of doctors investing in building hospitals and using their finances and coming together. Have you ever thought about doctors coming together and having a cardiopulmonary insurance to take care of all the groups of patients so that you can have health care for all, cardiopulmonary transplantation for all? Just a thought while I was listening to your talk.
Oh, there's no doubt in my mind that at some point in time, more universal health coverage will be required. Will that happen in our lifetime? That later is a question. But one thing is that we publish apart from studies looking at costing. So the public
Mala, you're breaking up. There is your sentences are breaking up. You're breaking up some.
I'm going wrong. The public perception of costs is very naive, as is the perception of IAS officers and health officials. A very realistic and real world costing, as is seen in private hospitals. And for the matter, the study that we did is as applicable to a public hospital as us. The only difference is in a public hospital, that cost is borne by somebody else, whereas in a private is paid for by the patient. So perhaps involving business schools like IIMs, we need to do more important costing studies and risk categorization, so that at some point in time, Ayushman Bharat or CGHS or even private health insurance starts funding these procedures. Because privately paying for everything is beyond a point not possible.
Excellent presentation as usual, sir. I want to ask you one question. You have mentioned one patient with high creatinine and high bilirubin. Do you have some specific protocol to look after kidney after transplant with preoperative raised titer?
Unfortunately, it's very important. High creatinine,
It's very difficult.
the risk factor 5 years.
So your voice is not clear.
I don't know what's wrong. We do a fairly detailed assessment prior to accepting a patient for an isolated heart transplant, looking at the duration for which the creatinine was high, whether there is evidence of medical grade kidney disease in terms of kidney length, cortical medullary differentiation, and presence of albumin in the urine, and then take a call. If in given cases, if a VAD is affordable, that might be a better choice. We also have, we follow different immunosuppression protocols for patients with high creatinine by avoiding CNI inhibitors in the first few weeks. We are trying our best to push for a combined heart and kidney allocation in our state and in Noto, because the liver guys get to do combined liver and kidney quite easily, whereas in our system, the heart does not draw the kidney, it's the other way around. So if they're going to wait for a kidney allocation, that's going to take 2-3 years, by which time our patients would die. And again, organizations like INSHLT, which has started, are in a position to make a strong representation to the concerned authorities that these patients with high creatinine, with combined heart and kidney disease, are now increasingly, with more and more Fontans being able to transplant, we are seeing patients who would benefit from combined liver and heart transplants. So we need to evolve like other countries and have better protocols in position so that the available organs best serve these patients. Otherwise, you do a wonderful heart transplant and they die after 7 months or 1 year. It doesn't serve any purpose.
Can you hear me, sir?
Yeah, I couldn't hear you before.
Do you have some renoprotective protocol in post-operative, early post-operative period in patients with high creatinine? Because two is
in patients with high creatinine, we almost invariably use induction therapy. We try to avoid tacrolimus, not only for the first 4 days, but for the first several days till the urine output is adequate. I'm not particularly concerned about a creatinine value of say 1.8 or so in the postoperative phase, as long as urine output is good. And once the cardiac output improves over a period of time, the renal function very often settles down at one level. The challenging patients are those with severe right atrial elevation of right atrial pressure. In fact, the paper we are presenting in ISHLT in Boston in the next month is exactly that. Patients with very high CVP on vasodilators tend to do poorly even at 5 years. So in patients with high CVP, our current approach is to electively put them, instead of meldonidone infusion, we have an ambulatory intra-aortic balloon pump protocol so that their perfusion pressures are higher for the same degree of right atrial pressure. We also have very low threshold for renal replacement therapy in the perioperative period so that the creatinine is kept under control and volume status is maintained.
For a very lucid and, as usual, excellent presentation. Thank you.
Yes, thank you, Bala, for an excellent presentation. And I just wanted to add a comment to what you said, that we adjust the tacrolimus levels. We don't start, like he said, 7 days also, for lung also. We can replace with sirolimus, but in the early stages, sirolimus causes dehiscence of all the anastomosis. So
I agree.
that's why we don't use sirolimus is renal protective, but yeah, for lung we do reduce. For heart, Bala, you want to comment on that?
No, I couldn't hear the
Reduction. Do you reduce steroids early as a renoprotective mechanism?
You mean pre-operative?
Post-operatively.
Steroids like rapidly.
Thanks a lot, Bala, for an excellent presentation and for educating us as always. Thank you. Our next speaker is one of the few surgeons in the world who does living related lobar transplantation. His name is Dr. Hiroshi Date. He is one of the 3 surgeons who does living lobar related lung transplantation. Request them to go ahead. He may be available. Is he available for question and answers?
Yes, I am.
Excellent. Yeah. Please go ahead. Yeah.
Ladies and gentlemen, members and guests, it is my great pleasure and honor to be invited to give a talk on living donor lobar lung transplantation. I'm Hiroshi Date from Kyoto University, Japan. I have nothing to disclose in this presentation. Lung transplantation in Japan has grown significantly over the last 20 years. In average, about 80 lung transplants are performed annually in Japan now. At the same time, waiting list for lung transplantation has grown significantly. About 500 patients are currently waiting on the list. In contrast, only a small portion of these patients can receive cadaveric lung transplantation because of the scarcity of cadaveric donors. As a result, the average waiting time exceeds 800 days, and more than 40% patients died before receiving a lung transplantation. It is for this reason that living donor lobar lung transplantation is still a required option in Japan. There are 9 active lung transplant centers in Japan. Kyoto University, where I am working at now, has the largest experience, followed by Okayama University, where I used to work. In my personal experience of lung transplantation, about half of these were performed as living donor lobar lung transplantation. This is the inclusion criteria for living donor lobar lung transplant recipient. The age should be less than 65. We accept only critically ill patients who are unlikely to survive the long wait for cadaveric lungs. Regarding living donor, we accept only relatives within the third degree or spouse. Age should be between 20 and 60. ABO blood type compatibility is required, and good blood gas and good pulmonary function are mandatory. How to inform this operation to the potential donors is very, very important. We inform them about permanent loss of vital capacity in about 15 to 10%. We inform them about various complications and possible mortality. To avoid coercion, we ask an observer to be present, and we do an individual interview so that they can give us their honest thoughts. We repeat interview at least 3 times to give them what is called cooling off period. Preoperative condition of these patients were very poor. 60% of them could not walk, and 14% were ventilator dependent, and 2 patients were on ECMO. The recipient came to our transplant centers from all over the country, and because these patients are usually very sick, I often went to see the patient in a local hospital and to evaluate on site, and made a decision if I should bring these patients to our transplant centers. This is the example. This girl was living in Northern Ireland and came to Kyoto by flying ICU and received urgent living donor lobar lung transplantation. Interstitial pneumonia, bronchiolitis obliterans, and pulmonary hypertension were the 3 major indications. We have accepted various indications. I should mention that the majority of bronchiolitis obliterans patients had a past history of hematopoietic stem cell transplantation and developed bronchiolitis as the result of graft versus host disease. We recently performed a living donor lobar lung transplantation for lung injury after COVID-19 infection. The patient was a female patient, and she was on VV ECMO for more than 3 months. She had no other organ failure, and she received a lobe from her son and her husband. This is preoperative and postoperative chest X-ray. Because only 2 lobes are implanted in this operation, size matching is a very important issue. We have 2 ways of assessing size matching. One is a functional size matching, which is used to evaluate undersized graft. We rely on measured donor's forced vital capacity. And if the estimated graft forced vital capacity exceeds 45% of the predicted value of the recipient, we accept the size matching. Regarding the anatomical size matching, we use a CT volumetry. This is often used to evaluate oversized graft. We now know that twice as big as the chest cavity, the lung, which is twice as big as the chest cavity, can squeeze in without problem. We have developed 2 strategies for undersized graft. One is upper lobe sparing living donor lobar lung transplantation, which we have performed already in 14 patients. And this is an example. The patient was adult male with pulmonary hypertension and received small grafts from his parents. Upper lobes were preserved. And as you can see, after transplantation, cardiac size shrunk and pulmonary artery pressure was normalized. Perfusion scans showed a majority of blood flow were directed to the small grafts implanted, indicating that the preserved lobes provided an adequate chest cavity for the small grafts and also worked as a reservoir during the early postoperative period, thus to avoid lung edema. Another strategy was to use a right-to-left inverted technique. This is based upon the notion that the right lower lobe is a little bit bigger than the left lower lobe. For example, this young female received a right lower lobes from her brother and her mother. And this is after transplantation. The right side is the right lower lobe implanted, and the left side is the right lower lobe inverted and implanted. Regarding the strategies for oversized graft, we have performed single lobe transplantation for small recipients, just like a single lung transplantation. For example, this young boy was very small, and his mother's right lower lobe was 270% of the chest cavity of this young boy. This young boy was on a ventilator, and after transplantation, the right lower lobe expanded beyond the midline, and his heart shifted toward the left, and the preserved left lung shrunk. And in spite of this adventure, he did very well and could walk like this in a month after receiving single lobe transplantation. We have also performed a segmental transplantation for a very, very small pediatric patients. We have done a segmental transplantation in 6 patients already. This is the post-operative chest X-ray after a bilateral segmental transplantation. The right lung was a right basal lobe, and the left lung was a right superior segment of the lower lobe, which was reversed and implanted as the left graft. This is the survival of my personal experience in living donor lobar lung transplantation in 156 patients. The 5-year survival rate was 83%, 10-year survival was 75%, and 15-year survival rate was 67%, which was much better than the world average. Regarding the pediatric patients, which I performed living donor lobar lung transplantation in 50 very sick pediatric patients, long-term survival was excellent, 80% survival up to 20 years. Outcome of living donors is also very important. We have seen some complications after the operation, but these complications could be successfully managed, and no operation-related death was encountered, and all donors have returned to their previous lifestyles. We should not forget that they lost their pulmonary function about 10 to 15% permanently. I would like to emphasize the importance of team effort to have good results after living donor lobar lung transplantation. In summary, living donor lobar lung transplantation can be applied to various lung diseases, both for children and adults. Size mismatch can be overcome with various techniques. No perioperative mortality was encountered in living donors. Living donor lobar lung transplantation provides excellent long-term survival. I would like to thank the association for the privilege of presenting this information. Thank you very much.
Is he with us? Dr. Hiroshi, are you with us?
Yes.
Congratulations on wonderful results. So what my first question is, how you educate the donor for lung transplant that in postoperative period he will have little physical capability, exertional capacity may be reduced in donor. So how to overcome that?
Thank you very much. It is very important how to inform this operation to the potential donors. As I said, we inform them about the permanent loss of vital capacity in 10 to 15%, which usually is not affecting much on daily life once they recovered. But we never explain about this procedure to the potential donors. I always tell them that the possible comorbidities and possible complications and possible even mortality.
What is the key step? Because your results are extraordinarily good as compared to others. So what precautions or what special protocol you are taking, except it is understood that ischemic time is less?
Thank you very much. Thank you very much. As compared to cadaveric lung transplantation, I think two different donors into only one recipient is beneficial for the patient, because even one lung is rejected, the other lung can function without rejection. Even the patient developed CLAD, that is often a unilateral CLAD, so the patient can survive after developing CLAD. But if you look at the history of living donor lobar lung transplantation, most of the other centers have reported that the 5-year survival rate is less than 50%, even after living donor lobar lung transplantation. I think our result is better than the reported result. That is probably based on the team effort, as I said in the last slide in my presentation.
Fantastic presentation, Dr. Date, and fantastic work you're doing in the world, which is awesome and leaves us speechless to say anything about the work that you're doing. It's phenomenal. My question to you is, do you have to, obviously your cold ischemic time is very less. When you are doing all these complex surgeries of lobar transplantation, is your warm ischemia time, are you measuring it? And is the warm ischemia time much longer than what it would be for the cadaveric transplant?
Thank you very much. I think warm ischemic time means the implantation time during in the recipient. The warm ischemic time, which is you can call a implantation time, is probably exactly the same as cadaveric lung transplantation. It is usually less than 60 minutes in one lobe. Certainly you need another 1 hour warm ischemic time for the second lobe implantation, but we usually perfuse the first implanted lobe at first, and then we implant the second lung. So the Ischemic time is short, and ischemic time is shorter than the cadaveric lung transplantation, but the warm ischemic time is probably the same as a cadaveric lung transplantation.
Use VA ECMO for support while doing after implanting one lobe when you do the other lobe?
Thank you very much. That is also a very good question. We routinely now use a VA ECMO during the transplantation. Even the patient on VV ECMO, we switch to VA ECMO during implantation.
Is it possible for one of us to come there to your center to observe?
Of course, we have accepted a number of visitors from all over the world until the COVID-19 attacks us. That's the problem. Our hospital regulation is very strict. At this moment, we cannot accept any visitors from foreign country. Hopefully, this regulation will be removed in a short period of time.
Excellent. Audience, anybody wants to ask any questions, please feel free. He is one of the most remarkable surgeons in the world. We are honored to have him speak to us. Dr. Dade, first time I heard about you was from my mentor and teacher at the University of Philadelphia, University of Pittsburgh in Pittsburgh, who is currently the chief of Temple University. My mentor was a Japanese, his name is Dr. Yoshi Toyoda. He was the first one to give me your publication in JTCVS when he talked about, I am sure you know him well. He's also one of the leading surgeons in USA. And he's my mentor. Everything I know about transplant, I learned from him. And incidentally, he is going to be the next speaker. So
thank you very much.
Thank you very much.
Very nice comments.
Thank you very much for your presence over here. And we really feel good that we could learn and hear something so fantastic as what you're doing in this world. Thank you very much.
Thank you very much. It was my great honor.
Our next speaker is a well-known surgeon who did probably the first heart transplant in Pune, who is the director of heart and lung transplant at Sahyadri Hospital in Pune, Dr. Manoj Durairaj. Is he here? Manoj Durairaj, please.
Excuse me, sir. There is just a slight change in the list.
Sure.
We'll be bringing up Dr. Martin Misfield right now. Martin Misfield. He's live available right now, so he wants to.
This session or from another session?
So from the previous session, sir, he was supposed to talk about the innovations to reduce the post-operative.
So then Manoj can wait and then he can, Manoj, no problem. Next. Okay, go ahead, man. It's a recorded presentation.
It's a recorded presentation. He'll be available live to take questions.
Okay.
We now invite Dr. Martin Misfield, the director of the university, the Department of Cardiac Surgery from Germany. We'll be talking about the modern concepts in the thoraco-abdominal aneurysm repair.
Hello, my name is Martin Misfeld and I would like to share you modern concepts in thoracoabdominal aneurysm repair and the technique we use at the Leipzig Heart Center. Our surgical principles are performing the procedure on a beating heart with moderate hypothermia, initiation of cardiopulmonary bypass via the left groin, so we don't use left heart bypass, and a stage approach. We're minimizing dissection to decrease the risk of bleeding, and we usually use partial resection, sometimes complete resection of the fourth rib to have an optimized access to the aortic arch. If necessary, we open the lower thoracic aperture in a straight way, which is indicated here, so that for closure the fourth and fifth rib are attached smoothly to each other. We staple the diaphragm and try to preserve parts of the diaphragm to the chest wall if possible. We also try to avoid complete dissection of the visceral arteries before reimplantation, and for postoperative pain management we perform cryodenervation. One important aspect is spinal cord protection, and we follow the concepts of the Misake procedure, which I will explain later. So we perform in almost all cases which are included in the study preoperative stage coiling. We routinely drainage the cerebral spinal fluid. If still back bleeding from spinal cord arteries is seen, we immediately oversew them. We have a strict perioperative blood pressure control protocol. If the patient is hypertensive preoperatively, we try to keep the post and perioperative blood pressures above normal levels, and intraoperatively we perform NIRS monitoring, which I will explain in detail later as well. So these are the two aspects I'm going to explain. So we follow the principle of the coronal network, which has been extensively described and investigated by Christian Ertz before, and we perform minimally invasive segmental artery coil embolization, which you can see here. Actually, this prospective randomized trial called Papa Artis trial is the largest European Union and German research foundation funded research project in aortic surgery ever. You can see here the participating countries. First in men was of this concept was performed in 2015 under the lead of Christian Ertz. This is how the Misake procedure is performed. Usually the pediatric cardiologist or the interventional radiologist perform the coiling procedure. Here the segmental arteries are located and they're intubated with a guiding wire. In this example, on the lumbar area, the third on the right, the microcatheter is positioned and then coils are applicated to perform the coiling. This procedure is performed in selective high-risk patients for spinal cord ischemia, so usually Crawford type 2 descending aneurysm. The procedure is done under local anesthesia with a percutaneous transfemoral access. No CSF drainage is used in these patients. The patients are monitored for 3 days with regards to normal or even higher blood pressure, and the Misake procedure is performed up to 3 times, depending on the number and localization of the segmental arteries which needs to be closed to develop the collateral network. Intraoperative monitoring also is based on the spinal collateral network and the close relationship of spinal cord perfusion and muscle perfusion of the musculus erector spinae. So we perform NIRS measuring of these two muscles, and this concept has been is based on extensive animal studies, which also has been performed by Christian Etz. Here you can see the procedure we performed. This is a patient who underwent a David procedure, aortic valve sparing procedure, with a replacement of the aortic arch and the conventional elephant trunk. And he has developed increase of aneurysm of the descending aorta with a remaining type B dissection. The fourth intercostal space is opened, and the lower thoracic aperture is open in a straight way. We staple the diaphragm. This gives a clear cut. It's very hemostatic and also reinforces the attachment stitches, which will be performed later on. Part of the diaphragm in the posterior aspect is opened using the diathermy, and here you can see our retraction system. We use the fourth rib is partially resected over a length of about 3 centimeters posteriorly, and the approach in the abdominal area is retropericardial, so we dissect the abdominal descending aorta, and care is taken to achieve good hemostasis at this point. We then open the left groin to connect the patient to the cardiopulmonary bypass. Here you can see the aneurysm of the descending aorta with some kinking. So the left groin is opened oblique, and the femoral artery and vein are only dissected superficial. And under TEE guidance, we start with the femoral cannulation. And this is followed by arterial cannulation using Seldinger's technique. We believe that the cannulation of the femoral and of both femoral vessels is advantage, especially if you have one side lung ventilation, and we prefer this technique compared to left heart bypass. Our arterial management is standardized with both radial arteries and right femoral artery. We then clamp above the diaphragm for the first stage approach, and we also clamp just after the left subclavian artery. Then the thoracic aorta is opened longitudinally, and here you can see the conventional elephant trunk. Spinal cord arteries are immediately oversoon if they still have some back bleeding. And the dissection membrane is resected to make sure we find all potential open spinal cord arteries. This is the branched graft we use, and this is anastomosed to the conventional elephant trunk using a 3/0 Prolene suture. We try to position the takeoff of the side branches just at the level or above the diaphragm to give us a good length of the side arms to the visceral arteries, which makes the attachment and later control of bleeding behind the descending graft much easier. After completion of this anastomosis, the graft is clamped distally and the aired side branches are the aired, and the anastomosis is checked for hemostasis. We keep the graft clamped distally to measure adequate length for the distal anastomosis. Then visceral perfusion is performed. We use cold blood perfusion for all visceral arteries, also for the renal arteries. We don't use custodial for the renals. The distal anastomosis is either performed with an additional distal clamp just above the iliac arteries, or as you can see here in this example, in an open fashion, so the groin perfusion is stopped for a short while. The descending artery is open completely just behind the takeoff of the renal arteries. The dissection membrane is resected and visceral perfusion is initiated with 200 mils per minute for each visceral artery using the perfusion catheters. Then again the dissection membrane is resected and we look for remaining open spinal cord arteries, which are also oversewn immediately. Here, as the dissection also incorporated the iliac arteries, tongue-shaped piece of the dissection membrane was excised distally, and again remaining visceral or lumbar and arteries are oversewn if they show some back bleeding. The stitches are very generous because especially in Marfan patients or patients with connective tissue disease, they otherwise could tear off very easily. Finally, the distal anastomosis is performed again using a 3/0 Prolene suture with generous stitches deep through the tissue. And just before we finish this anastomosis, we reinitiate cardiopulmonary bypass via the left groin and de-air the graft and the side branches. Before we finish this anastomosis, we give information to. Before we close the chest, and ideally at the beginning of surgery, we performed cryodenervation for postoperative pain management using the AtriCure Cryo Ice 2 probe. These are important aspects which we have to follow, not to induce any. So thank you for your attention, and I hope I was able to show you the principles we follow of modern concepts in thoracoabdominal aneurysm repair.
Are there any questions for this presentation?
Sir, he's not live yet.
He's not available for answering.
No, sir. We can move on to the next.
Sorry, I can't hear you.
We can move on to the next because he's not available online.
Manoj, Yoshi is ready for the presentation. So can you wait? We'll finish Yoshi and then he's just waiting for the presentation. Okay. Yoshi, you can come on. Dr. Toyoda is one of the leading surgeons in lung transplantation, but he does heart and mechanical circulatory support. He is the surgical director of heart and lung transplantation and all adult cardiac surgery at Temple University in Philadelphia in USA. He is a pioneer in lung transplantation. Minimally invasive lung transplantation was first described by him in this work, the anteroaxillary approach. We are fortunate that he is going to talk to us, and we look forward to learning the state-of-art lung transplantation, where he is going to talk to us about post-COVID and all the other new things that he has acquired, the ex vivo, and he is going to share his experience with us. Dr. Toyoda, please. Yoshi Toyoda.
Hi. Can you hear me?
Yeah.
Okay. Can you see my screen?
Yes, yes, okay. We can.
Thank you. Yeah, thank you very much for the invitation. And then sorry about the participation. I am and then Dr. Prisha from India, he just joined. Finishing up. So sorry about the delay. So I was asked to talk about the lung transplant surgery, and especially for the difficult case such as IPF with pulmonary hypertension or the concomitant coronary artery disease. So this is the lung transplant volume in the US. It's increasing, but the COVID pandemic slowed down a little bit. And this, I've been doing lung transplant since 2004. I started at the University of Pittsburgh and I moved to Temple University in 2011. When I joined, the lung program at Temple was shut down due to the bad outcome and small number. But we activated, we applied for UNOS certification, and then we did the 10 transplants for free to get the CMS certification. And then a few years later, we became the largest lung transplant center in the US. And we are the largest in 4 years over the last 5 years now. To become a big center, we've been pushing the envelope, especially recipient and donor selection. And then to maintain good outcome for such high-risk patients, we need to refine, we need to improve surgical techniques. And I'll talk about that. So as Dr. Tucker said, we sort of developed less invasive surgical approach. We reported in 2007 in the Polish journal. And in Pittsburgh, the clamshell approach was the standard approach. for double lung transplant, but we developed this anteroaxillary approach. And to do this approach, we positioned the patient supine for not only double, but also single lung transplant. And we put the arms up to the anesthetic screen to expose the axilla. And this is actual incision like this. With this, usually we can complete pneumonectomy in 20 to 30 minutes from the skin incision. But still, this exposed hilum very well. This is closure. So the obvious benefit with this approach is no sternal complication. Also, the less delayed chest closure. Sometimes with clamshell, difficult to close the sternum because the heart is swollen or something. And patients tend to be extubated earlier, and hospital stay looked shorter. So we changed our approach from posterolateral thoracotomy for single lung in the lateral position to the supine position with the anteroaxillary approach, and double lung from clamshell to this approach. So when I do lung transplant for IPF with severe pulmonary hypertension, but still I always try to do off pump. But before we start the pneumonectomy, we hyperventilate both lungs to prevent acidosis during the one lung ventilation. But still, we sometimes need to use pump when hypotension or low output or the high CVP and hypoxia or the acidosis. Or sometimes pulmonary artery pressure is too high so that clamping the pulmonary artery is dangerous. And then when we use a pump, I prefer to use cardiopulmonary bypass, but sometimes I use VA ECMO when we need a pump at early stage of the surgery because of the severe adhesions or something. And when I cannulate, I do central cannulation, usually aorta and right atrium through the thoracotomy. This is an example of the aortic and right atrial cannulation through the right thoracotomy. Use a self-retaining retractor to expose the hilum. So now recipient age is increasing worldwide, as you know. And in Temple University also, about 30% of our patients, recipients are age 70 to 80. And age 70 or older patients tend to have more IPF, and we try to do single lung transplant. And mostly we do this anteroaxillary approach, but they do well short term. And in the last year's meeting, I showed this slide. This was up to 2016. At that point, there was no difference in survival. But now we analyzed for 10-year data, and then 70 or older patients have worse outcome, worse survival rate compared to the younger patients. That is understandable. So when you start older patients, we need to be careful. When we started in 2012, we did not do any 70 plus recipients. Highest age was 69, but we gradually pushed the envelope. And elderly patients have multiple comorbidities. So this is our concomitant procedures at the time of lung transplant. Majority is the CABG and other procedures as well. We recently published this paper, the coronary artery disease in the lung transplant. And we found the lung transplant alone patients are younger and lower lung allocation score, so the less risk. But this is a concomitant CABG group, the highest lung allocation score, so they were sicker patients. But up to the 7-year follow-up, survival is no difference. compared to concomitant CABG group at the time of lung transplant versus lung transplant alone. This is some of the examples. This is left thoracotomy and LIMAT LAD. This is also left thoracotomy, single left lung with a vein from the descending to the ramus to the LAD, two vessel bypass. So at the temple, I have done so far 51 CABG and lung transplant. And the surgical approach was median sternotomy 29 and anteroaxillary approach 28 and clamshell 4. And the CABG number was 1 to 4. Majority is a mid-cab LIMAT LAD, and sometimes CABG times 2, 3, 4. Usually the vein anastomosis is done at the ascending aorta through the left chest, just like a mixed CABG. And about 80% we do off pump, but sometimes we use on pump, but beating heart. This on pump is lung transplant part needed pump. So that's why we did on pump and beating heart CABG. And we do more single lung transplant than double for the concomitant case. So my approach for the coronary artery disease in lung transplant patients, first choice is a no intervention. We want to make surgery simpler. So we just want to do lung transplant only, especially negative stress tests or non-significant coronary disease. But if it's significant and anatomically suitable for PCI, we recommend PCI pre-op, pre-listing or during the listing. And especially for patient stable and can wait for 3-6 months until off Plavix. But sometimes we do lung transplant for patients on Plavix. And then if that's PCI is not a good option, then we offer CABG. But the indication should be anatomically good and then difficult for PCI, such as left main or bifurcation lesion. And also, if LIMAT to LAD is probably better than PCI, then we sometimes do LIMAT LAD. But during the case, if lung transplant becomes complicated, then always we can defer the CABG part, and we can do PCI later if it's indicated. And if it's difficult for CABG or PCI, and lung transplant also difficult, then we do put IABP if patients develop myocardial ischemia during the case. So today, that's all I prepared. Thank you.
Can I ask you a few questions? Yoshi, what is your experience with post-COVID? Did you all do any surgery for post-COVID ARDS patients on ECMO? And what did you do any? What is your experience with COVID ARDS?
We have done over 25 lung transplants for COVID, but for the severe ARDS on ECMO, we did probably about 5 or so. They almost always have severe adhesions, but the rest is the same.
What were the outcomes of those 5 patients?
Surprisingly, patients so far are doing well. And also unique to us is we do many single lung transplants for COVID patients. Some literature suggests we should do double, but we do mostly single. But they don't seem to recur, or infect the transplanted lung after single lung transplant. But if it's ARDS on ECMO, those patients, of course, lungs are not functioning. So then we do double.
what about your experience with ex vivo? Have you started using ex vivo?
We tried a few, but that's about.
Well, Dr. Sharma, you want to ask any questions? Or anybody in the audience wants to ask any questions? There is nobody. Anybody wants to ask any questions? No problem. So Yoshi, thanks a lot. Very fascinating. Yeah. And wish you good luck for your patient and hope he does well. And thank you very much for being with us and answering all our questions. Dr. Sharma, you want to say anything?
Thank you very much, sir. Your work is absolutely wonderful and it's very inspirational for all of us. Thank you.
Good evening. My friends, the inaugural function is going to start very soon on second floor Ruby Hall. And after some time, I think entry might be restricted. So please go and occupy your seat, please. It's going to start at 6 o'clock. Thank you.